Prezados colegas da Sociedade Brasileira de Cardiologia, com enorme satisfação, o Departamento de Aterosclerose de nossa sociedade está dando início no curso Doença Aterosclerótica, da Pesquisa Básica à Prática Clínica. Essa é uma iniciativa para poder trazer os avanços da doença aterosclerótica, desde a bancada do laboratório até a arena clínica. Contaremos com ilustres convidados internacionais e, principalmente, com grandes pesquisadores de nossa cardiologia brasileira. Portanto, é uma enorme satisfação para esse departamento poder tê-los assistindo este curso, que certamente será de grande valia. E para dar as boas-vindas a todos, eu convido o presidente de nossa Sociedade Brasileira de Cardiologia, o professor Marcelo Queiroga. Bom dia, Marcelo.
Bom dia, professor Chagas. É uma honra participar de um evento de um nível científico tão elevado para discutir a pesquisa clínica ou a prática clínica, né? A medicina translacional. Somente com a ciência nós seremos capazes de vencer os desafios da saúde pública. Nós estamos passando por um período de grande dificuldade. Essa pandemia da Covid-19 já vitimou milhões de pessoas e centenas de milhares de óbitos no mundo inteiro. E o caminho para enfrentar essa dificuldade, não há dúvida, é a pesquisa. O Departamento de Aterosclerose bem sintetiza esse espírito, né? Nós sabemos que em 1985, Brown e Goldstein ganharam o Prêmio Nobel de Medicina. Isso só se faz com pesquisa de qualidade. O programa desse evento é um convite, sobretudo aos jovens, para que eles se estimulem e adentrar por essa seara. Doenças cardiovasculares, como todos sabem, são um sério problema de saúde pública. Mais de 500 milhões de pessoas, todo mundo tem doença cardiovascular, são mais de 18 milhões de óbitos. Então, é fundamental que tenhamos essa missão, uma missão que nos foi legada por Dante Pazzanese, nosso primeiro presidente, de difundir o conhecimento científico de qualidade. E a Sociedade Brasileira de Cardiologia é um celeiro de valores que a cada dia se renova, e isso é um compromisso com a ciência e com a difusão do conhecimento científico. Antes de entrar nessa apresentação, eu assistia lá a doutora Fabiana, em um francês de altíssimo nível, conversar com o Anatólio. Então, a cardiologia brasileira, e particularmente o Departamento de Aterosclerose, está de parabéns por esse evento, e podem contar com a Sociedade Brasileira de Cardiologia apoiando essas ações, que faremos isso com muita determinação.
Muito grato, presidente Marcelo, e é exatamente esta a função de nossa diretoria: trazer as novas lideranças, trazer os jovens e, principalmente, incentivar a pesquisa de alta qualidade. Por isso mesmo que este evento coube à organização a dois jovens pesquisadores, dois jovens cardiologistas de brilhantes carreiras, de experiência internacional, e que, juntamente com o nosso grande Miguel Moretti, que organiza tudo de uma maneira perfeita, organizaram esse curso para vocês. Então, a palavra é desses jovens pesquisadores. Então, eu quero apresentar a doutora Fabiane Rached e doutor Marcel Lieberman. Por favor, Fabiane e Marcel, vocês dão sequência. Obrigado.
Obrigada, professor Chagas, obrigada, professor Marcelo Queiroga. Eu fico muito feliz, a gente desenhou esse curso juntamente com o Marcel e todos que estão aqui, com muito carinho. Espero que todos aproveitem, justamente para a gente falar da aterosclerose e o risco residual, tanto da bancada para a prática clínica, para todos também aproveitarem e curtirem nesse sábado de manhã. Eu queria dar as boas-vindas, a gente chamou ilustres palestrantes internacionais, eu vou dar as boas-vindas ao Natol Contucha, um grande amigo e diretor de pesquisa da Unidade de Dislipidemia, Inflamação e Aterosclerose do INSERM, da Universidade de Paris, de Paris-Marie Curie, na França, e também ao Borg Nordestgaard, que é o professor da Universidade de Copenhague, na Dinamarca. Ambos eles falam bastante, tanto da HDL quanto do triglicérides. A gente vai falar tanto da bancada também com a epidemiologia e a prática clínica. Eu queria chamar o Marcel para dar as boas-vindas aos nossos outros palestrantes também. Muito obrigada e curtam a nossa programação.
Obrigado, Fabiana. Eu também gostaria de agradecer ao professor Marcelo Queiroga, ao professor Antônio Chagas, que brilhantemente dirigem, respectivamente, a nossa SBC e o nosso departamento de aterosclerose, e também, principalmente, a Fabiana, ao Dr. Miguel, que também, de forma muito precisa, organizaram esse curso de sábado de manhã, que vai navegar aí entre a bancada e a prática clínica, sempre lembrando que uma boa pesquisa, uma pesquisa de impacto, que consegue almejar alvos terapêuticos novos e inovadores, sempre precisa navegar entre a prática clínica, né, uma pergunta clínica, e isso acaba muitas vezes saindo também da pesquisa básica, né? Então a gente nunca pode afastar as duas áreas, e sim trazer as duas áreas de uma forma conjunta, e isso traz principalmente aquela ideia da colaboração em pesquisa, né? A colaboração em pesquisa é algo essencial para que a gente cresça mais rápido e melhor e consiga atingir os nossos objetivos, que é melhor tratar os nossos pacientes, né? Bom, os outros convidados que eu vou apresentar são muito relevantes na área de cardiologia e na área de aterosclerose. É o professor Peter Lieb, né, que tem é um pesquisador-chave, né, na área de aterosclerose. Ele trabalha no Brigham and Women's Hospital, da Harvard Medical School, tem mais de 450 trabalhos originais publicados, é um dos grandes e relevantes pesquisadores na área, e a gente vai ter o prazer de tê-lo aqui hoje. A nossa outra convidada é a doutora Cynthia Hilaire, que pertence à Universidade de Pittsburgh, trabalha lá no Vascular Medicine Institute, onde ela desenvolve também uma pesquisa de aterosclerose e de arteriosclerose, principalmente focada na área de calcificação vascular, né? Eu tive o prazer de conhecê-los pessoalmente também, e principalmente a Cynthia, com quem eu trabalhei no comitê do ATVB, né, que é da American Heart Association, principalmente relacionado à organização dos congressos e também na área de Early Career Development, lá no ATVB. Então, eu espero que vocês gostem do curso e aproveitem. Obrigado.
Muito grato, presidente Marcelo Queiroga, doutora Fabiana, doutor Marcel, e vamos então ao nosso curso, ao nosso evento. É um privilégio nosso para dar início às apresentações e aos debates. O professor Sérgio Kaiser, nosso querido colega da Universidade Estadual do Rio de Janeiro, grande pesquisador na área de aterosclerose e hipertensão arterial, e um amigo de longa data. Sérgio, bem-vindo, muito grato pela sua participação, e agora você comanda.
Muito obrigado, Chagas. Bom dia a todos. Em primeiro lugar, meus sinceros agradecimentos pelo privilégio de poder participar desta excelente iniciativa. Parabéns ao Departamento de Aterosclerose, parabéns à SBC, e bom dia, senhor presidente Marcelo Queiroga, bom dia a todos. Vamos iniciar essa primeira apresentação do professor Anatole Contuche, que vai falar sobre HDL colesterol, a ascensão, a queda e as esperanças. Bonjour, professeur Contuche, bon après-midi pour vous. S'il vous plaît, veuillez commencer votre présentation. Vous disposerez de 20 minutes.
Bonjour, monsieur. Bonjour tout le monde. Good morning to Brazil. Thank you very much for inviting me to this very interesting conversation. It's hard to say meeting because we don't really meet, but it's a pleasure being with you. I'm not going to go into too many details, so except thanking you once again, and because the time is limited, and I will switch immediately to the topic of my presentation, which is, as requested by the organizers, HDL cholesterol, the rise, the fall, and the hope. Well, I will try to go through this topic accordingly. So my presentation will be divided into 3 parts, and let's start with the rise of HDL cholesterol. Well, this is an introductory slide which is about the definitions. I think we can safely skip it just to draw your attention to HDL particles, which are the smallest and densest lipoproteins shown in the lower left corner as compared to other lipoproteins. And why we are particularly interested in these particles, in small, dense HDL particles? Well, the rise of HDL. This is a timeline of what we know about HDL. So the term was coined in the 50s when lipoproteins were first isolated using ultracentrifugation. And in that timeline, there are plenty of events, as you clearly are very well aware of. But let's just focus at 2 of them, which are shown here in red. So the first one is association between low plasma HDL cholesterol and cardiovascular disease. This is an example taken from multitude of studies published predominantly in the 80s and in the 90s of the last century. And here you can see that association that when HDL is low, the risk of cardiovascular disease increases in both men and women. This example is taken from the ERIC study. You can see here also what is interesting now, that the HDL cholesterol levels were divided in quintiles, and the highest levels people look at that time in the 90s or 2000 was around 62 in men or 81 in women. As we know now, it's probably much too low, because HDL can go much higher than that. Well, and the second prominent event in the timeline was the development of the HDL hypothesis. The HDL hypothesis was proposed by Miller and Miller, the famous publication in Lancet, 1970 and 1975. And how they put it, this is just a citation from that publication. Reduction of plasma HDL concentration may accelerate the development of atherosclerosis, hence ischemic heart disease, by impairing the clearance of cholesterol from the arterial wall. What is very important in this context, they did not talk about raising HDL cholesterol to combat cardiovascular disease. It was only about low HDL cholesterol and impairment of the clearance of cholesterol from the arterial wall. Well, that time we did not know anything about the pathways underlying cholesterol efflux from the arterial wall. Now we do know there are plenty of them, the multitude of the pathways, those mediated by cholesterol transporters like ABCA1 and G1, by surface receptor like SRB1, and we do know that all these pathways are predominantly that one mediated by ABCA1, which largely responsible for cholesterol efflux from lipid-loaded macrophages in the arterial wall. All of them can be impaired. And these pathways actually together constitute what we call now first step of reverse cholesterol transport pathway, in which cholesterol goes from the arterial cells, predominantly macrophages, first to HDL, and then it's thought to go to the liver to be eliminated through the bile. Well, that hypothesis led to the development of the concept of HDL function, with cholesterol efflux, cellular cholesterol efflux from macrophages being the most studied biological function of HDL. Then this function was clinically assessed in several studies, large-scale studies across patients with cardiovascular disease or patient developing cardiovascular disease. And you can see one of the probably the most famous example taken from work of the lab of Dan Rader at the University of Pennsylvania. And you can see here a very nice association between decreased cholesterol efflux capacity of HDL and presence of cardiovascular disease. And in subsequent studies, they developed that concept to the incident cardiovascular disease. HDL cholesterol efflux capacity was predictive of the development of cardiovascular disease in these studies. These considerations together led to the concept of HDL-raising therapy. The therapy was proposed as a possibility to normalize both circulating HDL levels, in other words, HDL quantity, and biological function of HDL, such as cholesterol efflux called HDL quality. And the hypothesis went that this approach can attenuate atherothrombotic disease. Well, these studies were performed over the last approximately 20 years, and now we come to the part 2, the fall of HDL. So HDL in 2021, and it looks like we went close to the end of the road. This slide summarizes the results of HDL-raising trials, large-scale trials. The pharmaceutical companies spent billions, literally billions of dollars developing these drugs, putting them in large-scale trials, and where the results are largely disappointing. Let's look at the right column more precisely. Here you can see the hazard ratios of all these trials performed with niacin, which nicely raises HDL. Also with CETP inhibitors shown down there, like torcetrapib, dalcetrapib, bicetrapib, anacetrapib. And you can see that the hazard ratio was in best case 0.91, just 9% decrease cardiovascular risk, the only truly beneficial trial with significant benefits. But you can look at what's shown here in the red. HDL cholesterol was raised tremendously, more than double, by 133 or 112%. And despite this extreme HDL raising, the effects were modest at best. So many people consider it as the end of the road or close to that. And the problem is that there was literally no explanation, no clear explanation why all the studies failed, despite so robust associations between low HDL cholesterol and elevated cardiovascular risk. So we can conclude basically from these studies published up to now that drug-induced HDL cholesterol raising typically does not reduce cardiovascular risk. What is important, very important to say, that all the studies were performed as a background of statin treatment, and statin treated patient and statin, as we have some data on that, and our hypothesis is now that that was predominantly the statin treatment which abolished potential beneficial effects of HDL raising, but we will come to that later. So the key question now, why did HDL cholesterol raising therapies fail? Let's look at that more precisely. This slide lists several possibilities. Let's start with HDL cholesterol raising that might potentially have been excessive. Well, remember that time people look at only the quintiles of HDL cholesterol distribution in the 90s. And when you look more precisely, when you divide HDL cholesterol levels into, in that case, in 8 different groups, you more specifically look at extremely high HDL cholesterol levels, as you can see here in this slide, which exceed 80 or even 90 milligram per deciliter. Here you can see that the cardiovascular risk unexpectedly, and as they put it in that paper, paradoxically, goes up. And that was the first publication of this kind from Canada, and this finding was confirmed since then in up to 10 different publications. So I would say it's firmly established. And given that CETP inhibitors led to extremely high elevations in HDL cholesterol, there is a possibility that HDL raising was excessive in these studies. So other possibilities are that HGL raising resulted deleterious of target effects, as particles were dysfunctional, potential benefit was embodied by statin treatment, as I mentioned, very likely. Let's look just at the very last possibility which allows us to move on to the last part, which is hope, still linked to HDL cholesterol raising. So the last possibility is that HDL cholesterol was not and is not causatively related to cardiovascular disease. This concept was developed rather by Børge Nordersgaard, who is going to talk, as far as I know, directly after myself. And I very much look forward to listening to Børge's talk, which are always excellent. And this slide was kindly provided by him. The HDL hypothesis, 2014, look at the date, he considered it to be a kind of Titanic. And HDL functionality is also another attempt to save our souls. But the real future is in remnant cholesterol. Where are the links between all the three? Let's look at that more precisely. So plasma triglyceride levels, as published by several labs, but many publications come from the University of Copenhagen. They're now firmly established as another cardiovascular risk factor. You can see here one of many examples. So the higher the triglycerides, the higher the cardiovascular risk, the presence of cardiovascular disease. Yeah, so why it's like that? You can see here another slide from a review published by Børge Nordersgaard. We very well know that chylomicrons and other triglyceride-rich lipoproteins are too big to penetrate in the arterial wall to induce lipid accumulation in macrophages, but upon they are hydrolyzed by lipoprotein lipids, they become remnant lipoproteins, and these remnant lipoproteins, they're still rich in cholesterol. They can penetrate the arterial wall, and they can be taken up by macrophages and induce atherosclerotic plaque formation. So where is the place of HDL in this story? So the simple explanation is that HDL cholesterol and triglyceride concentrations are inversely correlated. So triglyceride concentrations vary more on a daily basis than those of HDL cholesterol, which probably accounts for why HDL cholesterol statistically, purely statistically, more strongly associated with cardiovascular disease as compared to triglycerides. So because the conclusion is then low HDL cholesterol is probably innocent bystander and might merely be a long-term marker of raised triglycerides and remnant cholesterol. But the question is still, why is like that? Are there mechanistic associations? Definitely there must be, if it's a biomarker. Let's look at that more precisely. So HDL metabolism, this is a cartoon taken from a book we published with John Chapman several years ago. And you can see here many pathways. HDL metabolism is highly complex, but one of them, which was largely neglected over the several decades, links triglyceride-rich lipoproteins like VLDL predominantly here, and HDL via lipoprotein lipase. So lipolysis of triglyceride-rich lipoproteins by LP is a major source of HDL cholesterol. Let's look at that. Yes, and this pathway can be impaired in under conditions of dyslipidemia, atherogenic dyslipidemia, such as in type 2 diabetes, metabolic syndrome, and so on. More known pathway also impaired under these conditions involves CETP-mediated heteroexchanges of extract cholesterol and triglycerides between TGRL and HDL, and this was the reason why CETP inhibitors were developed. But quantitatively, the lipolysis mediated by LPL is a major source of HDL cholesterol, as you can see here. As a result, low HDL cholesterol often results from defective TGRL lipolysis by LPL. So to look at that more closely, you can see here chylomicron particle. Interestingly, chylomicron particle contains a large amount of ApoA1, which is a major apolipoprotein in HDL, up to 15 to 20% of total chylomicron proteins. It's not very clear why it's like that. Yes, and upon lipolysis, when chylomicrons enter circulation, you can see here that they become remnants. Free fatty acids are liberated as a source of energy. But what happens to surface lipids of chylomicrons, like free cholesterol and phospholipids? You can see there that these phospholipids, they predominantly go to HGL, they add to the existing HGL pool, which is expanded. As a result, ApoE1, which goes together with surface lipids to the HGL pool, intestinally derived ApoE1 associated with chylomicrons provides a major contribution to plasma ApoE1 levels. You see up to 30 to 40% of total plasma ApoE1 is a major source of circulating ApoE1 and a major source of HGL. As a result, HGL cholesterol levels are positively correlated with LPL activity and negatively correlated with triglyceride levels. Interestingly, HGL plays causative role in triglyceride lipolysis. You can see here some data from an in vitro experiment performed 20 years ago. So control LDL on the left, then you lipolyze your LDL, which become core, what people call core remnants, so just smaller particles. Then you add some HGL, low HGL, to the mixture, and you can see that the particle becomes even smaller. So lipolysis is accelerated, enhanced by the presence of HGL. But when you increase HGL concentration, you move to high HGL, the particles become even smaller. So it means that lipolysis is further enhanced. And what happens to HGL? You can see here HGL pre and post lipolysis. You can very well see that HGL grows in size, consistent with the transfer of the material transfer from VLDL to the HGL. So let's add HGL then to the cartoon, the concept developed by Borg Nordersgaard. You can see here this leads us to what we call now the reverse remnant cholesterol transport hypothesis, or RRT hypothesis. You can see here that surface lipids can go from lipolyzed remnant lipoproteins to HGL, and then they can go to the liver, as shown here with green arrows. If we put it in words, so we propose then that acquirement and transport of free cholesterol released from triglyceride-rich lipoproteins during lipolysis is a key pathway that links triglyceride and HGL metabolism. This activity is predominantly mediated by ApoE1 that exchanges between TGL and HGL, reflecting distinct lipid binding properties of this protein. HGL particle as a whole provides lipid surface required for the absorption of TGL surface remnants. HGL shuttles excess free cholesterol from lipolyzed TGL to the liver, presumably via hepatic SRB1. And HGL cholesterol in reality is an imperfect static measure of this dynamic pathway, which is still not an innocent bystander, but a causatively related biomarker of this process. The pathway originates in the intestine with the secretion of ApoE1 on high low macrons. The efficacy of free cholesterol transfer to HGL upon HGL lipolysis by LPA may therefore underlie the relationship between HGL cholesterol and cardiovascular disease. It means, in other words, is in our view of the world, this is the HGL function which underlies the relationship between HGL cholesterol and cardiovascular disease. And then the interesting question is whether this pathway, this hypothesis, can explain the association between both low and extremely high HGL cholesterol with cardiovascular disease. Let's look at that more precisely. To evaluate the hypothesis, we design an assay to evaluate free cholesterol transfer from TGL to HGL in vitro. So we will first look at photometry, which didn't really work. Then we went to LC-MS, which is excellent, sensitive, and accurate, but very laborious and time-consuming. And as a result, we choose a fluorescent approach. We label human TGRL with fluorescent free cholesterol, which is very well-known body pipe cholesterol, and other called top floor cholesterol. And then we label TGRL with that molecule, and then we follow the transfer of that molecule upon TGRL lipolysis by LPL from TGRL to HGL. You can see here, you can follow the transfer of both phospholipids and free cholesterol. This is what we did. But I will focus on free cholesterol in this presentation. How the data look like? Here you can see the kinetics, they saturate upon time as a function of the concentration of HGL. And the dose dependencies shown on the right, they also saturate. And what is interesting, the transfer even decreases if HGL concentration goes too high, as shown here on the right slide. Then we choose, shown here in red squares, we choose experimental conditions that the assay outcome doesn't depend on time, but does depend on HGL concentration. And then they applied that assay to several groups of patients, widely different in HDL cholesterol concentrations. In other words, we looked at people with very low and very high HDL, as well as people with intermediate and normal HDL levels. Here you can see several groups of subjects we looked at. Patients with acute myocardial infarction is quite low HDL cholesterol, 39 milligram per deciliter. These patients, I need to say, they came from INCOR in Sao Paulo, thanks to a very nice collaboration with Fabiana Rachet and Raul Santos and Carlos Serrano. Then we look at patients with type 2 diabetes, with high HDL of 80 on the average, and also with extremely high HDL cholesterol, over 100. And what we found is shown in this slide. You can see here that for every group of a patient group, we had a corresponding control, normal epidemic group. You can see here the transfer of free cholesterol was very low on the left in patients with acute myocardial infarction in red. In diabetics, it was also significantly decreased, but not that much. So when we moved to patients with high HDL of 80 milligram per deciliter, there was no difference despite elevated cholesterol levels in this group. And most interestingly, in patients with extremely high HDL cholesterol, shown here in pink on the right of these graphs, the transfer was paradoxically decreased, as you can see here. And then we can evaluate cardiovascular risk. Yes, well, here are all the data together, shown together. You can see here that the dependence of free cholesterol transfer, lipolytic free cholesterol transfer from TGL to HDL on HDL cholesterol concentration is like inverse U-shape. It's mirror-like as compared to the dependence between HDL cholesterol and cardiovascular disease. You can see here shown as individual values or as mean values in all the groups. And once again, you can see it quite obviously, quite clearly that those two dependencies, it's like they're mirror-like. So we have inverse U-shape on the left and true U-shape on the right. And when we evaluate expected cardiovascular risk for our HDL cholesterol levels as observed in our patient groups, and you plot that expected cardiovascular risk against free cholesterol transfer, we were quite astonished to observe truly straight lines of these dependencies. So the relationship between cholesterol transfer measured in vitro and mortality for given HDL levels is strikingly linear. But when we did the same for HDL cholesterol, we expectedly observed U-shaped curves. I will not go into too many details. I will finish with a slight detail in our RRT hypothesis in comparison to widely known RCT pathway. So the pathway, the RCT pathway is about moving free cholesterol from arterial wall to HDL and then to the liver for elimination into the bile. As compared to that, the RRT pathway, shown here in green, starts with removal of free cholesterol from triglyceride-rich lipoprotein supported then lipolysis, predominantly from the surface remnants. Then that cholesterol goes to HDL, and then it goes to the liver exactly as it happens in the RCT pathway. So the difference is where that cholesterol which is eliminated through the liver, where it originates. So in our view of this work, the more important source of cholesterol, much more important as compared to this cholesterol export from arterial macrophages, is the lipolysis of triglyceride-rich lipoprotein. Well, and when this pathway doesn't work properly, as it may happen in people with hypertriglyceridemia, like in diabetics, and so on, shown here in 1, so LPL is defective, so we can try to correct it. And the two obvious ways of correction is to enhancement of LPL activity, which can nicely be done with oligos against ApoC3, for instance, with inhibition of NGPTL3 and so on. And we can try to slightly enhance the concentrations of ApoA1, not too much. That was probably the problem of HDL-C raising trials. The HDL cholesterol was extremely enhanced, and that was too much, and the transfer was inhibited. Well, take-home message is the association of both low and extremely high HDL cholesterol with cardiovascular disease may reflect reduced flux of cholesterol from the HDL to the liver upon lipid-mediated lipolysis. Interventions aimed at accelerating this process, including, for instance, fibrates or ApoC3 oligonucleotides and so on, may decrease plasma triglyceride, raise HDL cholesterol, and reduce cardiovascular disease. It's therefore time to move from accelerating cholesterol efflux from the arterial wall to decelerating cholesterol influx in the arterial wall, as it should happen when we accelerate HDL lipolysis. Thank you very much for your attention. I'm sorry for taking a little too late, but I'm not really used to doing talks over Zoom and things like those. Thank you very much for your attention.
I'm mute. I was mute. Sorry. So thank you very much for your excellent presentation. And since Professor Nordesgaard is not yet present, I will call the next speaker, Professor Raul Santos, which will talk about a very important issue of growing importance, which is Lp(a). So what we know and what comes next. So Raul, por favor, a palavra é sua.
Obrigado. Good morning, everyone. Bonjour, Anatole. So Fabienne asked me to do the presentation in English, so I'll try my best to make myself comprehensible. So the title of my presentation is Lp(a), what we know and what comes next. So hold on a second here. So just need to change from to there. Okay. So this is my disclosure. So this is Lp(a), right? So Lp(a) is an LDL-like protein with an additional apolipoprotein, apo(a). And actually, this lipoprotein has been studied since 1963. And actually, lots of controversies, but lots of advancements also on understanding its pathological role in the risk of cardiovascular disease. So basically, for more than 30 years, we've been trying to solve the mysteries of Lp(a). This is a seminal paper that was published in 1989. I remember when I started working with Professor Raul Maranhão on lipidology, this was a must-read paper, and still many of the doubts and controversies of Lp(a) have not been solved yet. So he called that many of the aspects of Lp(a) were even mysterious, right? So almost 30 years later, I was able to participate on this NIH working group on Lp(a). And actually, we learned a lot about Lp(a). However, we still needed to understand more about the lipoprotein. And I was also able to make some commentaries about the role of Lp(a) in FH as an additional risk factor. However, there's still doubt, especially in secondary prevention, how Lp(a) can influence on mortality. So there's still many controversies regarding Lp(a). So the question that comes is, okay, how many people have high Lp(a)? Should we worry about it? So probably yes, because we should have, let's say, 1.43 billion people in the world with high Lp(a), defined as over than 50 milligrams per deciliter. That's a value that comes from the studies from Bart Nordesgaard in Denmark. And as you can see here, there's probably between 15 to 30% of people with high Lp(a), depending on the ethnicity, because the disease, the lipoprotein is genetically determined, and ethnicity has a lot to do with that. So what about in Brazil? We don't have so many epidemiological data. This is something that we presented last year at the ACC meeting. So we have studied 13 years of patients that were admitted at INCOR or participated in the outpatient clinic, more than 4,000 people. And as you can see here, we had around 30% with people with Lp(a) over than 50. Of course, this is a biased population, usually people with high cardiovascular risk or presenting already cardiovascular disease. Anyway, this is not so much different from what is being proposed from the studies. And interesting, we found a very weak correlation of Lp(a) with LDL cholesterol levels. So what determines high Lp(a) in blood? So the Lp(a) is genetically determined. Actually, between 50 to 70% of LPA levels are determined by the genes, mainly by the polymorphisms of Kringle 4-2 repeats, and there's little influence, let's say, from diet, disease states, and other factors that might influence, let's say, cholesterol, triglycerides. Lp(a) in most situations actually is not influenced by this factor. So that's why there are recommendations. That's because there are some recommendations to measure Lp(a) at least once in the lifetime, and to use it as a marker for the rest of our lives. So the problems with Lp(a) actually is that it's not a homogeneous lipoprotein. We might have more than 40 different isoforms of Lpa, and that might influence on Lpa levels. And actually, since we have different isoforms of the lipoprotein, we might have high Lpa levels. However, these high levels might not be associated with a greater risk of cardiovascular disease, for instance, as we have when we have the predominance of big Lpa particles. On the other hand, if we have a predominance of smaller particles, we might have an increment in the risk of cardiovascular disease. And unfortunately, most of actually the methods that we have to measure Lpa in the world actually are not accurate, because actually they measure Lpa mass and not the number of Lpa particles. And these assays actually, they're highly influenced by the number of isoforms, and they might give us, let's say, inadequate accuracy in determining the real amount of Lpa and its association with cardiovascular risk. So the idea is really to use assays that are a little sensitive to Lp(a), and we have this in some laboratories in Brazil, but not the majority. And also, there's this controversy to say, okay, which is the pathological number from which values we really will find people with high risk of cardiovascular disease. And even if we consider 50 milligrams per deciliter or 125 nanomoles per liter, actually these numbers are not interconversible. So that's the issue of that. And also quite interesting, actually, since Lp(a) is rich in cholesterol, actually 30 to 40% of its mass is cholesterol. Actually, if we have very high Lpa levels, actually that might influence in the values of LDL cholesterol or non-HDL cholesterol, because Lp(a) cholesterol is considered as LDL cholesterol. So that's why when we give, let's say, high dose statins and cholesterol goes down very much less than we expected, we should suspect that this person might have high Lp(a). So no doubt that Lpa is associated with an elevated risk of cardiovascular disease. Why is that? Because it is rich in cholesterol, because it looks like LDL. However, it is also extremely pro-inflammatory because it carries oxidized phospholipids, and also because it's prothrombotic. So here we have three characteristics of this lipoprotein that are associated with an increased risk of development of atherosclerotic plaques. So, and we have strong evidence from the literature that indeed Lpa is independently associated with the greater risk of cardiovascular disease. So we have the classic epidemiological risk factors that are subject to biases and unmeasured confounders. But we have stronger evidence actually from Mendelian randomization studies and also from GWAS, genome-wide association studies, that actually show a stronger actually association of higher Lp(a) levels and the genes associated with these higher Lp(a) levels with a greater risk of atherosclerotic cardiovascular disease, not only coronary heart disease, but also stroke. Furthermore, we have strong evidence, not only from observational studies, but also from genetic studies, that high Lpa is associated not only with coronary heart disease, as shown here in this data from Denmark, but also increment in the risk of aortic valve stenosis, or aortic valve calcification, and consequently aortic valve stenosis. However, despite the fact that the lipoprotein has a homology with plasminogen and that it might inhibit fibrinolysis, actually we have this genetic data from Professor Nordestgaard showing that actually is not associated with an increment in the risk of thromboembolism. Maybe if we have extremely high levels of Lpa, it might influence in reducing fibrinolysis, but in most situations, actually, is not a cause of at least venous thrombosis. Maybe it should work in the atheroma thrombosis, but venous thrombosis probably not. So, considering also the association of LPA with the cardiovascular risk, we can clearly show here that actually even in a situation where LDL cholesterol is the #1 cause of atherosclerosis, like familial hypercholesterolemia, if you have high LPA and you have FH, actually you have a 50% greater risk of developing cardiovascular disease, as this data from the Safe Heart study showed. And interesting, when we're talking about FH, we must talk about cascade screening. And since LPA is genetically determined, actually high LPA runs in the families. And actually, doing cascade screening is also an excellent opportunity for not only identifying people affected by FH, but also people affected by high Lp(a). So in this data also from the Spanish group, from Pedro Mata, actually we can see if we go for, within the families, not only for FH, but also for LPA, high LPA, we will identify individuals who have either conditions and much more frequently than if you just do, let's say, opportunistic screening overall in the population. And it's important here to discuss that actually there are controversies whether the LDL receptor will clear Lp(a), because remember, it's an LDL-like particle with ApoB, but probably only in extreme situations where LDL is very, very low, actually, we will have the influence of the LDL receptor on the clearance of LPA from the plasma. So the question that comes, okay, we have association of Lp(a), strong association of high LPA with an increment in the risk of cardiovascular disease, but should we measure LPA in everyone? Because one of the things that comes to clinicians is what should I do with high LPA? I don't have a very strong therapy available that will robustly reduce LPA, so why should I worry about it? So actually, when we go to guidelines, actually there are some controversies if whether we should measure LPA in everyone, as let's say the ESC/AES guidelines, because considering that probably 1 in 5 will have high LPA, so it would be worth, and also since it's extremely, let's say, constant during lifetime, so you measure it once and that's it. So you have an idea if LPA is high or low, and that might influence on the risk of cardiovascular disease. But this is not the way as many people see. For instance, in the United States, if you go to the ACC/AJ or NLA, actually, they suggest that we should measure LPA in families with early cardiovascular disease history, patients with FH, individuals with recurrent atherosclerotic events, individuals that LDL drops little with statins, and possibly individuals with intermediate risk. So this would be higher risk individuals, and actually part of this risk could be attributed to LPA. And of course, when we find high LPA, you should intervene and treat the other risk factors. So, okay, so let's say if I measure LPA on my patient and it's high. So what should I do with my patient, considering that so far we don't have, let's say, robust therapies approved for treating LPA? And furthermore, we don't know whether if reduced LPA will prevent the risk of cardiovascular disease. So I think we should, let's say, separate the patients in two situations. One is primary prevention, and the other one is when patients already have cardiovascular disease. So what I do as a clinician when I find high LPA in my patient? So definitely I check for the other risk factors for atherosclerosis. I check the family history. This is extremely important. Should I calculate and reclassify risk? I'm going to show you something. Because remember, atherosclerosis is a disease of many risk factors, and actually it's the whole array of risk factors that will determine the risk. So should I check for subclinical coronary atherosclerosis? And of course, control the other risk factors, low LDL cholesterol, someone who hasn't had high LDL, or maybe use aspirin, considering that it might increase the risk of thrombosis in the arteries. So what's the evidence that we have that LPA will reclassify risk? Because remember, every time we have a new biomarker, we need to show that this biomarker will change the risk classification of our patients. And we have metrics for that. We have the discrimination, and most importantly, we have the net reclassification improvement. So this is data from the EPIC Norfolk study in Europe, and also we have data from one study in the United States that suggests that actually if you get an intermediate risk person and you have high LPA or low LPA, we might be able to reclassify the risk in around 15 to 16% of this individual. That means that the net reclassification improvement should be around 16%. So what about the use of subclinical atherosclerosis? There's no doubt about that coronary calcium is a very strong marker of risk of cardiovascular disease. And we know that people who have calcium score of 0, even in the presence of other risk factors, especially people over the ages of 40 or 50, actually have a very low risk of cardiovascular disease and death on the next 10 years. So the question that comes, okay, if I have high calcium and I have high LPA, are these additive? And on the other hand, if I have high LPA and low calcium or 0 calcium, will that, let's say, identify someone who has a lower risk of events? And the answer probably is yes, but it's not definitive. This is data from the Dallas Heart Study and from MESA, more than almost 6,000 people from different ethnicities, and this is extremely important because LPA values may vary according to ethnicity. These individuals were followed by almost 12 years, and we have 440 events. And as you may see here, as the higher the calcium score, the greater the risk of events, and the higher the LPA, the greater the risk of events. However, they only found an additive interaction of high calcium score and high LPA in those with CAC scores over than 100, those who have, let's say, an elevated burden of subclinical atherosclerosis. On the other hand, those who had a calcium score of 0, even in the presence of high LPA levels, the risk of cardiovascular events was just 2.9 in 12 years, 2.9 in 12 years of follow-up. So suggesting that even if you have high LPA, but if you don't have subclinical atherosclerosis, actually the contribution to this risk is very small. So, but on the other hand, if you have an elevated plaque burden and you have high LPA, definitely LPA will influence on this risk and will indicate a higher risk individuals. So what should I do? Should I reduce the LDL in these patients? And that's what I do, right? When I find someone that I understand that LPA is increasing the risk of cardiovascular disease, basically what I do, I try to correct all the risk factors, and definitely reducing LDL is something extremely important. There's controversy whether statins may raise LPA. And this is a meta-analysis that was published a couple of years ago in the Lancet, almost 3,000 people in the randomized clinical trials. And in that study, actually, statins didn't change LPA. Maybe in some individuals that might occur. But important to say here is actually that even if I reduce LDL cholesterol, LPA will still mark an increased risk of cardiovascular disease. And actually, let's say the relative contribution of LPA increases in those people where we reduced LDL. So showing that actually LPA will still be there, is still having a bad influence, and definitely not only we should reduce the LDL cholesterol, but we must pursue therapies to reduce LPA. So what about the use of aspirin? Let's say that aspirin may reduce the risk of thrombosis, but actually aspirin may reduce the risk of cardiovascular disease overall. And if I have someone who has a greater risk of developing cardiovascular disease, aspirin might help, independently of the possible deleterious effects of LPA. And this is data from the Women's Health Study, from the group of Paul Ridker. So we have more than 25,000 Caucasian women here that were followed by up to 10 years. And as you can see here, those women that had a polymorphism that raised the risk of LPA, those women had a greater risk of cardiovascular disease. And of course, if you have a greater risk of cardiovascular disease, definitely you have a greater benefit from therapies like aspirin. And actually, those women with high LPA, those polymorphisms, actually have a 56% relative reduction in the risk in comparison with those women with low LPA levels who just had 9% reduction in risk. So suggesting that because they have higher risk, they might get a benefit from the use of aspirin. So what about secondary prevention? So basically, we have to control the risk factors very intensively in those individuals. So reduce LDL intensively, the question is, should I lower LPA? Because PCSK9 inhibitors may reduce LPA by 25%. Should I use LPA apheresis? We can reduce extremely well LPA with apheresis. Or should we wait for pelacarsen for the LPA Horizon trial to do it? So, as I said, we have evidence that PCSK9 inhibitors reduce LPA by 25%. And actually, individuals who have high LPA and have intensive LDL reduction with PCSK9 inhibitors will have a greater benefit than those individuals who have low LPA. So showing clearly that higher risk individuals will get a greater benefit from stronger LDL reduction. So what about reduction in LPA? So this reduction of LPA that is induced by PCSK9 inhibitors could reduce the risk of events. This is not definitive data. This is actually post-hoc data from Odyssey suggesting that actually reduction in LPA induced by alirocumab could also bring some benefits. So for every 5 milligrams per deciliter I reduce LPA, I would reduce the risk of cardiovascular disease by 2.5%. However, this seems too much because when we go to the genetic studies, actually to have the same impact as reducing LDL by 40 milligrams per deciliter, I mean a 20% relative risk reduction, we should reduce LPA between 100 or between 66 and 100 milligrams per deciliter. So this is something that comes from the genetic studies. And so definitely we need very robust therapies to reduce LPA and prevent cardiovascular disease. So, and this actually might come from the antisense oligonucleotides therapies. That's something that we published a few years ago, showing that actually mupirocin, an antisense therapy for ApoB, reduced LPA by 25%. And that led to the development of much stronger drug, that is pelacarsen, that reduces LPA up to 80%, and actually this drug is being tested in the Horizon study that actually is testing individuals with high LPA, taking statins, and actually definitely this will give us the answer if a robust reduction in LPA will prevent events. So basically to conclude, after 30 years, LPA is a little less mysterious. It's an independent marker for cardiovascular disease and aortic valve calcification and stenosis, extremely determined by genes. There's discussion whether we should measure LPA in everyone or in some specific groups. Definitely, we must stratify the risk of cardiovascular disease, treat the other risk factors, and still waiting for the good news, I hope, of LP Horizon. Thank you very much. Obrigado, abraço a todos.
Muito obrigado, Raul. Thank you very much, Raul, pela sua abrangente apresentação. André, bom dia, bom dia, Rocha. Muito bem.
Bonjour, meus amigos.
Bom dia.
Bonjour, todo mundo.
Valeu, Natal.
Fabiana, parece que você tem alguma notícia a dar aí para nós?
Infelizmente, o Borg teve um problema na internet, lá em Copenhague, então a gente vai começar com o nosso colóquio. Se ele conseguir entrar até o final, a gente consegue conversar um pouco com ele, mas eu acho que o problema na internet, a gente vai ter que adiantar o nosso colóquio para discussão. Não vão faltar talentos, a gente está aqui com o André Espósito e o Rochinha, então vamos discutir um pouquinho com o Anatol.
Bom, então, vamos iniciar, então. I think that, since Professor Anatol Kontos is here with us, I'd rather start this conversation in English so that he can understand and participate. And if, I don't know if the audience has already delivered some questions, but I could start. Regarding Lp(a), I would ask you if a 40-year-old lady looks for you and she comes and tells you that her Lp(a) is like 250 millimoles per liter. She doesn't have any risk factors for cardiovascular disease. Would you request a calcium score or just stimulate changes in lifestyle? She's a little overweight, sedentary. So what would be your approach in such situation?
That's a good question, Sergio. And actually, that's what we see nowadays, because people check on the internet about high LPA, and then they get berserk about that, right? So that's the issue. So as you said, I think we have to value the presence of other risk factors. Family history extremely important. If no family history, I'd be more at ease with the patient. However, I'm a fan of checking subclinical atherosclerosis, so maybe a CTA, if I'm worried about that, I might not find calcium, but I might find, let's say, 5% people that have non-calcified plaques. I think that could help. So I do that, and if, let's say, no plaques at all, I would insist on lifestyle changes. So, but on the other hand, if they have a strong family history or if I find plaques, I'd be very aggressive with the LDL cholesterol in that lady, even if she's young.
In the present case that I was telling you, this patient didn't have a family history of cardiovascular disease. And after all my explanations and attempts to reassure her that she could feel comfortable about her situation, that maybe there might be future possibilities in the next 10 years, she said, after all the consultation, "Doctor, thank you very much, but I feel myself like a walking time bomb." And that's the problem. But regarding the indication, the difference between European guidelines and American guidelines about whether we should or we should not measure at least once in a lifetime Lp(a), I'd just like to call your attention upon a study that was published yesterday by Pradeep Natarajan and his group, based on UK Biobank, and they show that the risk of developing ASCVD was about 1.5, 50% increased in patients with a family history of cardiovascular disease, and also 1.5% in patients with elevated Lp(a), and with the fact that these risks was absolutely independent from each other. So this might reinforce the idea that maybe we should ask for a determination of Lp(a). I will just ask one more question. At which age, if you decide to request Lp(a), would you request this exam for your patient?
Oh, this is complicated, Sergio. Sincerely, I don't know. If the patient has FH, I would determine as soon as I make the diagnosis, because as I said, there's not much influence on getting old and LPA going higher. Of course, if someone has, let's say, inflammatory disease because FH, LPA might have an acute phase reactant behavior. So I'd rather wait for someone to be in a good state of health to measure LPA. Otherwise, it gets complicated. So sincerely, let's say if you start measuring cholesterol, if you want to check in everyone, so I think the same time, the first time you measure LDL. So, but sincerely, I don't measure LPA routinely in everyone. I consider all the other factors. And also we have this issue of the methods to measure LPA in Brazil. So very few labs actually will give me an accurate value. So I still think that we should wait a little bit more before asking to measure LPA in everyone.
Sergio?
Thank you.
Sergio, may I add a question to Raul?
Of course.
So first of all, it's a great pleasure to be here. I want to thank the organization for inviting. It's great to see all our friends here. And Raul, in this case that Sergio just presented us, so it's a lady, she's in primary prevention. Would you somehow use the LPA plasma level to maybe to set a lower goal for LDL for this patient? Would you change something for you to determine the LDL goal? Because this is not in the guidelines, right?
Yeah.
Maybe in private prevention. But would it change for you in your daily clinical practice?
that's complicated. Of course, let's say if a patient is intermediate risk and LPA is high, I might try to reclassify the risk of the patient. So as I showed you, 15% might go up or might go down depending on the value of LPA. And let's say if the risk seems higher than the one calculated, I really would be more aggressive in proposing, because that means I will start giving statins in primary prevention for a 40-year-old woman, right? I'm not against reducing LDL cholesterol. Definitely, I love reducing LDL cholesterol. But the question is, should it worth it for her? If he has any sign of subclinical atherosclerosis, definitely I would start. So I have my bias here. So I check, okay, I might check the carotids, and if I say IMT is 1.5, or there's a plaque, even non-obstructive, or there's the subclinical ather in the coronary arteries, definitely totally different story. If family history is strong, totally different story. So that's how I should work on this,
Thanks.
Hi, thank you everybody for the good and important lectures. I'd like to ask a question for Anatol. Thank you very much. And Anatol, what do you do with a patient with isolated low HDL levels? Do you think you have to search for a genetic source? What do you think about it?
Thank you, Fabiana. Thank you. It's a pleasure being here again. Thank you for the invitation. Regarding the isolated low HDL, what we do in our hospital, which is the biggest actually in France in terms of lipidology, we looked at the genetics, but normally we don't prescribe any treatment. In the case of isolated low HDL, it's kind of similar to what Raul is saying. It strongly depends on what is associated with the isolated low HDL, family history, for instance, clearly. But basically, if it's only about low HDL, we always do genetics. And then, sometimes we find something, but typically we don't find anything clear, It's typically so kind of multi-genetic, several polymorphisms, we do find them. Small polymorphisms with small effects, and then the combined effect might be, difficult. It's difficult to say, it's also complicated. So the word, you use it several times, Raul. I would use it also for isolated low HDL. Except it's extremely low. If it's extremely low, then you clearly have to go for Tangia or whatever, ABCA1. But if it's kind of, I would say, 20 milligram per deciliter is kind of low. But if it's isolated, normally, hard to say.
Yeah, we have actually these genetic causes of low HDL are very heterogeneous regarding the risk of cardiovascular disease. So we have our family that APOA1 deficiency, and we have 2 homozygotes siblings, and actually they develop cardiovascular disease by the age of 40. And so when extremely low, definitely you have to try to understand which disease it is, right? And as I said before, actually, when we say that something has, let's say, a relative risk, 2-fold, 3-fold greater relative risk when LPA is higher than, let's say, 50 or HDL is less than 20, we're talking about relative risk. We're not talking about absolute risk. And that's why we have to consider the whole scenario and all the other risk factors and other markers in order to understand what's the absolute risk of that patient developing cardiovascular disease during a given period of time. And so that's what we should consider when we're talking about treating, right?
Absolutely. So as in association with hypertriglyceridemia, then it makes a lot of sense immediately. You can think of fibrates, you can think of many things, or say what is going to be developed, like NGPTL3 inhibitors, ApoC3 inhibitors. That might be very interesting. But in the absence of hypertriglyceridemia, I'm not at all persuaded whether we need to treat something, So in the concept, how we look at the things, the HDL might be low, like in APOA1 Milan or Paris, but it might still be very efficient in eliminating the remnants. Then you don't need any therapy.
It's quite intriguing, right? This relation of HDL with triglyceride-rich lipoproteins, and I guess HDL pays the bill because of the remnants, that's what I understand. Go ahead, Andre.
Well, hi, Anatol. It's wonderful to see you again. And this time, with COVID time, has been very, very hard for all of us. And missing the opportunity of meeting friends like Raul, Sérgio, Rocha, Fabi, and yourself has been very, very hard for us. But we hope it gets through in some months, and maybe we can get again. You, as always, did a very good presentation, clear-cut explanation of something that's very deep to understand for normal audience as us, and thank you for that. And I would say that, like in tennis game, we have to conclude this set. This set was done, we lose the first set, but we have still another set to play and to program in 8DL, and I believe that would be nice to clean up this mess and start thinking about 8DL in a totally different way. This is the main question I'd like to ask you. Should we consider 8DL in the same approach we are considering LP(a), LDL, or something much more complicated that depends on cell behavior, like sphingosine kinase production, or the BCG1, the BCA1, and the cell biology that have to come together with the increase in the level 8DL? Or should we always keep looking at what's happening in the bloodstream? So it seems to me that maybe we lose the focus, and when we had so much influence of LDL trials and try to make 8DL a kind of LDL particle, and it would be wrong. What do you think about it?
Well, I will give him, Andre, first of all, just to return. It's a great pleasure seeing you. It's really, I miss a lot direct conversations, like during meetings, during true meetings. And I very much hope that they will come back again, that we will be able to meet in person, because it's impossible to replace that. It's great that we have a discussion like this now, but we will have to meet in person one day. I hope it will come back. So thank you very much for your question. And just to give you, to try to reply, to give you my personal view. Not everybody will share it, I'm pretty much sure. But to me, I think the difficulty of the development of HDL field, I'm in it for 20 years. Because we did not understand why the trials didn't work. I think that was a major reason why we went into too many details. I think the story, we should try to keep it still simpler. So HDL clearly carries plenty of stuff, sphingosine 1-phosphate and whatever, 50 proteins or 100 proteins and so on. But I think that the underlying story should be simpler. Say, Borke, I hope he will still be able to deliver his talk. He always likes to emphasize, I'm a simple guy, which is clearly not true. He does excellent science, but his view of the world, it's really, we should really try to find kind of a basis which is not necessarily always complicated. It might be simple at the end, but we must understand. So I would say that we should try to look at HDL. So our attempt, our RIT hypothesis, is our attempt to clarify, to simplify the things, try to understand, to provide a relatively simple message. Well, I would say personally, I don't believe too much into efflux. It doesn't really happen that much to contribute to protection for cardiovascular risk. And those fluxes mediated by lipolysis, by HDL from lipoproteins, I think that is a relatively simple explanation, which might be close to what is going on. We should try to simplify. That's my personal.
I have two questions from the audience. Do anybody have any comment to Professor Contos before I ask the question? No? Okay. So I have a question here from Dr. Maria Helena Sardilli. Should we associate statins in primary prevention if there is an HDL level above 80 or 90 milligrams per deciliter and LDL between 100 and 170? Quem gostaria, doutora Fabiana, doutor Rocha, doutor Rochinha, quem gostaria de responder essa pergunta? Who would like to answer this question? Dr. Fabiana, Dr. Rocha?
I can go. Should I answer in English or Portuguese?
Go ahead, please.
English or Portuguese?
I think you can answer in English so that Professor Contos.
Not off, but understand.
Okay. If we are talking about primary prevention, we have to take into account the risk calculation of this patient. So we need more information to decide whether we'll need a statin or not for this patient. We cannot only consider the HDL level, we'll have to take into account the other risk factors, family history. We have to go into the risk calculation to define if we need a statin for this patient, not only the HDL level and the LDL level. That's my opinion. Fabi?
If I would include something else, there is a description of a two-peak relation between high HDL and coronary disease. There is some group of patients with very high level of HDL and severe disease. And another part, some patients with very high level of HDL and no disease. So it's very hard to decide, looking at the lipid profile, what kind of patient you have. So this situation, primary prevention, I would advise to make a calcium score or carotid evaluation. Maybe you would have in your hand the patients with very severe disease. So this is my take.
Yeah, it's actually she's considering that very high HDL would be deleterious, right? But for most situations, Anatol, you can correct me if I'm wrong, but most situations have high LDL, let's say in the ranges of 80, 90, is not bad. Actually, we see that a lot in patients who have, let's say, a very long lifespan. And actually, we have some rare variants in some, let's say, SRB1 and receptors like that might be associated with high and dysfunctional HDL and might be associated with a higher risk of cardiovascular disease, but it's in most situations not like that, right? So as Andre and Rocha said, we have to do a risk evaluation, and I'm positive if you have some doubts, you should check for subclinical atherosclerosis, because I think it's the strongest marker we have at the moment that might indicate a higher or lower risk of cardiovascular events.
Yeah, and I'd like to ask also, Anatol, because when you talk about high HDL, we don't know the limit. Do you think you have to use other markers to know about high HDL, do some functions, do this transfer that you cited in your presentation? I like to know if you can look for in this high HDL cholesterol in these people that have high HDL cholesterol, that you can look further in the markers like functionality of HDL.
Oh yes, definitely, Fabiana. The thing is that to me it's a very novel story, it's a developing story. So the association between extremely high HDL and elevated risk, well, first publications or strong publications 5 years ago, and then it was confirmed several times. But the problem is that first we don't know why it's like that. So what we are trying to propose, is such a hypothesis. Why the risk goes high, and so we need to first understand that. Then we need to understand whether there are additional, as you're saying, there are biomarkers which may predict risk despite very high HDL, and then we have no idea how to treat it. That's the most embarrassing, because exactly as the question was, LDL is say 150 and HDL is 120. What do we do? Well, we should clearly try to probably decrease the LDL cholesterol to, I don't know, 70 or something. But what to do with HDL of 120? We have no idea.
Ask the person to start smoking.
Right, something like.
I think you have to try to modulate the HDL. That's the problem. Not just the link with triglycerides, but modulate the HDL. That's the question of how to modulate the HDL particles.
But Fabi, I reviewed one of these studies, and actually JCAM, and even wrote an editorial with Phil Barter on the one in the elderly people. And actually the association of extreme high HDL with mortality was much more with total mortality rather than cardiovascular disease. And actually we might have some confounding, especially because of alcohol consumption, that might be associated. They say they adjust for that, but I sincerely, we should have, let's say, median randomization study with genes that give you very high HDL and see what happens. I remember, Andre, many years ago when we started working with Raul Maranhão, and we had the CETP mutants in Japan, people with very low CETP and very high HDL, and they developed atherosclerosis. So I remember this was a very nice example of this. But, for these epidemiological studies, it's still complicated. And actually, we have a U-shaped relation, right? Because very low HDL is also a marker of overall mortality and sometimes other diseases. So this is very complicated to let's say, disentangle these things,
Well,
from the other.
If I can add something, what makes complicated too, when you look at HDL, is the multiple sources for increasing HDL. So it's very tough for us to see what's happening besides. So I agree with Raul. It's not simple to say that very high level of HDL can increase your mortality, but for sure must have some kind of patients with high HDL that has trouble or has high probability of developing disease.
My dear speakers, we still have 6 minutes, and I have 2 questions here which I would like to address. One of them is from Dr. Desiderio Favarato, and it's for Dr. Contos. Dr. Contos, do you think that regarding HDL cholesterol, are we still looking at the picture, not really at the movie? How is the approach that you suggest to change it?
Well, we look at the picture, right? That was the question. We should look at the movie, right? Something like that. That we need to put dynamics into that. Oh, definitely. That's definitely. So the key to this, if I understand the question right way, so the key is it's always a snapshot. HDL cholesterol level is a snapshot. The dynamics behind that. So we have plenty of pathways contributing to it. Yes, and obviously we must somehow provide the kinetic background, to what's going on, to what we just see as a snapshot. Well, and then we, in my view, people much too much focus on selected pathways like CETP, that mediated by CETP, and they forgot about the rest. And if you just the reason why we moved to lipolysis was there are old papers predominantly done by Ernie Schaeffer's lab in Boston, and they looked at the contribution of different pathways into HDL cholesterol, and astonishingly, lipolysis by LPL provides huge contribution. I just reread them, say, seven years ago, and was astonished to find that. And it was kind of forgotten, people focus on the CETP as crazy. They forgot about the rest. Dynamics, clearly, if I understand the question right way, clearly, we must move from the picture, from snapshot to the dynamic, but it's extremely difficult because to do these studies, how to do that? You need isotopic studies, and even in the 80s, 90s, it was highly regulated, and now it's virtually, in France, it's virtually impossible to do studies like that, from ethical point of view.
Natal, since we have some very few minutes, would I ask you, what do you think about phenotyping HDL in clinical practice? It would be helpful for this kind of discussion.
Phenotyping, you mean, Andre, right?
Yes.
Well, phenotyping in which way? Because we do plenty of stuff.
Or something easy, simple, straightforward.
Well, because we do plenty of, we measure, say, 400 lipid molecules in HDL. We measure kind of 50 proteins semi-quantitatively and 30 glycan moieties now. And it leaves you with an array, with a huge data set. That's why I was saying that it became much too difficult, the whole field. Then to make sense of that, you do computational biology, you come up with principal component analysis, plenty of stuff, heat maps, but then at the end, the outcome is not obvious at all. You don't understand still, despite you measuring plenty of things. We need phenotyping, but then first we need kind of underlying mechanism, to look at biomarkers for that. first the idea and then probably the measurement, not other way around. If you do systems biology on HGL, once again, you have hundreds of values and then you don't understand still.
Dr. Anatoly?
Excuse me, I have one question from the audience.
Just one quick question still on HDL before we move on. Do you still see any role for therapeutics like lipoprotein A1 mimetic peptides? Is there still any role for that? D4F or something like that?
But the mimetic peptides, they were very interesting. You know, it was very interesting possibility, but the problem was low bioavailability. You know, people did not manage to really bring them into the circulation. They were orally supplemented or administered or whatever way, as far as I remember. So it's still another problem. If you look at, say, approaches like Resverlogic, the molecule that slightly increases hepatic production of APA1. That might be helpful. But the thing is, what I think, according to the data, according to the U-shape and according to what we're doing, there is still a small window when you can increase cholesterol APA1, and this can bring clinical benefits. You may not go too high. So if you go to extremely high values, that's clearly can even be deleterious, not beneficial at all. But if you start at relatively low HDL, like in diabetics, and you slightly increase HDL, say by 10% or 20%, and you're not on statins, then it might be beneficial. But the thing is that the benefits, I did not touch that topic, it's very interesting. So that benefits you can gain from enhancing the lipolysis, in moving cholesterol more efficiently from TGRL to HDL, that benefit, remember all studies, niacin was efficient in the 70s, coronary heart drug project, very nice data in the absence of statin. But when you do statin treatment, that benefit is already present. We have some data, so quite strong data on that. Clinically, statin already address potential benefit which might be taken into account by HDL raising drugs, you know. So because of the statins, I would say the statins, they kind of kill largely HDL raising drugs. We did not understand why that. Now we are trying to understand. So because of that, to sum up, there is small window probably when we can still gain, but it's not huge because of the statin treatment.
Great, thanks.
Well, I apologize to Dr. Francisco Laurindo and Dr. Ana Paula Marti, because we will have no more available time for their questions. I'm very sorry about it, but I have to finish the session because we're moving on to the next one. Thank you very much. An excellent discussion. And if somebody wants to say goodbye, please do it now.
Obrigado, pessoal. Tchau, tchau.
Bye, everyone.
Thank you, Raul. Merci beaucoup, Anatoly. Bye.
Merci, Anatoly. Merci, Fabi.
Tchau.
Oi, pessoal. Estamos de volta para a continuidade do nosso curso. E agora nós vamos para um momento muito especial para esse departamento de aterosclerose. O professor Peter Lieb, que fará a conferência deste curso, além de ser uma referência mundial na área de cardiologia, na área da pesquisa translacional, é um grande amigo da cardiologia brasileira, sempre presente em nossas atividades, e principalmente nos oferecendo o programa Jorge Paulo Lemann, que tem feito com que brasileiros possam ir a Harvard e lá desenvolver 2 anos de pesquisa com necessidade de retornar ao nosso país. Já conseguimos formar um número expressivo de pesquisadores, desde o início desse programa, quando éramos presidente da Sociedade Brasileira de Cardiologia, e isso tem trazido contribuições extraordinárias na formação de jovens pesquisadores no Brasil. E para receber o professor Peter Lieb, eu tenho o privilégio de também trazer para coordenar esta sessão um dos maiores nomes da cardiologia brasileira e da pesquisa translacional, aquele que sempre é o meu mestre, o professor Protásio Lemos da Luz. Protásio, a palavra é sua.
Thank you very much, Chagas. Peter. Thank you very much, Dr. Chagas. Peter, are you there? Okay, you are.
Can you have my video?
Good morning.
Good morning.
Are you listening to me?
Yes.
Okay. Well, Peter does not need any introduction. He is the greatest authority in the world regarding inflammation in cardiovascular disease. He is a great friend of the Brazilian cardiology, and he will speak to us on inflammation and cardiovascular risk, clinical perspectives in diagnosis and treatment. Peter, I'm glad to see that your hair is grayer a little bit. Are you trying to imitate me?
Yeah. So I need to share my screen. I learned a few minutes ago that StreamYard is not compatible with any browser but Chrome. And I do not keep Chrome on my computers because I don't want Google to run my life. But you can hear me and see me? Can you hear me?
Yes, I can hear you.
Okay. Can you see me? You commented on my...
Yes, yes, very well.
Okay. So let's share the screen.
Okay, are you hearing me?
I am hearing you.
Vai compartilhar o screen dele, a aula dele.
Vou usar a tua mesa um pouquinho.
Estou compartilhando a tela. Okay. Well, this platform is incompatible with my system, and I'm having, it says it can't share my screen. It says the browser can't access screen. So I'm going to try to sign in on another computer. Okay. I asked actually to have a technical rehearsal, but was that didn't work out. Okay, so I'm going to to leave and come back in.
Ok.
Okay.
Ele vai tentar em outro computador, né? Vou botar só um mudo aqui um pouquinho.
No curso como esse hoje, use o tempo, por favor.
Enquanto o Peter prepara a sua apresentação, eu gostaria de mencionar que esse curso aqui se insere dentro do conceito de medicina translacional. Como vários de vocês sabem, há poucos anos eu criei a Associação Brasileira de Cardiologia Translacional e temos participado dos congressos da Sociedade Brasileira de Cardiologia e da SOCESP. Esse conceito é de extrema importância, porque no passado muitos desenvolvimentos que foram iniciados na área básica demoraram muito tempo para atingir a área clínica. Um exemplo clássico é o do colesterol em aterosclerose. Quando os russos descreveram isso pela primeira vez, era 1908. E até que surgisse o primeiro estudo realmente bem feito sobre isso, que foi o Framingham, passaram-se mais de 50 anos. Então, vejo bem, a ideia da medicina translacional é precisamente encurtar esse tempo de translação entre o conhecimento básico e a aplicação clínica. Por outro lado, há também a importância da relação entre a observação clínica e o esclarecimento fisiopatológico, que em geral requer tipos diferentes de experimentação para que se chegue aos mecanismos íntimos das doenças. E, por fim, mais recentemente, nós temos uma coisa de extrema importância, que é a necessidade de transmitir esses achados, tanto básicos quanto clínicos, para a população. Então, é um outro desafio que o mundo inteiro está enfrentando. E muitas universidades, e o INCOR, por exemplo, é um exemplo disso, estão trabalhando no sentido de juntar os esforços dos pesquisadores básicos e dos pesquisadores clínicos e também a juntar a ajuda da informática em suas várias formas para oferecer esses conhecimentos à população. Então, este curso é uma demonstração típica do valor e da necessidade que nós temos hoje, a chamada medicina translacional. O que o Peter vai falar agora, por exemplo, é um exemplo típico. Faz mais de 20 anos que ele e o seu grupo estão estudando esse processo inflamatório. E eles estudaram isso em células individuais, em culturas, em vários modelos experimentais, incluindo camundongos e outros animais, e, por fim, com o estudo Cantus, eles transportaram esse conceito para a área clínica e demonstraram que, precisamente, o processo inflamatório, de fato, faz parte do início da evolução e das complicações da aterosclerose. Então, eu quero cumprimentar os membros do Departamento de Aterosclerose por organizarem esse curso com esse espírito. Uma outra coisa que eu gostaria de registrar é o crescimento da capacidade científica brasileira. Quer dizer, há anos nós tínhamos aqui vários bons cardiologistas, práticos basicamente. Mas ultimamente nós vemos com grande satisfação o crescimento da capacidade científica no Brasil. Então nós temos hoje várias universidades e institutos, como no Rio de Janeiro, no Rio Grande do Sul, em Minas, em Curitiba, e em São Paulo, instituições com condições de fazer essa medicina translacional. Um exemplo disso agora tem ocorrido, por exemplo, durante essa pandemia de Covid. Vejam que o Grupo Coalizão, que foi formado aqui, e outros, como o nosso mesmo aqui do INCOR, têm participado de uma maneira exuberante de vários estudos relativos à Covid. Então, eu vejo um grande progresso da pesquisa clínica e da pesquisa básica no Brasil. E é um esforço que deve ser reconhecido. E hoje nós temos vários grupos nossos publicando em revistas internacionais de alto prestígio e dando conta da produção científica. Então, embora o país esteja enfrentando uma crise muito grande em vários aspectos na área da saúde, não é apenas a redução dos recursos para a saúde, mas vários aspectos que levam a um prejuízo muito grande da assistência médica à população. Então, infelizmente, nós estamos vendo, por exemplo, todo dia, notícias da grande mortalidade por causa de Covid. Vejam bem, no último mês, praticamente todos os dias, a mortalidade por Covid excedeu 1.000 pacientes por dia. Nós temos filas de doentes esperando leitos para internação na UTI. Apesar de todas essas dificuldades, eu acho que a ciência brasileira está produzindo contribuições significativas, não só nesta pandemia, como também em outras áreas. E eu acho que, especificamente, a cardiologia brasileira tem contribuído de maneira notável para esse desenvolvimento. Uma outra coisa que tem nos ajudado é o que o Chagas mencionou antes. O Chagas estabeleceu um convênio com a Harvard Medical School através do professor Peter Libby e através da Fundação Lennon, que tem possibilitado a formação de cardiologistas na área de pesquisa clínica em Boston. Eu mesmo agora estou em contato também com o Montreal Heart Institute e encaminhando uns 2 alunos para lá para fazer pesquisa clínica e experimental. Então, é muito auspicioso a gente ver o desenvolvimento da cardiologia brasileira nesses últimos anos, e como disse, através do desenvolvimento de programas de pesquisa. E eu devo salientar aqui, como foi dito no começo também, que isso se deve, em grande parte, à capacidade que várias instituições têm tido de estimular a carreira de pesquisadores jovens. Quer dizer, se não fosse esse desenvolvimento, nós não teríamos chegado ao nível que nós estamos na cardiologia brasileira em termos de pesquisa. Quer dizer, é claro que nós estamos ainda longe do que é o padrão de grandes universidades americanas e universidades europeias. Mas eu vejo como um dado positivo o fato de que nós estamos progredindo. Quer dizer, nós estamos avançando, estamos formando pessoas, formando pós-graduandos e melhorando a educação. E, como eu disse, isso se deve, em grande parte, à capacidade das universidades e dos institutos de estimular a carreira dos jovens. Agora, é claro que nós temos ainda um longo caminho, mas nós estamos iniciando. Parece que o Peter agora... Are you ready, Peter? Hello?
I'm here.
Are you listening to me?
Yeah, I see you. I hear you. See you fine. I had to download Chrome because this platform, StreamYard, is not compatible with any of the browsers that I use or am comfortable having on my computer. I actually have a moral aversion to putting Google software on my computer, but I did it for Brazilian cardiology today. Let's see if you can share my screen.
Hello?
Ele vai compartilhar.
Estou compartilhando, tentando de compartilhar.
Sim, sim.
Até. Okay, can you see my screen?
Not yet.
Well,
Está em share. Fala para ele. Embaixo está em share. Aí ele compartilha.
This is just not going to work because it's making me reboot in order to give access to this crazy platform you're using. When you invited me, I asked if we were going to be on Zoom, which actually works. So it's going to take me a little time to...
Hello?
Ele vai conseguir ver a aula e falar. É só ele mandar por e-mail para o Dr. Moretti.
Moretti, está me ouvindo?
Fala para o professor Peter mandar para o professor...
Estou, professor. Professor Peter pode mandar ou para o meu e-mail ou para o e-mail da doutora Viviane e nós passamos a aula para ele.
Too big. File's too big. Let's see if I can get this. Why don't you go to the next speaker while I set this up, okay?
So, the next part of this session is a colloquium with Dr. Raul Maranhão and Viviane Giraldez. Viviane is your fellow, as you remember.
Yeah.
And so I think we'll ask Dr. Maranhão and Viviane to start some discussion on this general topic of inflammation. So, Maranhão, what would you like to say and consider regarding the importance of inflammation, the concept of inflammation in atherosclerosis? Are you there, Maranhão?
No.
He's not?
No. No.
Viviane?
Hello.
Viviane, can you hear me?
Yes.
So you studied with Dr. Peter Levy, and I said before that he has been studying this issue for more than 20 years. So what can you say about the concept of inflammation in atherosclerosis?
Hello, Peter. Hello, Professor Protásio. It's a pleasure to be here and participate in this wonderful session. It was a real pleasure and an extreme honor to be with Peter for 5 years studying in his lab. So I can say I learned a lot about the role of inflammation, not only in atherosclerosis, but other conditions such as obesity, which is also a risk factor for atherosclerosis. So I think there was a huge evolution in this area. So from the role of cytokines, chemokines, several inflammatory types in atherosclerosis and atherothrombosis, and now we are finally translating into therapies that target inflammation in atherosclerosis. So, I think this is the talk of Peter. I think he's going to talk a lot about that, I believe. So I'm very happy that finally this translation, and it took several years, as Professor Protásio said, but we are finally know that anti-inflammatory agents can be very important to reduce cardiovascular risk. We just don't know which one we are going to use. Of course, we need to address the adverse events that come with it, but we definitely know that it can work. So it's a pleasure to be here and discuss that.
Viviane, let me ask you a question. The general concept sort of troubles me in the following sense. First, the amount of reduction in cardiovascular risk in the CANTOS trial was relatively small, although statistically significant, with the doses of 150 milligrams. Then the study with methotrexate was neutral. How do you interpret this?
Well, of course, also Peter can talk much better than me about that, but I think that for these agents to work, they really need to reduce inflammation. So they can be anti-inflammatory, but in that population that they are being tested, they need to reduce inflammation. And so insert what I believe was one of the, the reasons for not for we don't see a benefit was that maybe, for some reason there was no reduction in inflammation markers, so showing that there was not enough reduction in inflammation, and that's why the drug didn't work. That's what I believe. Of course, there may be many other factors showing that, justifying the lack of benefit, but I think this is one of the reasons. So we, Peter and Riedker and all the other authors showed that for CANTOS, the subjects who benefited actually had a reduction in CRP and IL-6, and the ones who didn't, who didn't have this reduction didn't benefit. So there was a P interaction significant for that difference, showing that probably it's only the ones who have this reduction will benefit from the anti-inflammatory agents.
Yeah, I remember that in the first study by Dr. Riedecker, it was shown in patients who were taking statins that there was a reduction in CRP as well. Then in the CANTOS trial, patients with high LDL levels were excluded, so that the study was aimed to focus specifically on the inflammatory side of atherosclerosis. So that's the major finding. So in other words, when you use statins, there is an anti-inflammatory effect. But the CANTOS trial eliminated the effect upon LDL because it excluded patients with high LDL. And is that the case? Is that so?
I think, I mean, since the drug doesn't affect lipid profile, so I think we can say for sure that the effect was based on anti-inflammation. So the only effect of the drug was on inflammation. So there is no way we can attribute that benefit in modification of lipid profile. So I think we can be sure for that, about that. My question on anti-inflammatory agents, and I would like to ask that to Peter, is basically if we can safely use these anti-inflammatory agents like chronically. You know, like in CANTOS, of course, there was an increase in infection. So in the colchicine trials, there was, in one of them was increase in pneumonia in the COCOT, in the other one, there was an increase in mortality. So this could be by chance, but it also raises our worries, right? If we can use that safely. So that would be a question that I would address to Peter.
Peter, are you okay?
Well, I'm back on. Can you see my screen?
Yes. I can see it. Good.
Okay. Yes, so I had to install Chrome and reboot in order to give it permission to use my camera and my screen. So you can hear me and you can see my screen?
Yes, we can hear you. And I can see
you. I'm very sorry for the issues, but no one told me that your platform is only compatible with Chrome. And I have as I said, an aversion to give Google control over my life, so I don't keep Chrome on my computer, but I did install it. Okay, we're off and running now. Sorry. And this is the wrong presentation, but we'll come back to it. That's yesterday's presentation. I do this a lot. Here we go.
Okay.
All right.
Yes.
Yeah, this is the right one. Okay. So you asked me to talk about what's new in inflammation and cardiovascular risk. These are my financial disclosures. I don't take any personal money from any pharma or device company. So it's no news to this audience that inflammation is part and parcel of atherosclerosis, as we actually wrote up in 2002 in the Scientific American. And the views of atherosclerosis have really shifted over time. Can you see my pointer? Okay. Can you see the pointer? Hello?
Yes, Professor. Yes.
Oh, great. So way back in the 19th century, Rudolf Virchow, the great German pathologist, actually recognized that there was an inflammatory response in atherosclerosis, and he engaged in a very pitched battle with von Lokitansky, who believed that atherosclerosis was due to an incorporated thrombus. And then, of course, the chemists took over and taught us about cholesterol. And for really 60, 70 years, there was a focus on atherosclerosis as a cholesterol storage disease. Then in the era of cell biology, people learned how to grow smooth muscle and endothelial cells, and largely led by Earl Bendit and Russell Ross, we focused on smooth muscle proliferation as the key in atherosclerosis. And indeed, the smooth muscle cell proliferation was in response to growth factors like platelet-derived growth factors. And if you look at Russell Ross's early response to injury hypothesis, there were no inflammatory cells whatsoever. It was a bland proliferation. Then immunology was coming of age, and the work of Johan Hansen, and we contributed to some of the work with innate immunity, focused on the leukocytes and inflammation. And what we've done is come full circle so that our current concept of atherosclerosis involves a little bit of each of these historically ascendant concepts of atherogenesis. So we now understand that inflammation is fundamental in atherosclerosis from the very initiation of lesions through the progression and up to and including the thrombotic complications. I was asked by Nature Publications to put together a primer for students and others who wish to learn about atherosclerosis, and I put together an international group to write this. And we have a very simple presentation of the current concepts of the pathogenesis of atherosclerosis, where we have leukocytes that arrive, become activated, take up lipid and become foam cells. Smooth muscle cells will migrate from the tunica media into the intima and proliferate. And eventually we also recruit the adaptive immune cells as well. And I view the progression of atherosclerosis as a struggle between life and death. There is division of smooth muscle cells and of macrophages as well. But then they can die and form a necrotic core. And it's the balance between these various features that actually determines the character of a given atherosclerotic plaque. Now, many times in Brazil, I've gone over the concepts of the methods, the mechanisms that lead to weakening of the plaque's fibrous cap, which is comprised largely of interstitial collagen fibrils and inflammation. The story that we worked out in our laboratory over several decades was that when we have inflammation in the intima, represented here by the macrophage foam cell and the T lymphocyte, that we put the collagen fibrils in double jeopardy. We have worked out the mechanisms of inhibition of new collagen synthesis by inflammatory mediators, and we spent a great deal of time working out the conversations between the inflammatory cells that stimulate the proteinases that can break down collagen. So inflammation causes a defect both in production and in breakdown of the extracellular matrix, thinning the fibrous cap, making it weak and friable and susceptible to rupture and hence thrombosis. Over the last 6 or 7 years, my laboratory, having done a great deal of work to try to understand the cellular and molecular mechanisms of plaque rupture, we've turned to understanding superficial erosion, which accounts for between 30 and 40% of acute coronary syndromes these days. And that's a story for another time. Now, we have actually embellished the former concept of the cardiovascular continuum that was put forth by my mentor, Dr. Eugene Bromwald and Victor Zhao, many years ago, and expanded it to include inflammation. So the concept here is that, let's say you have an acute myocardial infarction, that you have a neurogenic stimulus that goes to the bone marrow that is actually mediated by beta-3 receptors that cause the bone marrow to increase the production of leukocytes. They can stop in the spleen, or they can go directly to the atherosclerotic plaque. And this is a way in which a remote inflammatory response, and it actually could be an infection somewhere in the body, but here represented by acute myocardial infarction, can actually boost the inflammatory response in the artery wall. Now, what is responsible for the inflammation in the plaque? It's probably not what we all say and think and write in our review articles, that is oxidized LDL. There's really hardly any hard evidence that oxidized LDL generates inflammation in human atherosclerotic plaques. And we know that LDL, native LDL, is actually not very pro-inflammatory. And it turns out that triglyceride-rich lipoproteins are much more pro-inflammatory than native LDL. We know that adipose tissue, an increasing problem worldwide, is filled with leukocytes. And this is a field that Viviane Rocha contributed to when she was a postdoctoral fellow in our laboratory. And we know that those leukocytes and adipocytes can generate huge amounts of inflammatory mediators that can influence atherosclerosis. We have a great deal of interest in the microbiome, including Dr. Protasio has been interested in the effects of the microbiome on atherosclerosis. And then something new, clonal hematopoiesis, which I'll speak about in a bit. Now, if you do use Google and go into Google Scholar and cross inflammation with atherosclerosis, you see that it takes nanoseconds to come up with over 1.5 million hits. And that's really reflecting the hundreds and thousands of research papers, animal experiments, and biomarker studies in humans that indicate that inflammation is involved in atherosclerosis. The challenge, though, is to move from the laboratory to the patient. And in particular, I set out many years ago to try to answer this question. Can targeted anti-inflammatory therapy improve cardiovascular outcomes in humans? If you'd like the background to this quest, which reaches back many decades, actually to the 1980s, this review summarizes why we chose interleukin-1 beta for the first large-scale anti-inflammatory trial in humans. And my focus on interleukin-1 beta was driven by all of the pro-atherogenic effects that interleukin-1 can have on endothelial cells, smooth muscle cells, and monocyte macrophages. I'm not going to go through all of them. There are really hundreds of different functions, if not thousands. These are the ones in these boxes that my own laboratory has been concerned with principally. But suffice it to say that there was a great deal of experimental basis for targeting interleukin-1 beta. This is just one example from 1986 when in print, I hypothesized a role for interleukin-1 in arteriosclerosis. I'm not going to take you through the decades of research in my basic science laboratory that led to the conclusion that IL-1 would be a target for a clinical trial. Let's just summarize it very briefly by saying that we were able to show that vascular cells can actually produce IL-1, and that was in 1986. This was very controversial and contrarian at the time. We then found that IL-1 can induce IL-1, autoinduction. And I think that this one experiment that I published in 1987 understands cytokine storm, which we're struggling with in our patients with advanced SARS-CoV-2 infection. In 1990, we found that IL-1 can induce huge amounts of IL-6. Notice this is a logarithmic scale. And we found that pro-inflammatory mediators that operate in the plaque can actually process the inactive pro-IL-1 beta to the active form. And we localized the converting enzyme in foam cells in human atherosclerotic plaques. What we didn't know when we were doing those experiments was that the enzyme, the converting enzyme, caspase-1, that converts pro-IL-1 beta to active IL-1 beta is the active part of a supramolecular complex known as the inflammasome that can be stimulated by atherosclerosis-related stimuli such as cholesterol crystals, hypoxia, disturbed flow, and products of dead and dying cells, for example. This, by the way, is a long-axis view of the NLRP3 inflammasome in a stained glass window that I commissioned and helped design. superimposed over an atherosclerotic plaque. Now, let's talk about clonal hematopoiesis, which was the mystery here on the far right. Clonal hematopoiesis is a very recently recognized link between aging, cancer, and cardiovascular disease. If you'd like to read about the details of this newly recognized risk factor, I refer you to this review that I authored in JACC a few years ago. And let me take you through this concept because it's very far afield from the mainstream of cardiology. We have progenitor cells in our bone marrow, stem cells, that can undergo acquired mutations during life. As we age, as we're exposed to environmental mutagens, these are somatic mutations. These are not mutations which we inherit from our mother or father. And some of these mutations can give an advantage to certain leukocytes and allow them to expand in the bloodstream and form a clone of mutant leukocytes. And it turns out that the mutations that give rise to these clones that have a survival or proliferative advantage, they are in leukemia, known leukemia driver genes. To get leukemia, you need to be unfortunate enough to accumulate 3 or more somatic mutations in the same clone. But on the road to acute leukemia, we found that if you have just one mutation in one of these leukemia driver genes, that your risk of cardiovascular disease is markedly enhanced. I'll show you those data in a moment. And also what's very curious is that although the hematologists, oncologists have come up with, say, 40 or 50 driver genes for leukemia, that only a handful account for most of the mutations that are associated with cardiovascular disease. As a matter of fact, the plurality are contributed by DMT3A and TET2 mutations. And here you see that if we look in a large genetic consortium, you see that the most common of these mutations that give rise to these clones in peripheral blood are DMT3A and TET2. Together, they account for the vast majority of these clones. And here is a very important figure that shows the age incidence of clonal hematopoiesis. We call it CHIP for clonal hematopoiesis of indeterminate potential, because most people will never know they have this, and the transition to acute leukemia is only 1/2 or 1% per year. You see that the inflection point is just when we begin to see a lot of atherosclerotic cardiovascular disease manifest clinically. Now, I put together with Sid Jaiswal a recent review of the interaction between cardiovascular disease and clonal hematopoiesis. And fully adjusted for traditional risk factors, you see that if you have CHIP, it's almost a 2-fold increase in the hazard ratio of developing cardiovascular disease. And that's on par with diabetes, and actually more than for total cholesterol or systolic hypertension. So this is a newly recognized, potent, and common age-related cardiovascular risk factor. Just to show you that by the time you're a septuagenarian, you have a 10% chance of having clonal hematopoiesis. And as our population ages, you see that it's going to be really quite an epidemic. In the experimental laboratory, I'm not going to take you through all of the details, but suffice it to say that when we did RNA sequencing on cells that bore mutation in TET2, which is one of these CHIP genes, we saw increased expression of interleukin-1 beta, and interleukin-6, and that was corroborated by my collaborators at the Mass General Hospital, who showed that the TET2 mutation in humans is actually associated with overexpression of IL-1 beta and IL-6. So this led to the recognition that interleukin-1 beta's shadow is cast even greater than we originally imagined, because it's involved as a mediator of the novel risk factor clonal hematopoiesis. Now, we've already mentioned CANTOS. I overheard some of the conversations about CANTOS. Let me show you some of the latest data. This was published last year, looking at the total event reduction in CANTOS, not just the first event, which is the pre-specified endpoint, but the total events. First of all, let me show you an analysis on treatment of the people who actually responded to the anti-IL-1 beta antibody. And as you can see in green, those who achieved the low median drop in CRP had an over 30% decrease in cardiovascular mortality and in all-cause mortality. This is the holy grail of all trials. Of course, on treatment analyses are subject to confounding, and in this Lancet paper, you'll see that there were 7 sensitivity analyses. There was no way that we could obliterate this benefit of canakinumab in the responders. And this is the total event. So here's the the primary endpoint, the benefit of canakinumab, which was about 15%, which is numerically exactly the same as we see with evolocumab and with alirocumab. So I've heard people say that the effect of anti-inflammatory therapy is modest. Remember, in all of those trials, Fourier, Odyssey outcomes, and in CANTOS, the patients were treated with statins. And in fact, the baseline LDL in CANTOS was 10 points lower than in the Fourier trial or the Odyssey outcomes trial. But here we see, if we look at total events, a striking benefit as shown by the difference between the placebo in blue and the anti-IL-1 treated individuals in red. Of course, we paid a price, and I heard Viviani talk about the small but statistically significant increase in infections, including fatal infections. But to counterbalance that, there was a striking benefit for other chronic inflammatory conditions. And of course, I'm not going to go into this, but there's also the huge increase in cancer mortality that we saw. So here just is a bit of a summary of some of the subsidiary investigations that came out of CANTOS. We found a striking benefit, over 50% decrease in gout. We showed that incident anemia decreased. So anyone that doesn't believe that the anemia of chronic disease involves inflammation, I refer you to this paper. And also, there was a decrease in need for arthroplasties in the patients who were treated with canakinumab. So CANTOS provided an opportunity for us to do a scientific experiment to test the inflammatory hypothesis of atherosclerosis in individuals who really didn't have a change in their lipid profile due to the intervention. And also, it opened the door to a new avenue to address residual risk. So where do we go after CANTOS to bring anti-inflammatory therapy to the clinic? Well, we believe that mining this pathway is going to be very productive. We targeted IL-1 beta. There are thoughts about targeting IL-18. We can target IL-6, and indeed, at the ACC, Dr. Ritker will present the results of a phase 2 study with an anti-IL-6 antibody that will be published simultaneously. It's a late-breaking session. The human evidence that IL-6 is causal uses genetics, Mendelian randomization. And in one, to me, very intriguing analysis that was led by my colleagues at the Mass General, we looked at people who had CHIP mutations and whether or not they had a loss of function mutation in IL-6 signaling. And they found that if you don't have clonal hematopoiesis, blocking IL-6 doesn't make any difference in cardiovascular outcomes. But if you have clonal hematopoiesis, there's a marked benefit of inheriting variants that interfere with IL-6 function. So these kind of data really suggest to us some ways forward in the practical application in a precision medicine way of anti-inflammatory therapy in the clinic. Now, will all anti-inflammatory agents improve cardiovascular outcomes? Although low-dose methotrexate, low-dose weekly methotrexate has transformed rheumatology, when Dr. Ridker led this study, the cardiovascular inflammation reduction trial, that used the same regimen, which has really been very beneficial for patients with rheumatoid arthritis and some with psoriasis, there was absolutely no decrease in cardiovascular events. But note that in the population study, there was also no anti-inflammatory effect as judged by on-treatment reductions in interleukin-1 beta, IL-6, or CRP. So CANTOS was a win, and there was a concordant decrease in inflammatory markers, mediators, whereas CERT was a null for cardiovascular events, and there was also no demonstration of an anti-inflammatory effect. Of course, as Viviane was speaking about, we've now entered an era where we have some approved clinically available drugs which may be beneficial and which attack inflammation. May attack the same pathway because colchicine, a microtubule inhibitor, may block the association of the components of the inflammasome that generate active IL-1 beta and downstream IL-6. So you all know about the Colcott study, which was led by Jean-Claude Tardif in Montreal, looking at patients who were in the early phase after an acute coronary syndrome and showing a remarkable benefit of colchicine treatment. And then at the European meeting, virtually last August, the LODOCO-2 investigators presented their data with a population of patients that were stable post-myocardial infarction and showed a similar benefit. So it's really exciting because colchicine seems to reduce events in the first days to weeks after myocardial infarction. And in those who are more stable, as shown in LODOCO-2, we may have an anti-inflammatory intervention that is available to us today. There are many other cytokines, and if you're interested in thinking about what other cytokines might be targeted in atherosclerosis, I refer you to this review written by Hafide Toufela and Alain Tegui with me. And this is, again, stained glass representation of interleukin-1 beta in the ribbon structure. So where are we with anti-inflammatory therapy of atherothrombosis today? I think we're at a turning point in the Second War. Winston Churchill said, "This is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning." So I'm going to stop there, acknowledging the fantastic people that I've had a privilege of working with and the people who fund our research as well. Thank you very much.
Thank you, Peter, for this wonderful and profound review on the mechanisms of inflammation. And thank you very much for quoting one of my preferred sayings from Churchill. It's the beginning of the end. Now, let me ask Dr. Marion, could you comment on Dr. Peter Levy's presentation? Your microphone is closed.
Thanks for this wonderful, as usual, presentation, Peter. Well, it's fantastic, the amount of observation of data you have in inflammation at this moment. I would ask you something. Do you have any look at the anti-inflammatory cytokines in your work, like interleukin 10 or 4?
There's great interest in trying to boost the anti-inflammatory limb of the immune and inflammatory responses. So there's been particular interest in regulatory T cells, which can secrete TGF-beta, which, like IL-10 and IL-4, may have anti-inflammatory effects. And so Ziad Malat is actually doing a early phase 1 kind of study where he's using very low dose interleukin-2 to boost regulatory T cells in individuals who've had an acute myocardial infarction, and they're actually seeing, at least with the biomarkers, a signal for benefit. So the first test of the stimulation of the anti-inflammatory limb may actually be to give low-dose IL-2 to increase regulatory T cells, which are inhibitory cells, largely through TGF-beta.
Well, in our lab, we're trying to resuscitate methotrexate as an anti-atherosclerotic agent. In fact, we use nanoparticles that similar to LDL structure. And what we see is that the anti-inflammatory action of methotrexate is several times increased. And at the same time, we were able to neutralize the side effects, the toxicity of the original drug. So we are starting research in clinical research on that to see if methotrexate has the ability to decrease the size and other characteristics of the lesion in tomography. But we also work in nanoparticles carrying carrying paclitaxel and other taxanes as well as docetaxel. We have finished with the collaboration of Dr. Rachet and Lucas Marinho, work with 40 double-blind study with 40 patients with chronic coronary artery disease, and we soon have the result as well. I would like to ask something. Do you have any nanoparticle, nanomedicine study in anti-inflammatory, in anti-atherosclerosis in your ambient?
Yes. So we have a paper that is in press in cardiovascular research where we can you hear me?
Yeah, sure.
Yeah, we have a paper that's in press, apropos, in cardiovascular research, where we have used nanoparticles that are targeted for areas of superficial erosion, which uncovers the basement membrane, which is rich in collagen type 4. And we've used a heptapeptide as a ligand for collagen 4 to direct the nanoparticles. We demonstrate in this paper that we actually do get an increase in uptake at places where there is endothelial denudation uncovering the type 4 collagen in the basement membrane. And we use the nanoparticles in proof of principle to deliver an inhibitor of an enzyme known as peptidyl arginine deaminase 4, PAD4, which is important in neutrophil extracellular trap formation. And so we think that's important in the, I said during my talk that for the last 6 or 7 years, we've been working on mechanisms of superficial erosion, and we've implicated, with the help of a Brazilian student who was in the laboratory, we have been able to implicate neutrophil extracellular traps in propagation and amplification of endothelial damage. So yes, we have been involved in nanoparticles, targeted nanoparticles, and of course, I'm familiar with your work on methotrexate. And I think that one of the reasons that CERT, the cardiovascular inflammation reduction trial, may not have shown a clinical benefit was because the enrollees were not chosen for having inflammation. In CANTOS, we enrolled people, included individuals who had a CRP greater than 2 milligrams per liter, whereas that was not an admission criteria for the CERT trial. For non-scientific reasons, actually. That was the original design, but it couldn't be done for non-scientific reasons. So I think that you're right to persist with methotrexate, which is the devil we know very well. And from the wonderful database in the CERT trial, we have very good handle on the toxicity. And there was actually an algorithm which ran in the background of SIRT, which used liver enzymes and leukocyte counts in order to adjust the dose in a double-blind, double-dummy kind of very complicated way. I think that computer algorithm ran tens of thousands of times during the conduct of the trial. And so they have a very, very strong database for safety. So we know how to use that drug in cardiovascular patients. So keep up with it.
Peter, there is a question here from Dr. Kaiser, Sergio Kaiser. He says, I am aware of preliminary studies with specific NLRP3 inflammasome inhibitor in heart failure, led by Antonio Abate in Italy. Any data already available regarding atherosclerosis?
Yeah. So Antonio actually is at Virginia Commonwealth University in Richmond, Virginia. He is originally from Italy, though. And yes, he's working with one inflammasome inhibitor known as Tapansa trial. But let me go back to the clonal hematopoiesis. Dan Walsh's laboratory was working on animals engineered to have defects in the clonal hematopoiesis genes. And he used an inflammasome inhibitor from a company called Inflammasome with a Z in the mice with this mutations that are related to clonal hematopoiesis, and showed that there was a decrease in atherosclerosis. He showed that around 2017 in a science paper. So at least experimentally, in the accelerated atherosclerosis of clonal hematopoiesis, we know that inflammasome inhibition works. And so it's a long story, but I'd say that there's 3 or 4 biotechs that are well advanced in inflammasome inhibitors, small molecule inflammasome inhibitors, and that there are 2 large pharma that are involved in that. So stay tuned. The inflammasome is very proximal in this cascade that I showed, and you might worry, well, if you're blocking this very important pathway very proximally, maybe you pay a greater price in terms of impairment of host defenses. But you can argue that there are many other inflammasomes other than the NLRP3 inflammasomes. Matter of fact, we have a Nature paper in press with Alan Tall that talks about the AIM2 inflammasome. And so by selectively targeting the NLRP3 inflammasome, one might leave other avenues of host defense open. So this is going to take large-scale clinical trials to sort out. It took us a 10,000-person, 3.7-year median follow-up to see this small hazard of infection in CANTOS. And so we're going to need equally powered studies to assess the safety of other hits on the inflammatory pathways. And Viviane already mentioned that there's a pneumonia signal in some of the colchicine trials, and actually in one of the ACS trials, a smaller trial, the COPS trial done from Australia, there's actually a mortality signal that we need to keep our eye on in patients treated with colchicine with acute coronary syndrome. So we really need to do adequately powered studies to determine safety. That's why I was so rhapsodic about the database of safety in SIRT, because it provides a way forward for the clinical use of methotrexate in cardiovascular patients.
Viviane, any question or comments about Dr. Peter Levy's presentation?
Well, first of all, I'd like to thank again the Departamento, also Dr. Chagas, Miguel, Fabi, Marcel for the invitation. It's really a pleasure, especially for being here discussing with Peter and Professor Protásio in Maranhão about inflammation. So Peter, actually, you just answered my first question about possible obstacles that would maybe delay the incorporation of colchicine into the arsenal for treating cardiovascular disease, atherosclerotic disease. So as you said, right, that there was this signal in mortality in LEDOCO-2. There was also, pneumonia in COCOT, also the difference between Australian patients and also people from the Netherlands. So, everything was was driven basically by the Australian patients. So I think all of these are questions, right, that may delay the incorporation. But do you see still, despite all this, colchicine as a possibility to be incorporated in our arsenal, or do you think we need to wait a little bit more? We need really large studies still to complete this cycle about colchicine.
No, I think we have to give a very careful look at the adoption of colchicine in selected patients. We've become very comfortable with using colchicine now for pericarditis, so it's really entered the cardiovascular armamentarium. And I would have suspected that the gastrointestinal unwanted actions would be limiting. But in fact, in LODOCO-2, the incidence of diarrhea was very small. And it's interesting, in Cold Corona, which is the study of colchicine led by Jean-Claude Tardif, remarkable that he started this large-scale trial of colchicine in ambulatory patients with SARS-CoV-2 infection. He started the trial in March. The paper has been submitted for publication, and the draft manuscript is available on a preprint server, medRxiv. And if you look at that paper, they started with a higher dose, with 0.5 milligrams twice daily instead of 0.5 milligrams daily. And there, the gastrointestinal side effects were much greater. So the 0.5 daily may be a sweet spot. And so I think we need to seriously consider if we should not adopt. We have 2 trials now, 2 large, well-conducted trials. There are the mysteries that you pointed to about the geographical difference in LODOCO-2. I have some thoughts about that, but we're running out of time here. But we do need to understand better the infectious risk with colchicine. If you look at the overall adverse event rates in LODOCO-2, they were remarkably lower than we see in most clinical trials. And so we need to keep our eye on safety. But I think it's wonderful that we have an independent affirmation of the inflammation hypothesis from the colchicine trials.
Peter, I was the coordinator of the Cold Corona trial in Brazil.
Mm-hmm.
And we included a number of patients, mainly from INCOR or some other sites in the country. I think colchicine has some advantages. First, it's an oral drug and has been used for a long time. Mm-hmm. The gastrointestinal effects are mild. No, we're used to deal with them. And the third point, it's very cheap. So in the Cold Corona trial, we demonstrated a reduction in the hospitalization and on the combined endpoint of hospitalization and death in patients who had confirmed diagnosis by COVID, by PCR. This is an important point. So I think it's not.
You're saying actually that the study missed its primary endpoint.
That's right. There was a trend, but it missed the primary endpoint. Yes. So the positive results, it is specifically for patients who had documented PCR COVID diagnosis. So I think it is, let's say, a good sign, but I don't think it is a definitive answer for this. But it's certainly a sign that deserves a clear scrutiny. What do you think?
No, I think that we really have to pay attention to colchicine as a cardiovascular therapeutic and learn more about the unwanted things. But as I say, I think, if I had a patient who came to me with a newspaper clipping saying, "Why aren't you putting me on colchicine?" we'd have a shared decision-making conversation, and I wouldn't be adverse to working with the patient to allocate them to colchicine.
Okay, let's have one more question. It's about interleukin 17. as a target, since it has anti and pro-inflammatory role? It's a question from Andrea Costa.
Well, the experimental literature with IL-17 is extraordinarily controversial and confusing, with some people saying, as you say, it's pro-inflammatory, some saying it's anti-inflammatory, some saying it is pro-fibrotic. That might be good. So we really need to probably have some pilot clinical studies looking at biomarkers and finding in humans, not in hyperlipidemic mice, whether or not IL-17 makes sense as a target. You can look at the discussion in that paper that I projected briefly. That is first authored by Hafid Etoufela, where we have a discussion about the IL-17 as a target.
Now, we'll have to close the session in the interest of time. I want to thank you very much, Peter Libby, Dr. Marianne, and Viviane, and let's go back to Miguel Moretti. Thank you very much.
Bye-bye, and I apologize for the technical errors because I...
Thank you very much, Peter. Thank you very much, all.
Film on my computer. It's on my computer now. I'll delete it when this is over.
Thank you.
Take care.
Bye-bye. Thank you, Peter.
Dr. Miguel.
Espero que todos estejam apreciando o nosso curso. A gente vai fazer um pequeno stop de 5 minutos para todo mundo levantar, mexer um pouco as pernas, evitar a trombose, tá certo? E a gente já está voltando em 5 minutinhos, ok? Não saiam daí, não desliguem o canal. Aliás, eu queria me desculpar com o Euler, com o Iguaraci, com a Fabiana, com o Desidério, porque realmente as perguntas chegaram muito depois, já quase no final da apresentação. Então, quando vocês forem fazer, tiverem as perguntas para fazer, já façam um pouquinho antes, para a gente poder ter tempo do coordenador jogar essas perguntas para os nossos painelistas, ok? Volto já. Mais 3 minutinhos, pessoal, e a gente já começa, ok? Não vou embora, fiquem aí. Só levanta da cadeira, toma uma aguinha. Bom, pessoal, retornamos. De novo, é um prazer poder estar aqui com todos vocês. Espero que todos estejam realmente apreciando o nosso curso. Realmente palestras fantásticas. E nós vamos ter agora mais 2 blocos que, com certeza, não vão ficar nada atrás dos 2 primeiros blocos que nós já tivemos. Para coordenar esse próximo bloco, eu vou convidar o professor Paulo Eduardo Belverbert, que é vice-presidente do nosso departamento de aterosclerose, e para moderar esse bloco nós teremos o professor Henrique Triabianco, que é o nosso diretor administrativo do departamento de aterosclerose. O professor Paulo vai apresentar o nosso palestrante, e nós teremos depois 2 colóquios. Teremos um colóquio com 2 outros convidados, o professor Francisco Fonseca e o professor Alexandre Pereira. Paulo, com você.
Bom dia. Bom dia a todos, obrigado, Moretti, parabéns pelo curso, pela excelência desse curso de doença aterosclerótica, parabéns aos coordenadores, professor Chagas, professor Moretti, Fabiana Rached, Marcelo Lieberman. E nós teremos agora uma conferência e, na sequência, um colóquio com participantes de grande peso. E um tema muito, muito relevante, um pouco árido ainda para a maioria dos cardiologistas, mas eu tenho certeza que, a partir dessa discussão, na próxima hora, ficará muito mais claro o papel da genética humana para descobrir novas terapias e alvos terapêuticos na dislipidemia. Contaremos com o professor José Eduardo Krieger, um expert no assunto, com inúmeras publicações na área, e, na sequência, a presença de outros dois grandes professores, o Dr. Alexandre da Costa Pereira, coordenador do Grupo de Genética e Cardiologia Molecular do COR, e o professor Francisco Fonseca, professor da Escola Paulista de Medicina da Unifesp. Seja muito bem-vindo, professor José Krieger, é um prazer recebê-lo aqui.
Bom dia a todos. Eu queria agradecer aos colegas pelo convite, e nós vamos discutir, então, nos próximos minutos, o papel da genética humana para descobrir novas terapias e alvos terapêuticos na dislipidemia. Há várias maneiras da gente introduzir esse assunto, mas um aspecto a ser lembrado é perguntar como é que anda a produtividade da indústria farmacêutica. E esse quadro mostra um panorama não muito favorável. O que nós vemos nas barras cinzas são o número de drogas que têm sido lançadas com sucesso desde o ano 2000 até o ano 2017. A gente vê que tem alguma coisa entre 60 e 80 drogas. Agora, o que está ilustrado em vermelho é o custo que essas drogas têm tido para chegar ao mercado. E esse custo está espetacular. Em outras palavras, nós estamos quase que triplicando o valor que gastávamos no início do ano 2000 para lançar o mesmo número de drogas. Então, esse é um quadro bastante preocupante, ele afeta todas as áreas da medicina e, evidentemente, que nós vamos focar nas oportunidades e como tentar melhorar esse quadro com os exemplos da área de doenças cardiovasculares, em particular nos problemas relacionados aos lípides. Muito bem. A primeira coisa que começa a dar uma noção do porquê dessa baixa produtividade é que menos de 5% das moléculas que entram em fase 1, nos trials clínicos, são eventualmente aprovadas pelas agências regulatórias. Então, esse é um problema muito grande. E a pergunta vem, então, por que as drogas falham? Então, a maior parte das falhas, isso é importante, acontece nos trials de fase 2, onde menos de 50% dessas drogas demonstram eficácia e 25% delas apresentam algum tipo de toxicidade. Então, esse é um grande gargalo, um grande funil. E, evidentemente, que essa falha nas taxas de sucesso, evidentemente, estão relacionadas ao processo como um todo do desenvolvimento. Então, principalmente, o que se imagina é que existe uma habilidade limitada para que a gente possa predizer os benefícios nos testes pré-clínicos, sejam eles utilizando células, animais e assim por diante. Então, esse é um pano de fundo importante que eu gostaria de lembrar. Mas tem outro ponto que eu acho que é igualmente importante. Se nós pegarmos drogas blockbusters, em outras palavras, aquelas que funcionam e funcionam em grande número de pessoas e que nós utilizamos há décadas, há anos, o que a gente vai ver é que, na realidade, a despeito do padrão ouro que nós temos para decidir, para utilizar as drogas, a sua eficácia é relativamente baixa. Eu estou falando aqui de blockbusters. Então, por exemplo, para o inibidor da ECA em doença hipertensiva, quer dizer, ele vai funcionar pela primeira vez para praticamente 1/3 dos pacientes. O beta-bloqueador da insuficiência cardíaca, um número ainda menor. Antidepressivos, 20% a 50%. Estatinas, 30% a 70%. Drogas como beta-2 agonistas para asma, de 40% a 70%. Então, esses são números que a gente não discute toda hora, mas eles são complicados. Evidentemente que eles estão ilustrando a diversidade genética e de ambientes que existem e que, a despeito de nós termos evidências diretas de que as drogas são seguras e funcionam, Quando você vai pensar no indivíduo, a coisa é um pouco diferente. E isso fica ainda melhor ilustrado nesse caso, onde nós estamos vendo o efeito individual sobre a pressão sistólica de 3 drogas que, notadamente, têm papel e são utilizadas no dia a dia. O inibidor da ECA, um tiazídico e um beta-bloqueador. Quer dizer, a despeito de que o valor médio de todas elas seja significante e importante, nós vamos ver que em alguns a pressão cai muito, em outros a pressão até aumenta. Então, essa é uma dificuldade que nós temos, porque as decisões que nós tomamos para utilizar as drogas, elas são feitas pela média. E há toda, hoje, uma tentativa de se começar a fazer opções com base objetiva para se fazer a tal de medicina de precisão, que permitiria a gente antecipar quais são aqueles que responderão ou não a essa ou aquela droga com maior eficácia e, evidentemente, com o mínimo de efeitos colaterais. Então, eu acho que isso coloca muito bem o pano de fundo e algumas das dificuldades que existem, e aí a questão, como é que nós podemos melhorar a identificação desses novos targets, alvos, não é? E como priorizá-los. Então, evidentemente que há avanços grandes nos modelos celulares ou modelos animais. Hoje, a gente dispõe de células de humanos, nós podemos reprogramar células no indivíduo adulto e depois diferenciá-las num determinado tipo particular, coisa que até bem pouco tempo atrás não era possível, e começar a fazer testes que talvez sejam muito mais informativos, não só para desenvolvimento de droga, mas também para a decisão de que droga nós vamos utilizar para um paciente específico. Imagina um paciente que tem uma arritmia, você tira um fibroblasto da pele, ele é reprogramado para virar uma célula multipotente, o que nós chamamos de iPS, depois ele é diferenciado por uma célula cardiomiócito, e especialmente um cardiomiócito com características de fibra de condução, onde a gente pode começar a fazer os testes na célula do indivíduo. Evidentemente que os dados de epidemiologia humana são fundamentais, haja vista o exemplo do colesterol, que nós vamos discutir em mais detalhe, e utilização de uma série de ferramentas de ômicas que estão permitindo também que a gente possa avançar um pouco mais e antecipar ou ter formas objetivas de prever quais seriam os melhores alvos, né? Na palestra anterior foi feita essa pergunta, quer dizer, que esse é um bom alvo, quer dizer, foi dito que existem vários dados ainda conflitantes. Então, é uma questão, será que é o melhor modelo? Será que nós não temos o melhor modelo? Quer dizer, como que ele pode ser informativo? E o que nós vamos discutir nos próximos minutos é o que a genética humana pode nos prover, e, em particular, os experimentos que a natureza faz. Então, o que são esses experimentos? Então, nós todos sabemos que existe uma grande diversidade de variações no nosso genoma, quando nós comparamos indivíduos. E é isso que faz com que, apesar da gente ter em comum mais de 99% do genoma, quer dizer, aquele menos de 1% vai fazer com que nós tenhamos cor de pele diferente, altura, fisionomia, mas também mecanismos fisiológicos. E é isso que vai fazer com que, provavelmente, a gente tenha maior ou menor sucesso na identificação desses novos alvos. E, fundamentalmente, com a facilidade que nós temos hoje de avaliar o material genético, em outras palavras, o custo do sequenciamento. Lembra que o primeiro genoma humano, ou seja, todo o projeto genoma humano, do final da década de 80 até o ano 2000, foram gastos cerca de 3 bilhões de dólares. Então, a gente disse que o primeiro genoma humano custou cerca de 3 bilhões de dólares. Hoje, nós estamos falando de algo em torno de 500 dólares. Quer dizer, então, é uma redução espetacular, desafia até a lei de Moore, que era utilizada no quanto que você poderia melhorar a capacidade de um chip de computador a cada ano, a cada 2 anos. A outro aspecto é que a nossa capacidade de medir fenótipos intermediários, o que seriam fenótipos intermediários? São aqueles surrogates de funções que nós temos interesse. A própria pressão arterial, ela é um fenótipo intermediário, porque ela é uma variante, ela depende de várias coisas, e a gente está procurando saber quais são os sinalizadores que podem dar uma melhor ideia desse fenótipo. O colesterol, marcadores de inflamação e assim por diante. E aí a pergunta é, será que isso é suficiente, fazendo essas associações, para decidir o que é um bom alvo? Olha, se tentou muito isso e se achava que sim. Mas hoje nós temos dados com refinamento de algumas ferramentas de genética, de epidemiologia, que permitem a gente analisar isso com mais cuidado. Então, vocês já devem ter ouvido falar das análises de randomização mendeliana, não é? Então, quer dizer, é um trial randomizado da natureza para validar alvos. Então, o que significa isso? Então, imagina que nós temos alguns exemplos aqui de fenótipos intermediários, por exemplo, LDL e doença coronária, Lp(a), a LP pequeno a e doença coronariana, e marcador inflamatório, CRP, e doença coronariana. A pergunta é, quais deles têm influência genética e quais deles estão qualificados para serem alvo? Veja que interessante, até bem pouco tempo atrás, essa simples associação fazia com que a própria indústria farmacêutica já pulasse para tentar desenvolver uma droga. Isso não é feito mais. Então, hoje, você procura analisar se a variante genética influencia o fenótipo intermediário e se ela influencia a doença. Se não houver essas duas relações, esse não é um alvo terapêutico para ser explorado. Ele ainda pode ser um marcador interessante da doença, mas não é um alvo terapêutico. No caso do LPAzinho, a mesma coisa. Então, existe essa relação, existem variantes genéticas que estão associadas com o aumento do LPA, e existem variantes genéticas que estão associadas com a prevalência da doença. Consequentemente, esse é um alvo terapêutico a ser explorado. Veja o CRP. Ele tem uma relação de variantes genéticas com o CRP, mas não tem uma relação forte de variantes genéticas com a doença coronariana. Consequentemente, ele pode ainda ser utilizado como um preditor de doença, mas ele não deve ser um alvo terapêutico. Então, esses são conceitos que vieram se desenvolvendo nos últimos 10 anos e estão mudando, porque muitas das drogas que foram decididas com base nessas simples associações, elas não deram certo. Nós já discutimos, já foi discutido na manhã de hoje a questão do HDL, quer dizer, existem várias dificuldades, então, nessa escolha. O que mais pode ser feito? Então, o que se procura utilizar da genética é, primeiro, identificar aqueles experimentos que são feitos naturalmente, ou seja, mutações que têm um efeito muito forte sobre uma determinada variável, no nosso caso, no metabolismo de lípides e, consequentemente, na doença. Depois, utilizando uma série de ferramentas de genética, que a gente hoje tradicionalmente fala de omics, para tentar entender o mecanismo molecular pelo qual aquele sistema, aquele metabolismo, no caso dos lípides, funciona. E isso começa a fazer com que a gente identifique, por exemplo, alvos ou enzimas que têm variantes e que estão associadas a maior ou menor atividade, que podem influenciar essa via metabólica e, consequentemente, podem dar origem a um novo marcador. E, fundamentalmente, uma outra parte que também é importante dessa nova genética é que antes nós fazíamos drogas simplesmente com base nas chamadas small molecules, né? Nessas moléculas que a gente utiliza até hoje. Hoje, essa caixa de ferramentas se ampliou demais. Quer dizer, hoje existem várias outras possibilidades que nós vamos descrever, algumas delas, como você pode atingir aquele determinado alvo utilizando essas ferramentas. Mas vamos pensar se isso acontece de fato. Então, nós temos 2 grandes exemplos na área de metabolismo de lípides. O primeiro deles é o próprio LDL, e eu não vou repassar essa história. Mas a segunda é uma história relativamente recente, que é a do PCSK9. Então, o PCSK9, ele desempenha um papel muito importante na reciclagem do receptor de LDL e no próprio clearance de algumas das partículas de LDL. Olha que interessante, ele foi descoberto em 2003, logo depois se identificaram variantes genéticas que nós chamamos que tem ganho de função, ou seja, eles ativam o gene, e isso estava associado a uma doença, a uma hipercol familiar dominante, numa família francesa. Então, utilizando genética tradicional, estudo de ligação, se chegou até esse gene. Rapidamente, alguns anos depois, foi esclarecido o mecanismo de ação do PCSK9. E só para lembrarmos, não é? Quer dizer, desse... eu acho que eu estou congelado. Vocês me ouvem?
Sim, estamos te ouvindo, Krieger. Acho que só foi no seu computador.
O computador está congelado. Então, vamos fazer só um pouquinho. Eu acho que o ideal é vocês me dão só... Eu vou ter que fechar e reabrir. Um momentinho só.
Ok.
É rapidinho. Você já vê a tela? Sim, né?
Sim.
Podem me ouvir?
Sim.
Ok. Então, essa figura ilustra muito bem o mecanismo do PCSK9, não é? E como é que ele atua. Então, se nós pegarmos essa metade do slide, nós vamos ver que o receptor de LDL é produzido, ele se liga junto com a ApoB e o LDL, entra no receptor, esse receptor vai para o lisossoma, no lisossoma o LDL é catabolizado e o receptor retorna para a superfície da célula e pode pegar outra molécula assim por diante. O que é que o PCSK9 faz? Ele é produzido também no hepatócito, ele é secretado, e quando ele se liga a esse complexo, ApoB, LDL, ele faz com que, quando você enderece esse complexo para o lisossomo, todo o material vai ser catabolizado. Então, você não tem a reciclagem do receptor como você tem nessa situação. Então, imagina que eu tenho uma situação onde esse gene está ativado, o que vai acontecer? Vai começar a faltar receptor de LDL, porque os receptores não estão ciclando. Então, esse foi um conhecimento muito importante e que pôde, então, dar origem a começar a se explorar isso do ponto de vista terapêutico. Logo depois, foi determinado também que uma outra mutação, aquela primeira era ganho de função, agora é falta da atividade do gene, ou seja, loss of function. Então, consequentemente, você vai ter mais reciclagem do receptor de LDL, e isso faz com que você tenha um baixo LDL, um colesterol na circulação, e também associado com baixo risco cardiovascular. Passou por aquele teste da randomização mendeliana, não é? Para ver se era uma simples associação ou se tinha uma relação causal, e tem uma relação causal, e mais ainda, aproveitando de diferentes estratégias das chamadas ômicas, não mais com small molecule, mas com biomoléculas, né? Anticorpos, RNA de interferência, assim por diante, foram desenvolvidos os inibidores. Vejam que interessante, estamos de novo congelados. Vamos ver se a gente consegue sair dessa rapidamente, senão vai ser necessário entrar. Tenho a impressão que esse apontador, ele está, de certa maneira, prejudicando. O ponto que eu quero falar para vocês, e que vai aparecer em seguida, enquanto eu estou novamente reiniciando o programa, é que todo esse ciclo, desde a descoberta da molécula até o desenvolvimento da droga, isso aconteceu em cerca de 11 anos, e que é uma coisa mais ou menos espetacular se nós formos considerar normalmente a velocidade com que essas coisas acontecem. Então, isso dá uma ideia para nós do que está acontecendo. Então, entre a descoberta e a validação, 3 anos, entre a validação e os primeiros clinical trials, 4 anos, e mais 4, 5 anos para o FDA e a EMA aprovarem. Então, um belo exemplo de como a utilização da genética e depois dessas novas técnicas de intervenção para desenvolvimento de anticorpos ou de RNA de interferências, drogas que estão tendo um tremendo sucesso na prática clínica foram desenvolvidas. Então, cerca de 11 a 12 anos, o ciclo todo. Então, isso mostra para nós, com esse exemplo, algo que é muito interessante. Então, vocês estão vendo nesse gráfico os níveis de LDL e risco cardiovascular. Então, vocês pegarem baixo e alto risco, baixo e alto nível de LDL. E o que nós temos aqui é quase que uma curva, não é? Aonde você mostra que os níveis normais, eles podem ser manipulados tanto para cima, com defeitos, por exemplo, no receptor de LDL, ou com aquelas mutações de ganho de função no PCSK9, e reduzindo o risco com as mutações com perda de função, e evidentemente que nós nem falamos, mas existem aquelas mutações que estão associadas ao gene do HM-GCR, que deram origem às estatinas. Mostrando, então, o poder desses experimentos que a natureza produz e que nós identificamos e tiramos vantagem não só para fazer diagnóstico, como também para desenvolvimento de novos fármacos. Então, essa questão da priorização do alvo, ela se tornou muito importante, dada a baixa produtividade que a farma está apresentando. Então, hoje, não só se identificam as necessidades médicas, né, utilizando daí essas ômicas, tanto para target identification, para identificação dos alvos, como para sua validação, novas terapias, com a ideia de que isso vai melhorar o manejo de doenças, a qualidade de vida, e realmente de maneira rápida. Existem uma série de abordagens para fazer isso. Você pode começar do que a gente chama de uma estratégia forward, não é? Que você vai de uma doença como uma dislipidemia severa, né? Fenótipos dessa natureza, aonde você identifica os genes causais, ou você começa dos genes, você primeiro descobrir o gene e depois vai entender como é que isso influencia o fenótipo clínico. Não é? De tal sorte que o entendimento da questão, no nosso caso, metabolismo de lípidos, se torna cada vez mais importante. Então, a gente poderia sumarizar essas questões, principalmente da genética e desses últimos 10 anos, em 2 grandes blocos. O primeiro deles é onde nós temos esses experimentos da natureza que provocam algumas poucas variantes com grande efeito. E são esses efeitos no gene do receptor de LDL, do PCKS9 e assim por diante. Isso está dando origem, então, a novos diagnósticos e novas terapias, conforme nós ilustramos. Mas existem também milhares de variantes que têm pequeno efeito. E até esse momento, nós não estamos sabendo muito bem como utilizá-las. Mas, dados recentes, analíticos, estão propondo que elas podem ser utilizadas para estratificar uma população. Esse é um conceito novo, onde você poderia começar a fazer a estratificação, não aquela que a gente já faz com sucesso, por exemplo, com os algoritmos de Framingham, quando a pessoa já está doente, mas antes do indivíduo estar doente, antes dessas doenças que precisam de décadas para se manifestar e que são dependentes de uma herança poligênica, ou seja, são vários genes envolvidos, talvez a gente já tenha estratégias com o chamado PRS, que é o Polygenic Risk Score, que permita não dar diagnóstico individual, mas numa população ampla, eu começar a separar essa população por estratificar e, por exemplo, começar a dar maior atenção para o decil superior e menor atenção para o decil inferior. Ou seja, esse tipo de estratégia está amadurecendo para começar a entrar na clínica. Ainda está em teste, mas ela realmente pode revolucionar a forma com que a gente lida de maneira mais objetiva, racional, com as chamadas doenças complexas que a gente ainda não tem atuação. E, para finalizar, eu vou dar alguns exemplos de como a gente melhora o conhecimento desses alvos utilizando essas ômicas. Não é? Então, por exemplo, nesse próximo exemplo, o que nós vamos fazer é tirar vantagem de alguma dessas ferramentas que estão disponíveis, por exemplo, grandes bancos de dados, onde, por exemplo, foram feitos sequenciamento de expressão em tecidos de pacientes. Nesse caso, num desses bancos, que é o GTEx, nós pegamos amostras coronarianas e a nossa ideia aqui era começar a identificar indivíduos que estavam lá no banco classificados como tendo a placa de aterosclerose, mas não tinham evidência de doença, não tinham comorbidades, controles e tal, para ver se a gente conseguia separá-los pelo padrão de expressão gênica. E o que vocês estão vendo aqui é uma análise de PCA, onde permite fazer isso de uma maneira não supervisionada e não separou muito bem o grupo. Então, o que é que a gente vem utilizando? Inteligência artificial. Um dos algoritmos de machine learning é o Random Forest Algorithm. Isso está sendo feito aqui no nosso laboratório, com esses alunos que estão aqui mostrados no painel inferior. E o que nós estamos vendo é que você começa a dividir isso dentro dessa tecnologia em árvores, e elas começam a separar agora. O vermelho e o azul são os indivíduos que têm placa e não têm comorbidades e assim por diante, até que a gente chegue nos tais genes candidatos. Então, novas ferramentas analíticas permitindo que a gente faça isso. Mas quando a gente está trabalhando com tecidos, isso já dá uma grande visão, mas o tecido tem várias células, e isso é um problema. Como é que nós podemos pegar algumas dessas perguntas e começar a analisá-las também individualmente? Então, um dos exercícios que nós estamos fazendo é utilizando células endoteliais da aorta, da coronária, e aonde nós fizemos a segunda pergunta: qual é o papel individual dos fatores de risco, individuais e em conjunto? Porque dificilmente um paciente aparece para nós com um único fator de risco. Em geral, ele tem todos eles. Então, é um paciente que, evidentemente, tem bifurcações, alterações de padrão de fluxo, ele tem, frequentemente, lípides aumentado, inflamação, hipóxia, ou tem todas as coisas. E o experimento que nós estamos querendo fazer é: será que somar 1 mais 1 mais 1 mais 1, em outras palavras, pode ser que tenham genes ou vias que são acionadas somente quando todos os genes todos os insultos são feitos simultaneamente. Nós podemos fazer isso no laboratório, né, fazendo cada uma dessas intervenções individualmente ou em conjunto, e a gente também, numa análise análise de expressão gênica, começa a separar esses grupos. Não é? O que estava esperado. E mais ainda, identificar os genes que estão expressados em cada um deles. Então, essa figura vermelha, que está com intersecção com todos os outros fatores, é o que tem todos os insultos simultaneamente, versus um insulto de cada vez. E o que eu quero mostrar para vocês é que o que acontece nesse que recebeu os 4 insultos não é o produto da somatória dos outros. Existe quase 50% dos genes que só foram modificados quando todos os insultos estavam presentes simultaneamente. Então, isso é fantástico, porque se você olhar isoladamente, você não vai entender o processo que provavelmente está acontecendo no seu paciente. Então, para validar esses dados, nós agora voltamos para uma situação complexa, ou seja, para uma coronária que tem uma placa, e agora nós vamos utilizar uma outra tecnologia, que é o single cell RNA, o sequenciamento de RNA numa única célula. O professor Peter Lieb mencionou isso também na sua apresentação. A forma de visualizar, então você faz milhares de sequenciamentos de cada um. Imagine aqui que nós temos cerca de 10 mil células e pelo padrão de expressão elas são organizadas. Nós estamos interessados aqui nas células endoteliais e a gente vê aqui que tem 2 populações, mas tem também as outras células que fazem parte desse tecido, do vaso. Ou seja, você tem músculo liso, fibroblastos, células imunológicas. Nós estamos agora focando aqui nas células endoteliais. Por quê? Porque nós queremos validar se aqueles genes que eu chamei que são emergentes, que só são modificados quando as células recebem todos os estímulos simultaneamente, se isso acontece no tecido de um paciente que tem esse problema. E vejam que interessante. Essa é a forma da gente visualizar esses genes aqui, nos 2 conjuntos de células endoteliais que eu disse que foram identificadas, e qual é o padrão de expressão deles. E o que eu quero salientar aqui em verde são aqueles genes emergentes, e principalmente uma categoria de genes que não apareceu quando a gente estava vendo os insultos isoladamente, e apareceu quando eles estavam juntos, e que é ilustrado por esse MYC, que é um dos genes que ativa a proliferação celular. Ou seja, todo o fenótipo de proliferação só foi desmascarado quando nós vimos a análise em conjunto. Veja que interessante. Então, a gente pode dividir o problema, reintegrar, utilizando essas famosas, essas ditas ferramentas ômicas. Portanto, para encerrar, o que é que eu procurei discutir com vocês nesses minutos? Primeiro, mostrar a importância dos experimentos que a natureza faz para avançar o nosso conhecimento na identificação e validação de novos alvos. Não é? Então, um exemplo disso é todo o esforço que é feito no mundo, e nós fazemos aqui no Brasil também, de identificar essas variantes. Esse é o programa Hipercol Brasil, que a gente já vem fazendo há alguns anos, e vejam, já analisamos mais de 2.000 casos individuais, que vários de vocês enviaram para nós. Isso pode ser feito ao nível da atenção primária, quando a gente tem níveis de colesterol elevados e vai buscar quem são esses pacientes, ou pode ser um paciente que está num hospital secundário, terciário, numa clínica, e que ele não precisa do diagnóstico molecular, mas nós, sabendo o diagnóstico molecular dele, nós vamos identificar os familiares que podem nem ter manifestado a doença, que tem risco. É por isso que a gente já segue 620 famílias. Então, veja que espetáculo. Todos vocês vêm participando e devem participar desse esforço. Nós não cobramos por esses exames, nós procuramos obter financiamento para isso, e aqui está como vocês podem entrar em contato com o nosso grupo para viabilizar, enviar amostras, saber como funciona, querer repetir o programa no ambiente de vocês. Quer dizer, então isso é uma coisa que está aberta. O segundo ponto que eu discuti com vocês são o papel das ômicas para aumentar o ambiente onde nós estamos entendendo essas alterações moleculares para melhor entendimento de fenótipos complexos. Evidentemente que eu não vou detalhar aqui, mas isso começa a dar um quadro bastante amplo do metabolismo de lípides, aonde ele atua, as proteínas que são produzidas pelos hepatócitos, quer dizer, os fenômenos que ocorrem na circulação, e, evidentemente, o que nos interessa muito, o que está acontecendo na célula endotelial e no músculo liso. Então, isso é o que faz com que a gente possa identificar e validar esses novos alvos. Finalmente, eu procurei dizer para vocês, nós não detalhamos, mas que existem também oportunidades com essas abordagens genômicas de aumentar o nosso toolbox de como influenciar um gene candidato, um alvo. Não é? Então, nós saímos daquele conceito onde a gente identificava o gene, a proteína, e tinha uma small molecule. Agora tem anticorpos, tem formas de interferir diretamente no gene. Quer dizer, então, isso são questões que abriram para nós esses mecanismos e tudo. Então, esses foram os três mensagens, os três take-home messages que eu gostaria de discutir com vocês, e, evidentemente, que esse é um trabalho em grupo do nosso laboratório e de colaboradores. Eu gostaria só de enfatizar algumas das pessoas que estão aqui e alguns dos membros, né, do chamado Hipercol Brasil. Em particular, eu gostaria de ressaltar o papel do Alexandre, da Cíntia, né, que coordena o dia a dia dessas atividades, e, evidentemente, do Raul, que é um grande parceiro, e a Vivi aqui no Instituto do Coração, e agradecer a atenção de vocês. Muito obrigado.
Muito obrigado, professor Krieger, pela belíssima apresentação, muito clara e simplificando um assunto que, para a maioria dos cardiologistas, ainda é algo bastante complexo, mas que é algo que nós temos que ter o conhecimento, a gente tem que estar dentro, porque isso não é mais o futuro, isso é o presente, em todos esses aspectos. Eu estou aqui com meu colega de diretoria, querido amigo Henrique Triabianco. Henrique, passo para ti a moderação, para nós podermos aproveitar os outros palestrantes também, que são pessoas de grande conhecimento.
Bom dia, pessoal. É sempre muito prazeroso ter a oportunidade de ouvir o professor Krieger, geneticamente determinado para estudar os assuntos das doenças cardiovasculares ligadas aos polimorfismos. Eu queria, antes de fazer a apresentação formal e ouvir a palavra dos nossos outros palestrantes, o doutor Francisco e o doutor Alexandre, é sempre muito relevante a gente tentar responder as perguntas, as inquietudes da prática clínica com os dados de laboratório, né? Nessa inserção, existem algumas perguntas que, para mim, ainda não ficaram muito claras, principalmente considerando as atuações dos microRNAs na expressão, no fenótipo de algumas doenças. Existem alguns papers, eu não sei se eles são ainda já foram publicados, mas algumas considerações mostrando a correlação de alguns polimorfismos, de alguns microRNAs linkados com a doença cardiovascular, expressivamente, fundamentalmente nos aneurismas de aorta abdominal. Eu queria ouvir o professor Krieger, se ele tem algum dado em relação a esse aspecto, linkando esses microRNAs com aneurisma de aorta abdominal.
Bom, essa área dos microRNAs, ela realmente é fascinante. E nós só temos que lembrar que um grande problema intrínseco dessa área é que nós temos um repertório de microRNAs que, como várias outras moléculas, ele é limitado. Então, ele pode funcionar num determinado sistema, mas funciona em outros. Então, ele não é puro, frequentemente ele não é puro para aquele mecanismo que nós estamos estudando. E é isso que causa também uma série de dificuldades, às vezes, na interpretação desses resultados, ou até mesmo na decisão de escolhê-los como alvo para atuação terapêutica, por exemplo. Então, aqui na nossa linha de pesquisa, nós estamos trabalhando com o aneurisma, mas já com um gene candidato, e não com um microRNA. Agora, existem dados na literatura, conforme você mesmo salientou, associados aos mecanismos que estão por trás do aneurisma, mas eu diria o seguinte, não tem nenhum desses marcadores que ainda... Você tem evidências da participação de alguns marcadores, mas nós não temos ainda uma visão de conjunto de o quanto que cada um desses marcadores e em quem eles vão ter essa função. Então, isso é algo que, à medida que os estudos se ampliarem e o nosso conhecimento melhorar, aquela equação mais complexa, eu acredito que fica melhor para o entendimento não só da biologia e, evidentemente, para explorar um pouco, tanto para efeito diagnóstico como terapêutico, esses alvos.
Muito bem, muito obrigado. Eu passo agora a palavra para o professor Francisco Fonseca, da Universidade Federal de São Paulo, as suas considerações iniciais, e se ele puder comentar um pouquinho sobre essa nova alternativa da redução do LDL colesterol por meio de modulação de RNA de transferência, como o inclisiran, diminuindo assim, dessa forma, a síntese hepática de colesterol. Você poderia falar alguma coisa, por favor, Francisco?
Bem, bom dia a todos, bom dia, Henrique, Paulo, Krieger, Alexandre. É uma satisfação muito grande participar deste tipo de atividade. Cumprimento o Departamento de Aterosclerose pelo brilho desse programa, o conteúdo científico realmente bastante impressionante. E cumprimento também o Zé Eduardo Krieger pela essa visão atual, né, abrangente, dos aspectos genéticos. Eu acredito que nós vivemos hoje um tempo de grande avanço da ciência e fundamentada no desenvolvimento da genética, né? Quando você citou agora os RNAs de interferência, eu acho que eles estão mudando, né, com perspectivas assim muito promissoras e de maneira muito eficiente, nesse caso, o LDL colesterol, por exemplo, com o inclisiran, né? E com 2 injeções por ano, quer dizer, uma modalidade de tratamento que a gente nem sonhava, né? E eu fico até imaginando qual será o futuro, né? Que você tem uma redução média de 50% no LDL colesterol, utilizando 2 injeções por ano dessa medicação, e talvez em doenças complexas como a hipertensão e o diabetes, sabendo a participação de alguns sistemas, talvez até no futuro nós possamos modular o sistema de angiotensina, ou modular a atividade simpática, ou ter também alguns avanços para que haja uma terapêutica efetiva e que possa ser utilizada dessa forma, por exemplo, com poucas administrações, tendo um controle dessas doenças complexas. O que ele citou muito bem, que você tem, por exemplo, uma medida de pressão arterial, é só um componente, né, da doença hipertensiva. Você tem múltiplos aspectos que não estão presentes ali, a atividade inflamatória, as alterações metabólicas, as pressões centrais, a velocidade da onda de pulso, a função endotelial. Então, as doenças complexas, eu acho que vão precisar muito da genética e dessas novas estratégias terapêuticas que estão surgindo. Cito também a terapia anti-sentido, também, que também é bastante promissora e direcionada mais especificamente a algumas moléculas.
O pessoal está um pouco inibido ainda em relação às perguntas. Eu passo as considerações do professor Alexandre, já colocando um pouquinho de pergunta. Apareceu aqui uma pergunta. Dr. Krieger, como evitar, Krieger, por gentileza, depois das considerações do Dr. Alexandre, mas já fica uma pergunta aqui do Desidério, como evitar um modelo carro que não funciona? Isso é multicausalidade, não relacionadas entre si, cuja abordagem fica quase insolúvel? Você pode responder essa pergunta depois das considerações iniciais do Dr. Alexandre. E eu passo para o Dr. Alexandre a tentativa de responder algum tema que me é muito caro, são os aspectos epigenéticos, especificamente na metilação, na acetilação de DNA e de histonas. Você poderiam comentar alguma coisa sobre isso, Alexandre, por favor?
Bom dia a todos, obrigado, Henrique. Bom dia a todos os participantes do workshop. E eu queria agradecer também a diretoria pelo convite. Henrique, eu acho que esse ponto que você colocou é bem importante também, porque ele diz respeito à participação do ambiente, né? Muitas vezes a gente acha que, ou tem a ideia de que a participação do ambiente ela é mediada por sinais que são efêmeros, né? Na presença, por exemplo, de uma exposição. Mas só onde ser o fato, porque hoje em dia a gente já sabe que determinadas exposições ambientais ou situacionais, elas vão levar a alterações no DNA, e essas alterações podem persistir por anos, né? Uma forma da gente estudar isso é exatamente isso que você colocou, são essas alterações epigenéticas. Então, eu acho que isso é fundamental para entender um pouco do que o professor Francisco e o Krieger discutiram em relação à multicausalidade, a todas essas interferências que podem estar, de certa forma, modulando o traço no futuro. É interessante também quando você pensa nisso e você entender que o processo realmente é complexo, que na verdade vai depender, para a gente conseguir entender esse processo, de uma série de abordagens que vão correr em paralelo, né? Tudo isso que a gente citou hoje aqui são componentes que estão ocorrendo ao mesmo tempo dentro desse sistema, e que na verdade você tem que desenvolver uma plataforma que te permita estudar isso ao mesmo tempo. Uma outra coisa que eu fiquei pensando bastante enquanto o professor Krieger estava falando, e eu achei perfeitas as colocações que ele fez, mas uma coisa que eu pensei bastante, eu acho que talvez a gente pudesse trazer para a discussão, é qual que é o papel da gente como comunidade dentro desse desenvolvimento. E quando eu falo o papel, qual que é o nosso papel local mesmo, né? Porque várias dessas coisas a gente descreve como, olha, isso aqui está acontecendo, isso vai mudar a forma como a gente faz as coisas, mas a gente está recebendo essa informação, né? E qual que é a implicação da gente estar fazendo isso e fazer isso por gerações, assim? Qual é a implicação da gente não ter esse conhecimento local no Brasil, né? E isso se torna fundamentalmente importante quando você está falando de genética, porque a genética das populações, embora, como o professor Krieger colocou, ela é fundamentalmente igual, ela varia de região para região. Tanto é que hoje em dia as pessoas conseguem fazer aqueles testes de ancestralidade e vão te falar assim, você veio do Brasil, você veio da Europa, você veio da África e assim por diante. Isso, na verdade, é só um exemplo de como existe uma certa regionalização desse conhecimento também, que é importante. E que essa regionalização ela pode ter consequências na forma como a gente tem acesso a essa tecnologia e na forma como a gente usa essa tecnologia, né? Então, acho que isso também é uma coisa importante para a gente discutir num colóquio como esse, né?
Eu não sei se você ouviu adequadamente a colocação do Alexandre.
Sim, do Alexandre, e a pergunta do Desidério, né?
Isso mesmo.
Talvez você repetir, porque eu não sei se o pessoal todo que está nos ouvindo, eu lembrei a pergunta. Você quer repetir a pergunta dele? Talvez seja, ou colocar só para a gente estar com todo mundo.
A pergunta do Desidério, se você tiver ela arquivada aqui, por gentileza, pergunte e responde.
Isso, tranquilo. Então, o Desidério, essencialmente, fez uma pergunta que é um desafio diário. Quer dizer, como é que você determina causalidade ou diferencia causalidade de associação quando nós estamos trabalhando com problemas complexos? É muito complicado. Isso acontece diariamente na vida de um pesquisador e na vida de um clínico. Quer dizer, isso é o que a gente lida diariamente. Então, eu procurei mostrar uma das metodologias que a genética trouxe e que estão contribuindo para isso. Quer dizer, mas utilizando um exemplo de cada vez. Então, o fato de você ter uma variante genética que está associada com um fenótipo intermediário, só para deixar bem claro, vamos colocar, né? Então, por exemplo, uma variante do gene PCSK9, níveis de colesterol e doença coronariana. Então, a associação entre doença coronariana e nível de colesterol está bem estabelecida. A pergunta que nós queremos saber agora é se aquele polimorfismo genético, não é, que influencia os níveis de PCSK9 e a doença coronária, se essas duas coisas estão acontecendo, se sim, isso demonstra, sugere uma causalidade e faria que, então, com que o gene PCSK9 fosse um target. Então, esse é uma situação bem isolada dentro de um sistema complexo, onde eu estou vendo a participação de um componente. Evidentemente que nós temos hoje ideia que esse componente, no caso dessas mutações que nós falamos, ele até desempenha um risco muito grande, por isso que ele tem um efeito grande. Agora, nós vamos ter uma situação nas doenças complexas, e acho que é isso que o Desidério está falando, aonde esses efeitos são pequenos, e aí a demonstração até dessas associações vai ser muito mais difícil. Quer dizer, primeiro precisa N maiores, precisam experimentos maiores, mas esse é o desafio. O importante é que nós estamos começando a ter ferramentas objetivas para responder isso. E um ponto que eu quero salientar é a questão do CRP. O CRP, quer dizer, ela tem essa associação, tem um polimorfismo que aumenta a atividade do CRP, quer dizer, e a atividade inflamatória está relacionada com a doença cardiovascular, mas o polimorfismo não está associado com a doença cardiovascular. Então, isso sugere que, sim, o CRP continua sendo um marcador preditor de doença, mas ele não é um alvo, porque eu não tenho evidência de que ele esteja sendo. Então, isso remete àquela questão, numa escala bem reduzida, para um gene de grande efeito, da pergunta que o Desidério fez. Isso vai ter mais problemas quando a gente estiver tratando daqueles problemas que são multifatoriais, com pequena participação. E é isso que nós estamos procurando evoluir. Então, ele está correto de colocar aquilo, e o que nós estamos fazendo é trazendo alguns dos avanços que estão permitindo que a gente possa diferenciar o que é uma simples associação do que é uma relação causal, e que é fundamental para as ações que a gente vai tomar, não é? No dia a dia. Henrique, está com você. Eu acho que o Henrique está congelado.
Então, eu vou fazer uma pergunta para o professor Fonseca. Foi citado na apresentação do professor Krieger os scores poligênicos de risco. E eu, pessoalmente, trabalho com prevenção e fico muito frustrado, porque nós não temos no Brasil, a princípio, como fazer essa avaliação dos scores poligênicos e quantificar se é um paciente com alto risco poligênico, médio ou baixo risco poligênico para uma futura doença cardiovascular. Como um exemplo, assim, para trazer para a prática clínica, né, chega uma paciente, uma mulher de 40 anos com fatores de risco moderadamente alterados, né? Será que a gente tem que tratar desde cedo essa moça, essa senhora de 40 anos? Então, eu queria saber como é que está a situação atualmente no Brasil em relação à identificação genética o sequenciamento genético da população brasileira, e se nós poderíamos, eventualmente, transportar essas informações que nós temos em outros países, especialmente na Europa, para o Brasil.
Obrigado, Paulo, pela pergunta. Eu acho que é um tema bastante interessante, mas a gente tem hoje a ideia clara das grandes doenças monogênicas, de você ter uma influência clara na doença e poder atuar. Quando você vê a participação dos scores de riscos genéticos, eu acho que ainda é bem limitado, e a contribuição de vários genes para a doença, eu acho que hoje, mais do que você fazer uma análise de um painel grande de genes, é você ver os dados anatômicos. Então, você tem um score de cálcio coronário, você tem imagens do desenvolvimento da aterosclerose, eu acho que dá uma ideia já mais definida para você intervir para um paciente, mais do que hoje a exploração de múltiplos genes que possam contribuir para aquele fenótipo que você está buscando, né? E especificamente também aquilo que o Henrique comentou, né, os dados de epigenética, os dados comportamentais também têm uma influência grande, e não apenas aquele polimorfismo em si. Eu acho que estamos tendo avanços grandes, mas principalmente, mais do que a contribuição na estratificação, o Krieger comentou o preço hoje barato para você fazer um genoma, um exoma, muito mais disponível do que a gente imaginava, mas eu acho que a gente ainda precisa de muita inteligência artificial para interpretar esses dados de múltiplas informações que estão começando a ser disponibilizados, mas que a gente ainda tem que evoluir bastante na interpretação desses dados.
Paulo, você permite eu fazer um comentário?
Com certeza.
Eu acho que as duas perguntas que você fez são críticas. E, evidentemente, que aqui no Brasil, nós vamos ter que começar a fazer uns testes de proof of principle, até porque, quer dizer, existe um projeto hoje na rua, ele não está totalmente financiado, de sequenciamento de 100 genomas brasileiros. Nós estamos muito atrasados nisso, comparado com outros países. E até por causa da nossa riqueza, que o nosso material genético é de interesse mundial por causa do problema da mistura que tem aqui. Muito bem, mas há algumas oportunidades. Então, nós temos algumas populações genotipadas aqui. Algumas populações são estudos nossos, do nosso laboratório, o Alexandre envolvido, por exemplo, a população de Baipendi. Então, é um estudo que a gente já vem fazendo há cerca de 15 anos e tal. Agora, tem também outras coortes brasileiras que já foram sequenciadas, ou pelo menos genotipadas em larga escala. E uma delas é a de Pelotas, não é? Que de conhecimento e tal, são uma população de nascidos em 1982, daqui a pouco vão ter 40 anos, e o que nós fizemos, então, foi, primeiro, derivar um score de risco poligênico utilizando os dados do UK Biobank. Então, nós pegamos o dado e derivamos aquilo. Eles fizeram, nós fizemos a derivação. E aí, a sua segunda pergunta, utilizar o PRS europeu na população brasileira. Muito bem, isso não está publicado, nós estamos quase submetendo, então a ideia funciona. Então, são 500 mil marcadores que nós conseguimos obter, e, inclusive, a nossa explicação do quanto ele está explicando da variação do fenótipo é até um pouco superior, está entre 10% e 14%, tá? Que não é pouco, da genética, evidentemente, né? Quer dizer, que a gente estava acostumado com coisas 2%, 3%, então isso está levando a 10% a 14%. E nós fizemos também com a população para validação com a população de Pelotas, com o mesmo resultado para a hipertensão arterial. Eu acho que a partir disso, quer dizer, tem uma outra coisa que nós estamos fazendo, é agora fazer o PRS nacional para ver se ele se aplica da mesma maneira, porque nós utilizamos, né, para aqueles que estão mais afeitos ao problema, o PRS importado, vamos dizer, não importado, mas obtido da população do UK Biobank, população de 500 mil indivíduos. Então, eu acho que isso começa a mostrar o potencial disso tudo. O que nós vamos fazer agora? Porque, por exemplo, o Fonseca mencionou um negócio que é importante, que o clínico sabe. Quer dizer, quando você está na quarta, quinta década, você já tem algumas manifestações, ainda mais com as nossas formas de indagar, seja biomarcadores, né, imagem, coisas que estão no sangue, assim por diante, mas uma ideia é, será que eu consigo pegar essas pessoas com 20, 30 anos para saber quem que eu tenho que estar olhando? Então, uma das coisas que nós vamos fazer agora, e que já estamos em contato com o pessoal de Pelotas, é nós, com base no dado que nós já temos, estratificar entre decil superior e inferior a população de Pelotas, essa população, e colocar uma pulseirinha que nós desenvolvemos aqui no INCOR, tá, na fase final de desenvolvimento, que avalia pressão arterial, 24 horas por dia. Então, a primeira coisa, nós vamos começar a colocar periodicamente uma exposição de 1 a 2 semanas, indivíduos de baixo risco genético, lembra, isso não é diagnóstico individual, é de população, para que a gente possa, primeiro, enquanto eles não têm hipertensão arterial, será que já está mudando algum fenótipo da pressão arterial nesse indivíduo, embora a pressão seja normal? Quer dizer, então, lembra, 24 horas por dia que essa medida vai ser feita. E nós vamos fazer isso, eles vão ter 40 anos em 2022, e a ideia é seguir. Então, primeiro, o algoritmo foi desenvolvido aqui no INCOR, quer dizer, nós temos sensores, você compra um Xing Ling chinês, mas todo o algoritmo com inteligência artificial para fazer a pré-tomografia, nós estamos desenvolvendo aqui in-house. Quer dizer, e isso agora vai para o campo. Provavelmente a primeira, ou uma das primeiras populações será a de Pelotas. Então, eu acho que é fundamental esses pontos que foram colocados tanto por você quanto pelo Francisco, para dimensionar no contexto que o Alexandre colocou. Quer dizer, como é que nós vamos trazer isso para cá? Ou nós vamos ficar só recebendo? Será que o PRS de lá funciona aqui? Será que nós vamos ter que ter o PRS ajustado, o que é o mais provável? Mas, surpreendentemente, ele está funcionando. Nós não comparamos ainda o PRS brasileiro com esses dados brasileiros e, eventualmente, o PRS brasileiro nas amostras do UK Biobank. Isso está em progresso.
Perfeito, Krieger. Muito obrigado pela resposta. Henrique.
Eu acho que nós já estamos com um horário estourado. Caso contrário, o Miguel me puxa a orelha depois. Eu queria fazer uma colocação, especificamente ao professor Alexandre e ao Dr. Krieger também, em relação à telomerase, que talvez justifique a senescência. Existe alguma ação, alguma atitude farmacológica que poderia modificar ou modular essa enzima dos telômeros?
Eu só vou pedir, desculpa, Henrique, eu vi a informação agora que nós estamos em cima da hora, então eu peço que as respostas sejam muito breves, para nós não perdermos o horário do curso, por favor.
Oi, Henrique, na verdade, existem ações nesse sentido, de estar tentando modular isso, mas fundamentalmente o que se usa hoje em dia é ela como um marcador de senescência, então, de você usar o tamanho do telômero como um marcador de envelhecimento celular que não necessariamente está associado com a idade cronológica das pessoas.
Vocês me desculpem, está ótima a discussão, nós poderíamos ir muito tempo adiante. Parabéns pela apresentação, parabéns pelos comentários, mas nós temos que dar sequência a esse excelente curso. Eu agradeço a todos, um grande abraço e espero que continuem conectados aí para nós acompanharmos essa beleza de curso protagonizado aí pelo Departamento de Aterosclerose. Um bom fim de semana a todos.
Legal, muito obrigado.
Tchau.
Nós fizemos esse bloco um pouquinho mais curto, porque nós conseguimos finalmente estabelecer o contato com o professor Borg, e eu vou convidar então agora a professora Fabiana para fazer a apresentação e a introdução do professor Borg.
Oi, estamos de volta. Eu gostaria de dar as boas-vindas a Borg Nordetgaard. Ele é um professor renomado da Universidade de Copenhague, da Dinamarca, e ele nos dará uma aula sobre a reascensão, a importância dos triglicérides, das partículas ricas em triglicérides, na fisiopatologia, desde a epidemiologia, na fisiopatologia e possível alvo terapêutico dos triglicérides, dessas partículas ricas em triglicérides. Welcome, Borg. Thank you very much for
thank you very much
with us, and good lecture.
And first of all, I'd like to apologize to everybody. It's I missed my slot. It's Saturday morning here in Denmark. The sun was shining. Spring was finally coming. So I forgot about work. It's not working as hard as you people in Brazil, but I'll try to do my best by giving you a talk now. So I first have to share my screen. It's doing now. I apologize. I had two screens. I will just have to start over again. Can you see my slide now?
Not yet.
Very good. So I'm going to talk on the title, Triglyceride with lipoproteins as a causal factor for cardiovascular risk, insights from genetics, bends, and clinical studies. I work at these two institutions, University of Copenhagen as a professor, and then a consultant or chief physician as Copenhagen University Hospital. Down below here you can see my conflict of interest, the most important one being the Danish taxpayer, because all my wages and research are paid by the taxes in Denmark. When I think of triglyceride with lipoproteins, I just think of when you have a plasma sample, you take a blood sample and take away the red blood cells, and then you can see many plasmas look like this. They can be sort of like yellowish, but you can look through them. They can have high LDL, but also high LP(a).
Sorry, Bart, to interrupt, but we are not seeing your slide. Can you try it again to share your screen?
Definitely.
Sorry.
No, that's okay. So I will just screen. Can you see my screen now?
Yes, perfect.
I do apologize because I had two screens. So I'm going to talk on the title Triglyceride with lipoproteins as a causal factor for cardiovascular risk, insights from genetics, bends, and clinical studies. When you take away red blood cells from a blood sample, you can either have you can look through the plasma, it's yellowish. There you can have high LDL and high LP(a). In that case, you would have high risk of cardiovascular disease. Then a lot of plasmas look like this. They're really turbid. This is because they have much larger lipoproteins. They have triglyceride with lipoproteins, high TGs or high remnants. And in that case, you have very high risk of cardiovascular disease. And then there's the special case seen in less than 1 in 1,000, where triglycerides is very high and you have like white or milky plasma where you have chylomicrons. Then you have high risk of pancreatitis. You can also have high risk of cardiovascular disease depending on how high the triglyceride is. Here's just shown symbol the three different lipoproteins that cause atherosclerotic cardiovascular disease. Out on the left, LDL particles that we know or hear most about. And then we have the LP(a) particle that looks like LDL, but it has this extra protein on top of it, apolipoprotein (a), that you already heard about from old centers. And then finally, the larger particles. I call them remnants. some people call them VLDL, some call them triglyceride-rich lipoproteins. So they are simply characterized by being larger and having more cholesterol and triglyceride contents. They all contain ApoB, shown here in purple. In some clinical guidelines, they use the term non-HDL cholesterol, and this will really, or non-LDL cholesterol, and that would be LDL and LP, or triglyceride-rich lipoproteins together, although Lp(a) is often part of LDL, but they are all containing ApoB. And here are the same three fractions, but now shown with the relative content of cholesterol shown in yellow and triglycerides shown in white. As you can see, LDL and Lp(a), they are dominated by cholesterol. But then when you look at the remnants, there's also a lot more triglycerides. These are some values from an American study on the average cholesterol and triglyceride content. But still, when you look at the total volume of cholesterol in the remnants, it's much larger than it is actually in LDL particles. When you do a clinical lipid test, you would usually focus both on the lipids and the lipoproteins. And what you often get, you get a number for plasma cholesterol, which is the composite of all these HDL, LDL, Lp(a), and remnants. Then you also order a total plasma triglycerides. That's like a pseudo marker of how many remnants you have. But notice there's also triglycerides in these particles. And then you get a number for HDL cholesterol. That's just measuring the cholesterol in HDL. LDL is just measuring the cholesterol in LDL, but it actually also captures the cholesterol in lipoprotein(a). Because we focus here on cholesterol in LDL and HDL, that's why I prefer to talk about remnant cholesterol, meaning the cholesterol content in these particles. And as you can see here, non-HDL cholesterol and ApoB, they are a composite of all these three lipoproteins. In the fasting state, the liver produces VLDL particles, lipoprotein lipase will degrade triglycerides, and then you will have the remnant particle IDL form that can be further transferred into LDL that can deliver cholesterol to peripheral cells or bring it back to the liver. In the non-fasting state, in addition, when you eat fatty meals, chylomicrons come to the bloodstream via the lymph, and then lipoprotein lipase will degrade triglycerides, producing chylomicron remnants. We usually take blood samples in the non-fasting state. I know this is also endorsed in Brazil, now also in the American guidelines and also in the European main guidelines. So this is a worldwide phenomenon. So when you talk about remnant cholesterol in the non-fasting state, it will capture IDL, VLDL, and chylomicron remnants. Still, VLDL and IDL quantitatively are more important than the chylomicron remnants. Here's my little summary of how I look at these three lipoproteins causing atherosclerotic cardiovascular disease. LDL, of course, we know from many, many years is what causes atherosclerosis. Stable atherosclerosis, we know, for example, from both heterozygous and homozygous FAs, they can get huge amount of atherosclerosis without maybe having a myocardial infarction. Of course, many of them do get one. When you have remnants, on the other hand, I'll show you the data, it seems like there could be more like an inflamed, unstable plaque, giving rise to plaque rupture maybe more easily than LDL. And then you have the Lp(a). Some people think it's causing atherosclerosis, but generally Lp(a) carry much less cholesterol in plasma than LDL and remnants. Rather, it's possible that Lp(a) indirectly could promote thrombosis because it has homology with plasminogen. We have worked on, and many others, using genetics to try to understand causality. This is really a breaking point for understanding remnants and triglyceride-rich lipoproteins. Here, compared with the randomized trials, which we usually use to understand causality. So doctors or nurses recruit patients into a trial. You flip a coin, and then half get placebo, half get a drug that in this case reduces the triglyceride-rich remnants. And then the confounders are equally distributed. That's the beauty of the randomized trial. And then you can look at what's the effect on cardiovascular disease. Mendelian randomization studies are just nature's own randomized trials. So when we produce children, it's a flip of a coin which alleles we give to different children. Some get a normal allele, and maybe some get an allele that lifelong lead to low triglyceride-rich remnants. And again, confounders are equally distributed. I do these studies with more than 100,000 people, and it's amazing to see that there's an equal number of people that smoke here and here. There's an equal number of obese people here and here. It's no difference. So you can look at the risk of cardiovascular disease unbiased. And also another problem of common epidemiology is reverse causation, namely that maybe cardiovascular disease could change something else. But in both the randomized trials and your genetics, there's no way cardiovascular disease can change your genes or how you are randomized into a trial. Here's a sum up of the data from our largest study called the Copenhagen General Population Study, published in 2018 in Nature Reviews Cardiology. What we did here was that we show here the hazard ratio for observational data, shown here, here, and here, and the causal risk ratio for myocardial infarction shows here for the genetic results. And first, what you can see here, so I put LDL cholesterol, remnant cholesterol, and Lp(a) cholesterol on the same scale. So just scale on cholesterol content for a 1 millimole or 39 milligram per deciliter increase. And when you see for a 1 millimole, 39 milligram per deciliter increase in LDL cholesterol, this is the higher risk of myocardial infarction, but it's actually higher for remnant cholesterol and yet higher for Lp(a). And when you look at the genetic risk, they are all on this side, the same side of the observational, telling us these are causal relationships. So for triglyceride-rich lipoproteins, the simplest chain of events is that when you have these, you have more atherosclerosis, particularly with inflammation, and this leads to myocardial infarction due to plaque rupture, as well as other atherosclerotic cardiovascular disease. And then when you have higher levels, you have higher risk. When you do something to reduce them with drug or lifestyle, this will lead to lower risk. Here's a showing the lipoproteins in plasma, where most of them just pass through, and here's the arterial wall. We know from some basic human and animal studies that the larger the lipoproteins, the more difficult it is for them to come into the arterial wall, simply because the holes in the endothelial layer is preventing the very biggest one from coming in. So chylomicrons and very large VLDL cannot come in, and HDL come in the fastest. But after they come in, so you can say, well, then LDL and Lp(a) would be more important than the triglyceride-rich lipoproteins up here, or the remnants. However, once they're in, neither of these particles can come through the elastic lamina. They are too large. Only HDL can go through. So these particles, the large triglyceride-rich, seem to be trapped preferentially to LDL and Lp(a) in the arterial intima. What convinced me way back as a young doctor was seeing patients with what's called remnant hyperlipidemia. It's also called type 3 hyperlipidemia or dys-beta lipoproteinemia. They have very high remnant cholesterol content in plasma, and they have these cholesterol deposited in the palmar crease xanthomas, and also tuberoeruptive xanthomas. So if you work in a lipid clinic, you see these patients. And what you notice on an individual patient basis that have accelerated atherosclerosis and premature cardiovascular disease as bad as familial hypercholesterolemia. That's a genetic disease of high remnant cholesterol. Here's just a summary of all our data from the Copenhagen studies, Copenhagen City Heart Study, Copenhagen General Population Study, showing that as non-fasting triglycerides go up or non-fasting remnant cholesterol, then the risk of aortic stenosis go up, the risk of mortality goes up, the risk of stroke goes up, and the risk of myocardial infarction goes up, where myocardial infarction has the highest risk. The only exception is actually acute pancreatitis, where the risk increases a lot. But then we have maybe 10 times as many myocardial infarctions as we have acute pancreatitis events. So nominally, these two diseases, myocardial infarction and stroke, are the most important. And you see the same for remnant cholesterol. Here, I didn't put acute pancreatitis because we believe that it's the triglycerides that leads to acute pancreatitis, while it's likely the cholesterol content that leads to these diseases. Here's the distribution seen in my country, Denmark, but I'm sure it's the same in Brazil. What you can see is that for non-fasting triglycerides, it could also have been remnant cholesterol. It's a skewed distribution with a tail toward very high concentrations. Approximately 27% have plasma that look like this, high remnants or triglyceride lipoproteins, and only 1 in 1,000 have the very high triglyceride concentrations. Here's the shown a similar thing for men and women for triglycerides on the top, remnant cholesterol below. And you can see there's a tendency that more men have higher triglycerides and remnant cholesterol than women, simply because of men often have a higher body weight or higher BMI at an early age compared to women. The most important factor explaining why you have high remnant cholesterol and high triglycerides is body mass index. So this is from this Copenhagen study, 100,000 individuals. And here we just put into 10 different groups by body mass index. So this is the lowest body mass index. This is the highest body mass index. And the 5 green groups are within the normal range area. The orange are within the overweight area, and the red are within the obese area. So the higher the body mass index, the higher the remnant cholesterol in plasma. And R-square of 12% explaining that of all the variation in remnant cholesterol, 12% explained simply by body mass index. Another important thing here shown by Signe Hansen in a publication from 2019, that when plasma triglycerides goes up, then plasma C-reactive protein also goes up, and it's a pretty steep increase you can see here. So I interpret this as probably because you have triglyceride being degraded, you will liberate free fatty acid, and this is called local inflammation. In exactly the same people, when we look at LDL cholesterol shown here, the higher the LDL cholesterol, there's no increase in C-reactive protein. People thought that for a long time, but it is the remnant particles or triglyceride lipoproteins that lead to increased CRP. So Annette Warburg and I, in this review from the Lancet, we said that the most likely explanation is that while both LDL and remnants can come into the arterial wall, chylomicrons cannot, then lipoprotein lipase at the surface of remnants, either at the endothelial surface or within the arterial intima, lead to liberation of free fatty acid and monoacylglycerol that are toxic to tissue and will lead to inflammation locally. Also important, remnants can be taken up directly by macrophages to cause foam cells, while we know that LDL needs some sort of modification before they can be taken up into foam cells. So here again, a simplified cartoon. So when you have remnants, some would call them VLDL, then I think we should think of what could the triglycerides do, what can the cholesterol do? And the triglycerides, probably like when we have chylomicrons, here being degraded by lipoprotein lipase, liberating free fatty acids that wherever it's liberating can lead to inflammation. And if it so happens to be in the pancreas, acute pancreatitis. However, the cholesterol content is, unlike for chylomicrons, very important for remnants because they can be taken up by foam cells, and then because cholesterol cannot be degraded, it leads to foam cell formation, atherosclerosis, and then myocardial infarction. And then the interplay of atherosclerosis and the inflammatory component of degraded triglycerides is maybe what causes a myocardial infarction. Nobody knows this for sure, but this is what's in my mind, how I think it most likely is that here's the higher triglycerides. So we know that as triglycerides go up, the risk of acute pancreatitis just increases and increases. For myocardial infarction, at some stages, it tops and then goes down because then you only have these very large chylomicrons that can no longer come into the arterial wall, could cause atherosclerosis. But exactly if it's here, or if it's here, that it starts going down, nobody knows. We have not data to tell about that. Here's some very new data that was just published late 2020 in JACC. Balling is the first author from our group, where we tried to deduce, is it the cholesterol content or is it the triglyceride content of VLDL or remnants that is most likely the cause of myocardial infarction risk and thereby also atherosclerotic cardiovascular disease. What we can see here is this is in about 25,000 individuals from the Copenhagen studies having done metabolomics separation of all the different lipoprotein fractions. So as VLDL cholesterol goes up, the risk of myocardial infarction goes up. This is the risk, and here's the confidence interval, and this is the distribution of VLDL cholesterol in the population. However, when you look at the triglyceride contents of VLDL, it does go up maybe till 1 millimole per liter, but then it seems to level off, unlike cholesterol. For ideal cholesterol and for LDL cholesterol, it also increases sharply with more of that cholesterol in plasma. And then we did a so-called mediation analysis, which was surprising to us what it found. We tried to see what's the explained risk from all ApoB containing lipoproteins to myocardial infarction risk. So when we looked at all ApoB, how much that leads to myocardial infarction when elevated. And then in mediation analysis, 50% was explained by VLDL cholesterol and only 29% by ideal and LDL cholesterol and nothing by VLDL triglycerides. And here's another paper that just came out in Clinical Chemistry a month ago. Johansen is the first author here. And here we tried to look at what's the mediated excess risk of the association between BMI and risk of myocardial infarction. So in other words, of this extra risk of myocardial infarction you have when you are overweight and obese, how much can be explained by these different factors? So diabetes could explain about 9%. Elevated systolic blood pressure. We all know that when you get obese, you have higher blood pressure and diabetes, 17%. And then nothing was explained by LDL and IDL. But cholesterol in the large and small VLDL combined explained 40% of the excess risk of myocardial infarction in those with obesity and overweight. What to do treatment-wise? Well, when you have high remnants, of course, what you would want people to do is eat less and exercise more, so they go from being overweight and obese to being lean. But this is very difficult for the majority of our patients. If they have diabetes, of course, you will optimize the diabetes treatment. If they drink a lot of alcohol, there's a case for trying to reduce that. Otherwise, the advice is to use high-intensity statin. And now with the new REDUCE-IT trial, in some places, you can also offer icosapent ethyl or EPA. And then certainly we still have fibrates, and I'm still believing this is a very good option when you have high triglycerides, despite being on statins. So fish oils in general, you should not use because it's usually too low dose. And here's just a recent 2019 European Society of Cardiology, European Atherosclerosis Society guidelines published in 2020 in European Heart Journal by first author François Marc. What they say, what's the recommendation for drug treatment for patients with hypertriglyceridemia? Well, the first recommendation is statin treatment. It is recommended as the first drug of choice to reduce cardiovascular disease in high-risk patients with hypertriglyceridemia. It's a 1B. And then in some cases, some high-risk patients with triglyceride levels of between 1.5 and 5.6, despite statin treatment, you can use icosapent ethyl N-3 PUFA, highly purified. And then there's also some cases down here shown where you can use fenofibrate or bezafibrate. These are the different options. And then, of course, we have the new ongoing trials, triglyceride-lowering therapy to reduce major atherosclerotic cardiovascular events after statin therapy. The REDUCE-IT trial has already been published in 2019. I'll shortly show you the results. The STRENGTH trial has also been published in JAMA in 2020. I'll show you the results. And then there's the ongoing study, the PROMINENT trial, using a selective peroxide proliferator alpha modulator or SPARM alpha. It's called pemafibrate. This is 100% recruited, but we will only expect results in several years' time from now. So here the REDUCE-IT, which was a big surprise to many of us that the results were so clear. So this is a study where triglycerides was reduced 20%, CRP 40%, and LDL 7%. I should say this was the difference between the active oil and the placebo. The placebo or control oil was mineral oil. But you can see as a function up to 5 to 6 years of follow-up, what is the patients with an event, the primary endpoint being cardiovascular death, MI, stroke, coronary revascularization, or unstable angina. So 28.3% in the placebo control group, only 23% in icosapent ethyl. This is a relative reduction of 25%, absolute risk reduction of 5%, number needed to treat of only 21. And then came the big surprise, Nichols' paper published in JAMA in 2020. So essentially using quite similar omega-3 fatty acids. It's not only EPA, but there's a lot of EPA and also DHA. But here, the control oil was corn oil, which is, of course, different from mineral oil. And here's the primary endpoint. It was stopped for futility. So up to 54 months of randomization, there was absolutely no effect on the primary endpoint, the same one, the MACE endpoint. Finally, for the future, what we hope for is that drugs that influence the lipoprotein lipase pathway. So when we eat a lot of fat, we have chylomicrons, and also the liver will produce VLDL. When triglycerides is reduced, we have to come to the chylomicrons and IDL. And these, if both these are high or these are high, you'll have a lot of atherosclerosis early on in your life. But then there are some proteins that influence lipoprotein lipase. So apolipoprotein 5 or HBP1, they will make lipoprotein lipase work faster. But these three will block lipoprotein lipase, ApoC3, NGPTL4, and NGPTL3. So drugs are now being developed, particularly for ApoC3 and also for NGPTL3, that if you inhibit, you block these proteins, then lipoprotein lipase can work faster and make sure we have less of these in plasma and also less of these in plasma, leading to what we know from genetic evidence, less atherosclerosis because we have less remnants in plasma. So with that, this is my final slide, just summing up for the three lipoprotein classes, LDL, remnants, and LP little a. LDL when high, like in familial hypercholesterolemia, you get a lot of atherosclerosis, but probably a lot of stable atherosclerosis. But you can have a myocardial infarction, of course, or a stroke. But if you have remnants, you also seem to have inflammation more prone than when only high LDL. And this could lead to plaque rupture and thereby myocardial infarction or stroke. LP little a, we don't really know whether it's causing atherosclerosis, but I tend to see that it is also quite likely that indirectly could promote thrombosis. So if you have a plaque rupture here on the background of atherosclerosis, then indirectly LP little a, if high, will lead to more thrombosis and then myocardial infarction and stroke. Thank you very much for your attention.
Thank you, Borg, for the excellent and clarifying presentation. I'd like to ask just one question because we have not time, but I'd like to, how can we estimate the risk for patients in primary prevention with normal levels of LDL and increased levels of remnant and triglycerides? Because I know that we have a lot going on LDL, but triglycerides, to estimate the risk in this patient in primary prevention.
Yes, so far none of the risk calculators have incorporated triglyceride-rich lipoproteins, but certainly I hope for the future that some of them will do so. But you know, it takes time before you have the evidence, before it really comes in. And the reason, of course, being that there's been so little randomized trials showing that when you reduce triglyceride lipoproteins, so it'll probably be a few more years. But if you ask me personally, I just look at it. If they have high triglycerides and thereby calculate remnant cholesterol, I know from all the evidence they have huge risk of atherosclerotic cardiovascular disease, and then I just still offer triglyceride reduction.
But do you think, can you use other markers to help us in the clinical practice? You can use ApoB. I don't.
Yeah, you can use ApoB and non-HDL cholesterol. Of course, the problem there being that this is a composite of LDL and remnants and LP little a. So people tend to lose focus a little bit on the. So I think it's much better that you look at LDL by itself and then you look at the triglyceride-rich lipoproteins by itself, just high triglycerides. But you can also easily calculate remnant cholesterol. We do that in my lab in Copenhagen. All the patients that have a full lipid profile, they also get the remnant cholesterol.
Okay. Thank you, Borg, for the excellent presentation. And I'd like to invite Marcel for the next presentation, for the next group. Thank you very much, Borg.
Thank you so much, and I apologize once again for being late.
No, not a problem. Thank you.
Olá, boa tarde. Eu vou moderar a próxima sessão. Gostaria de agradecer novamente ao Dr. Chagas, ao Dr. Moretti, à doutora Fabiana pela organização, né, do evento. Estou aprendendo bastante e E a próxima sessão a gente vai ter 3 importantes professores que vão dar as próximas sessões, que são a doutora Cynthia Hilaire, da Universidade de Pittsburgh, e também do ATVB, né? Eu a conheci inicialmente no ATVB, da American Heart Association, e com quem eu trabalhei com ela no Early Career Development Committee, e também depois o Dr. Ibrahim Francisco Pinto, né, um ícone da nossa cardiologia, também um expert na área de imagem em cardiologia e métodos complementares, e depois o professor Francisco Laurindo, que é também um meu mentor, né, fiz doutorado com ele, ele me ensinou muito, né, tanto em termos científicos quanto também é o meu mentor para sempre, assim como o professor Chagas e também o Dr. Protásio, né? So I would like to invite Dr. Cynthia Hilaire from University of Pittsburgh. She works there as assistant professor in VMI, Vascular Medicine Institute from Pittsburgh, and it's a pleasure to have you here with us. And as I spoke in Portuguese, you are my friend from the early committee, career committee from the ATVB, which I learned a lot there, and also it brings my career to another level also, and it's a pleasure to have you here. Thank you very much.
Well, thank you so much for the invitation. I'm going to try to share my screen now. Application window. Can you all see that?
Not yet.
Not yet? Okay. You can't see that. Okay. Let's try again. Let's try this. Okay. How about that?
Yes, that's perfect.
Okay.
But it's not it's not in the presentation mode yet.
How about now?
No, it's perfect.
Okay.
Yes.
Great. Well, I'm going to switch gears a little bit. First off, thank you so much for the invitation. It's really an honor to be invited. And you know, Marcel, it's especially by you, my old friend from ATVB. So I'm switching gears a little bit, and I'm going to be talking not so much about intimal calcification, which is related to atherosclerosis, but medial layer calcification, which is present in a whole host of disease states: diabetes, renal disease, general aging. And there's many different factors, you know, similar to atherosclerosis, there's many different factors that can regulate medial layer vascular calcification. And the one I'm really going to focus on today is a genetic cause. And by telling this story, and it really is a story, and it's a still evolving story, that it actually started during my postdoctoral fellowship at the National Institutes of Health back in 2010 or so. We started this project, and it's really in collaboration, which is a group called the Undiagnosed Disease Network. At the time when we started, it was a beta project, and the whole goal was to try to recruit patients with unknown disease causes and identify the genetic cause and hope to translate that to more common disease pathologies. And the story I'm going to tell you is the first disease that was discovered by what was then called the Undiagnosed Disease Program, but now it's a national program. It's called the Undiagnosed Disease Network. And so this is an x-ray of, you know, a normal healthy knee. This is hopefully what all of our knees look like. This is an x-ray of a knee of a family of patients who came to the Undiagnosed Disease Program. And what you can see is extensive calcification. This is in the femoral popliteal artery. And you can also see tortuosity. One of the patients actually had a vein graft procedure done. And you can see here that the calcification is protruding into the lumen, and you can see the vascular smooth muscle layer it's hyperproliferative, it's dysplastic, there's the infiltration of immune cells, but there's no atherosclerosis. And this is just kind of a video. I hope Yes, it's going to play. You can see here the calcification actually starts in the iliac and moves down into the femoral arteries. It picks up again behind the knee, and as this is turning, you can actually see one of the ankles right there. You can see calcification, and the angiography here, you can appreciate there's an extensive network of collaterals that have formed, and that's because this disease is rather slow progressing. The patients, when we saw them, were in their 50s, early 60s, but they were starting to get claudication pain in their 20s and 30s, and that's because the calcification was starting to grow such that it was occluding the lumen. And so this is the family that came to the NIH. It's crazy that we had all 5 patients affected, but you know, it allowed us to do very powerful genetic analysis. And so using heterozygosity mapping, just with kind of basic classical genetic SNP analysis, we identified one region that all 5 of these patients shared, that they were they had lost their heterozygosity state, and the parents remained heterozygous. And this was a 92 gene, a region that encompassed 92 genes. And doing kind of classical sequencing analysis, we found that this family and then 2 other families, unrelated families, all had mutations in a gene called NT5E. And I'll tell you about that gene in 1 second. We also were able to use in vitro disease modeling, kind of following after what Goldstein and Brown did with their original studies of familial hypercholesterolemia, where they took patient dermal fibroblasts. We also collected dermal fibroblasts from these patients and looked at gene expression at baseline and saw that this gene NT5E was very reduced in these patients, and also there was no protein. So what's CD73? CD73 is an extracellular enzyme. It's on the surface of many cells, highly expressed on vascular cells, both endothelial and smooth muscle cells, and it's also highly expressed on immune cells. And what it does is it takes extracellular AMP and converts it to adenosine and inorganic phosphate. Adenosine is then a very potent signaling molecule. It functions by binding to one of the 4 adenosine receptors. And these receptors modulate inflammation, processes like inflammation, proliferation, migration, apoptosis, all sorts of stress responses. And that's because AMP is only released, is only derived from ATP, which is only derived when a cell is under stress. A cell does not want to release its ATP, it wants to use it for energy. So when ATP is released and rapidly converts to adenosine, it's normally in response to a stressful event. But in these patients, they don't have CD73 activity, so they're not converting AMP into adenosine. They're not getting that adenosine receptor signaling, and the phenotype they present is this medial layer vascular calcification that's localized to the lower extremities. So like I said, we were able to collect cells from these patients, and using kind of a classical, it's called an osteogenic assay, we're able to cause these cells to calcify in a dish. And that's what you can see with this red stain here. So alizarin red stains hydroxyapatite or any kind of calcium-based crystal red. And you can see that in a dish, we can induce these cells to calcify. When we rescue it by introducing back CD73 in the wild type form, that calcification doesn't happen. And we can also see that if we add back adenosine, the product of CD73 activity, we can drastically reduce the calcification phenotype. And importantly, if we inhibit an enzyme called TNAP, which is alkaline phosphatase, which is needed for kind of any sort of ectopic calcification, we can also reduce the calcification processes. So these studies were indicating that it's an active, or rather a loss of a signaling pathway that is needed to actively repress calcification. And one of the more complicating things of this disease that we named ACDC, for arterial calcification due to deficiency of CD73, is that the mice and the humans aren't very similar. Knockout CD73 mice have been known about for decades. None of them presented with calcification. And I tried for years of my postdoc to try to get these mice to recapitulate, but they just didn't. And so what we did was we made induced pluripotent stem cells from these dermal fibroblasts we collected. And one of the key assays in confirming that your cell, your iPS cell, is really and truly pluripotent is to do a teratoma assay. So you can inject these stem cells into a immunocompromised mouse, and they will form nice teratomas. But the ACDC teratomas had all these little precipitations of calcification. When I actually would cut the teratomas, they were quite crunchy. And we could quantify this with micro CT analysis, and you can see there is a significant increase in the production of calcification in these ACDC teratomas. And we were actually able to section them and do some staining to determine that it really is bone-like substances. You can see here, you know, what is indicative of osteocytes, where you have this little halo around this bone-forming area. It stains for von Casa, alizarin red, but importantly, it stains for cellular markers of osteogenesis. So ostrix is a key transcription factor that's needed for the promotion of osteogenic genes. Same with osteopontin, and similar to what we saw in the dermal fibroblasts, TNAP, or alkaline phosphatase, is also localized to these areas of calcification. And a separate patient also was able to provide some vascular kind of scrapings. It was from a procedure that they were trying to increase blood flow to the lower extremities. And looking at this pathological sample, you can see there's extensive calcification all over. This is kind of, if you cut the vessel open and lay it flat, this is on the kind of a cross section of it. You can see alizarin red staining and von Casa staining positive, and you can also, similar to the iPS cells and similar to the dermal fibroblasts, see that alkaline phosphatase is co-localizing to these areas of calcification. Importantly, you know, this is a rare disease in a patient group that is suffering from low extremity, lack of perfusion to the lower extremities. And part of the goal of enrolling these patients into the undiagnosed disease program is A, to try to figure out the mechanism and identify what's happening in them, but B, to leverage what we can learn to start to make therapies. And we wanted to test if this iPS cell-based model could be used as a drug screen. And in fact, we found that it can. So when we injected these patient-specific iPS cells into a mouse, we could get very heavy calcification that you can see here by micro CT. And then we tested all 4 adenosine receptor agonists. And we did this by injecting the teratomas into the, injecting the cells into the mice, letting the teratomas grow for approximately 2 to 3 weeks, and then started injecting the mice with the agonists twice a week for the duration of the growth of the teratoma, which was till it was about 2 centimeters in diameter, which usually took about 6 to 8 weeks. So it was approximately 60 to 70% of the time the teratoma was in the mouse, it was being treated with either vehicle or treatment group. And we found that stimulation of the A2B adenosine receptor prevented calcification. So that's indicating that this increase in alkaline phosphatase is perhaps due to a lack of adenosine receptor signaling. And so that's the working hypothesis we started to come up with, and that is normal CD73 signaling allows for normal vascular homeostasis, because adenosine, when produced after a stressful event, can help the cells respond and compensate for that stress. But in our patient samples, in our patients themselves, they're not able to take this bolus of AMP and produce adenosine to elicit this signaling cascade that can help to keep alkaline phosphatase at bay. Whoops. Which is a great start, but it still doesn't help us to answer the questions of what's happening in these patients and how can we start to target this. We know that we're not able to just target the adenosine receptors by injecting adenosine. You know, that's what you do to kind of get someone, their heart pumping again. It's very nonspecific because these adenosine receptors are everywhere. We also can't target TNAP itself because that's actually been tried previously, but it has too many adverse effects. The drug levamisole is no longer in use. And so really we wanted to switch to start to focus on the mechanisms that are driving calcifications in the absence of CD73 and see if we could turn this into what's happening in more common rare disease pathologies. So we went back to the dermal fibroblast model and just started doing kind of stepwise experiments to walk down the pathway and see what was happening. And we know that when we expose either control or a CD73 deficient cells to an excess of AMP, the control cells make a robust burst of cyclic AMP, but the CD73 cells do not. And you can see this biochemically, where we have control cells that readily express CD73, but our mutant patients do not. And when we give AMP to a control cell, it will make this cyclic AMP and stimulate VASP and other molecules in the pathways downstream of cyclic AMP. But that doesn't happen in our patient samples. What happens instead, though, is a compensatory activation of AKT signaling. And you can see that at AKT on the tyrosine 308 and also on the serine 473. And you can see in a control cell that's not happening. And this is just the quantification here. And importantly, if we pre-treat these cells with chemicals that prevent the degradation of cyclic AMP, IBMX, and also directly stimulate adenylyl cyclase to independent of receptor activity to pump out cyclic AMP, we can see that we can reverse this phenotype. And when we give excess AMP, these cells now show activation or stimulation of VASP, phosphorylation of VASP, and the AKT stimulation, phosphorylation reduces, and that's all quantified here. So that's indicating there's a shift in the balance, like a dial. And so when we don't have CD73, when there's a stress that the cell needs to respond to, instead of going down a cyclic AMP-mediated pathway, an AKT pathway is getting activated instead. And we wanted to start to figure out what is happening downstream of that AKT activation. And so we started to go down an in situ way, in situ pathway, by just looking at the promoter of alkaline phosphatase, this key enzyme that's needed for calcification. And we just did a screen of the first 1,000 base pairs upstream of the transcriptional start site. And we were looking for putative transcription factor binding sites that were high in number, but also had very high homology for actually binding a transcription factor protein. And we found that FOXO1 transcription factor binding sites were the highest number in the ALK-Phos promoter. So I think there were 11 sites when we went out to a couple thousand, but they also had the highest homology. And you can see here, just in this percent nucleotide position frequency, almost every site is well above 90%. And this one, which is 50-50 putative binding, is kind of the wiggle room. So we decided to focus on FOXO1 signaling and start to see if this was what was causing our disease, our compensatory phenotype. And so taking these cells again in our in vitro disease model, we could expose both control and CD73 deficient dermal fibroblasts to excess AMP. And when we did that, this is just a short 2-hour assay, we could see that after 2 hours in a patient cell, we get very specific nuclear localization of FOXO1 that does not happen in a control patient. When we pre-treat the patient's cells with a stable form of cyclic AMP and expose them to AMP, this nuclear localization does not happen. And also when we pre-treat these cells with an A2A or an A2B receptor agonist and then give AMP, we don't get this nuclear localization. So this is indicating that without CD73, without adenosine receptor signaling, in an excess of AMP, we're actually getting FOXO1 localizing to the nucleus. So we wanted to see if FOXO1 itself could be targeted as means to prevent calcification. So this is a short 5-day assay where we put our cells in a dish and measure the activity of alkaline phosphatase. So this purple precipitate happens when alkaline phosphatase is active. And if we treat our cells every other day with a FOXO1 inhibitor, we prevent alkaline phosphatase activity. And when we pull this out to the 21-day in vitro disease calcification assay, we can see that when we treat our cells with the FOXO1 inhibitor, we pretty much prevent calcification in vitro. And so we really now wanted to make sure that it was acting on the promoter of ALK-Phos and not through some secondary or tertiary event, because again, these are long-term assays, 5 days and 21 days. So FOXO1 could be doing a lot of different things. And so what we did was we mutated this FOXO1 binding site in the ALK-Phos promoter. We took the Gs and converted them into As on a plasmid, and we could see by a luciferase assay that just with these 2 base pair mutations, we could significantly, almost 60%, reduce promoter activity of alkaline phosphatase in vitro. This is all really exciting. This is now focusing in on what's happening mechanistically to this rare disease population. However, there's only about 25 ACDC patients in the world that have these mutations in CD73. So, you know, our goal and the underlying objective of the Undiagnosed Disease Network is to take what we can learn from a rare disease and apply it to a more common disease state. And so we partnered with some colleagues at the University of Nebraska Medical Center because they had recently published a study that looked at the biomechanics of calcification on the femoral popliteal arteries. And so what you can see is a cross-section of the different vessels, the different types of vessels with the different levels of calcification that they had obtained and used in their studies. And so we collected from them vessels from adults, so these are all adults in their 40s and up that had 0 calcification, and ones that had kind of this heavy to severe forms of calcification. We were specific in that we wanted vessels that had pronounced calcification, but still also had other portions that appeared somewhat normal, kind of not a perfectly circumferential calcification, as you can see all the way to the right there. And so what we did is we then performed serial section staining on vessels from these control, and we had an N of 7 control, and we had, I think, 12 calcified. And we could see that in these control tissues, in the medial layer, we could see pronounced CD73 staining. And in calcified vessels, CD73 was not present in the close proximity of the calcification, nor was it present in a more healthy looking area that did not have robust staining for calcification. So CD73 was not present at all in any of the calcified vessels. However, FOXO1 was. You can see FOXO1 staining in very close proximity to the calcified area of calcified vessels. This FOXO1 staining was not present in control tissue, and importantly, it was not present in the non-calcified areas from the same vessel. This is also similar. This is also a similar pattern that we saw with alkaline phosphatase. So again, alkaline phosphatase was in very close proximity to the calcified area. It was not present in the control tissue, and it was not present in the non-calcified areas of the calcified vessels. And so this was very exciting for us because it's really starting now to dig into the mechanism by which a lack of adenosine signaling is driving medial layer calcification. And so we've now really solidified that it's through the A2B adenosine receptor signaling pathway, and we don't get and when we don't have adenosine receptor signaling, we see an increase in alkaline phosphatase activity, and this protein is needed for the transition of a healthy cell into a calcifying cell. Alkaline phosphatase itself is upregulated by FOXO1, and most importantly, we are now able to take this pathway of this rare disease and apply it to a more common disease state, which is great for the biochemist and it's great for the PhD scientist, but it's not great for the patient and their physician, because right now there's really no therapy that's FOXO1 based that we can give for vessel tissues. And so we went back and looked at other rare monogenetic diseases that result in peripheral artery calcification. And when you look at the spectrum of them, they all are related to ATP metabolism. Whoa. ATP metabolism. So on one side of the screen here, we have a disease called idiopathic basal ganglia calcification, or FARS disease. This happens due to mutations in PIT1 or PDGFR receptor beta. And this is a vessel in the basal ganglia area of the vein that is presenting with extensive calcification. And these patients actually go on to develop Parkinsonian-like symptoms. In the middle here, we have our disease, ACDC, so deficiency of CD73, and we've now determined that it's a lack of adenosine signaling that is resulting in this pathology. And then just upstream from that are two proteins, ABCC6 and EMPP1. And mutations in EMPP1 result in a disease called generalized arterial calcification of infancy, or GACI. And in this disease, it's a really horrific and advanced disease state, in that even in utero, affected babies will develop aortic calcification that you can actually see, on imaging modalities. And without treatment, they die within 3 months of birth. And mutations in EMPP1 prevent the conversion of ATP into pyrophosphate, which itself is an endogenous inhibitor of calcification, and it prevents the formation of AMP, which normally would help to stimulate and produce adenosine signaling to help also respond to those pathways that drive calcification. So thinking about pyrophosphate, this group, there we go, led by Munz and colleagues, decided to try and treat a GACI patient with bisphosphonates. And a bisphosphonate is more commonly used in osteoporosis, but this group, noticed that bisphosphonates are very chemically similar to pyrophosphate, which is absent in these patients. And they actually treated a patient from the moment of birth with bisphosphonates till about 3 months of age in this initial study, and they were able to completely resolve the arterial calcification that otherwise would have killed this patient. They've actually gone on to do follow-up studies. This initial study was in 2009. They've actually gone on to do follow-up studies where these patients will have a complete resolution or absence of progression. Many of them are now in their teens and 20s, and their only real risk is rickets, because obviously you're blocking calcification from forming. So we wanted to take this and see if we could apply it to our ACDC patients. And using the in vivo teratoma model, when we injected ACDC iPS cells and didn't treat them, we would get robust calcification. But when we treated the mice with 30 milligram per kilogram 3 times a week of etidronate, we could practically resolve or prevent the calcification. And so from these and a couple other in vitro studies, we were able to develop an open label, non-randomized single arm pilot study to see if we could use bisphosphonate to treat ACDC patients. And so these patients, we were able to enroll only 6 of them, so they were all serving as their own control. But we gave them etidronate, similar dosing to the mouse, 20 milligram per kilogram. The mice had a little bit more at 30 milligram per kilogram. But we gave the patients bisphosphonate for 2 weeks, followed by 10 weeks off and then 2 weeks on. And this has been going on for several years now. The study is still ongoing. Some of them have finished. The results are not clear. It's hard to tell because there's only an N of 6. But the last I spoke with the clinical arm of this group led by Manfred Bohm, 2 of them seem to improve. 2 of them seem to kind of stay the same, and 2 of them actually seem to get worse. So it's a little inconclusive right now. But to sum up, I feel like I went a little fast here, but that might be okay. To sum up, we've now really tried to work out why a lack of CD73 leads to calcification. we've seen that it's because there's a decrease in cyclic AMP signaling, there's an increase in AKT signaling, and this shift in the balance is leading to nuclear localization of FOXO1 on the alkaline phosphatase gene promoter, and that's upregulating ALK-Phos, which is helping to promote the calcification. And so we still have a lot of questions. Probably the biggest one is, why just the lower extremities? Why is this not happening in the carotids, in the coronaries, or in the aorta itself? We don't have an exact answer yet, but part of what our lab is working towards now is asking, is this having to do with the developmental origins? You know, so the different developmental beds, the different vascular beds are of different developmental origins. So is there sort of an epigenetic imprint on, say, the lower extremity vessels that primes them to more readily calcify that perhaps maybe isn't there on a different vessel? And so hopefully our future studies will help to answer that. And so this is obviously a team effort. This is us now in the COVID era, but really this work was started during my postdoc with my mentor Manfred Bohm, and also under the direction of the UDP program at NIH. And it's been an amazing journey, and we're really excited to continue it. So I want to thank you again for the opportunity, and hopefully I can get back to the share screen. Did that close out okay?
Thank you very much, Cindy, for your presentation. It was great. I have one question. If you navigate from bench to bedside, so if you see the mechanisms of the ACDC diseases and the investigation that you already performed, what can you send to the medial calcification of, for example, of peripheral artery disease patients because of diabetes or atherosclerosis that develop in the elderly, for example?
Yeah, so actually one of the things we're working on now is just that. So we're trying to do some in vitro studies that are modulating kind of the pathways associated with insulin intolerance, also looking at mineral imbalances and seeing if those actually modulate CD73 or the adenosine receptor activity specifically. And one of the other things we're interested in too is, you know, perhaps the adenosine receptor expression in the different vascular beds is different. So we don't have the answer yet, but that's where we're going in the future, because we're hoping to really try to nail down why, you know, a diabetic patient would form this versus just, you know, atherosclerosis in the peripheral system. So.
Okay, thank you. Thank you very much. So I will skip to follow the next speaker because of time. E eu vou apresentar agora o Dr. Ibrahim, que vai nos brindar com a próxima palestra. Por favor, Dr. Ibrahim.
Que eu achei que eu tinha sido convidado por engano, mas vou tentar não deixar o nível do evento cair muito nos próximos minutos para falar de cálcio, aterosclerose e tomografia. Eu gosto sempre de começar as minhas apresentações lembrando que eu tenho um grande conflito de interesse, que é o fato que ressonância e tomografia é o que eu faço no meu dia a dia. Então, eu gosto de avisar isso para as pessoas lembrarem de poder colocar algum filtro nas coisas que eu vou falar, uma vez que eu posso me entusiasmar com as coisas que a gente tem para mostrar. Mas eu vejo os métodos diagnósticos na cardiologia, na medicina, na cardiologia em particular, quando nós estamos falando de doença aterosclerótica, meio como um trabalho de detetive ao contrário. O detetive sabe do crime que aconteceu, vai juntando pistas, vai juntando informações e tenta chegar no culpado. Nós somos o contrário, nós sabemos quem é o culpado, nós sabemos que existe a doença aterosclerótica. O que nós tentamos descobrir é quem é o crime. E, na verdade, nós tentamos ir um pouco além, evitar que esse crime aconteça, sendo o crime as complicações, os chamados eventos adversos. E, por um lado, é preciso generalizar, e como agente de saúde pública, todos temos que fazer isso. Mas, por outro, é muito importante que a gente identifique cada paciente e trate de uma maneira correta. E é aí que eu acho que os métodos diagnósticos entram. Porque se nós falamos de população, Então, as medidas gerais de doença e estilo de vida, a luta para tentar fazer as pessoas adotarem um estilo de vida mais saudável, funciona bem. Mas o nosso trabalho no consultório é tentar indicar daquela multidão, daquele grupo de pessoas que nos procura, quem é que tem mais ou menos chance de evoluir com um evento adverso. Nós tentamos descobrir quem tem mais chance de evoluir com infarto, quem tem mais chance de ter morte por causa cardíaca e melhorar, fundamentalmente, a qualidade de vida das pessoas. E eu acho que os métodos diagnósticos entram muito aqui, em tentar mostrar quem é doente, tentar mostrar quem ainda não é doente, para que a gente possa modificar a história natural da aterosclerose quando ela existe e proporcionar uma melhor qualidade de vida para as pessoas. E para isso eu vou falar de exames anatômicos. Por que exames anatômicos? Exames anatômicos, no caso, pode ser o cateterismo, ultrassom intracoronário, tomografia por vigilância óptica. Eu vou falar aqui da tomografia computadorizada, porque os exames anatômicos vão revelar exatamente a estrutura dos órgãos que nós estamos estudando. No nosso caso, coração, artérias coronárias, eventualmente carótidas ou outras artérias do corpo. E nós vamos identificar quais as artérias que já têm e que não têm manifestação de doença. Esse é o princípio pelo qual se usam métodos como tomografia para tentar identificar um marcador da doença e, a partir daí, estabelecer risco de pessoas. Serve, portanto, a tomografia e outros exames como um farol que guia o médico para o local mais seguro, ou, na verdade, ajuda o médico a conduzir o paciente para um porto mais seguro e evitar complicações relacionadas à aterosclerose. Eu disse um marcador de doença porque a ideia de buscar o cálcio é que o cálcio está presente, como todos sabem, em praticamente todas as fases de evolução da placa. E a partir de um determinado momento, ele está presente numa quantidade que permite que os métodos de imagem o identifiquem. Isso é uma coisa importante. Muitas vezes nós podemos não identificar, tem quantidades muito pequenas, e nós vamos chegar a limitações do método mais para frente, mas já de cara eu quero lembrar, o cálcio precisa estar presente numa certa quantidade para que o método identifique e possa dar o sinal de alerta. Olha, isso aqui é doença. Também é importante que nós não confundamos com outras coisas que podem aumentar muito a atenuação por raio-x. Então, esses são aspectos relevantes da pesquisa da doença aterosclerótica. E o que nós vamos fazer, o raciocínio é, se existe cálcio, existe placa, portanto existe doença. Se não existe cálcio, não existe placa, portanto não existe doença aterosclerótica. E isso entra naquela ideia, daquele quadro que eu mostrei há pouco, de permitir personalizar tanto o fluxo diagnóstico, como principalmente o manejo desses pacientes. Personalizar o esquema terapêutico para cada caso, escolher melhor a forma de tratar. Infelizmente, o cálcio, nós vamos abordar isso mais para frente, ele não faz o outro passo que seria interessante, que é monitorar se esse tratamento vai bem ou não. Para isso ele não serve. Temos outras coisas, nós temos vários marcadores sendo discutidos na manhã de hoje, e o cálcio não vai entrar aqui. O cálcio, como nós podemos aplicar na prática hoje, ele é visto a partir da tomografia, um exame que eu tento mais ou menos reproduzir como funciona aqui. Ele é um tubo de raio-x que gira rapidamente, muito rapidamente ao redor do paciente, envia esse raio-x para um conjunto de detectores que está situado na extremidade oposta do aparelho. E como algumas coisas seguram o raio-x de uma maneira particular, nós podemos, a partir da forma como esse raio-x é atenuado, segura, né? Ele não deixa o raio-x passar, a gente chama isso de atenuação. Eu posso, a partir daí, reproduzir, olha, é um tipo de material, é outro. Isso eu faço melhor para a ressonância, mas eu posso fazer para a tomografia para algumas coisas. Uma delas é o cálcio. O cálcio segura muito o raio-x, ele mostra muito facilmente onde ele está presente. Desde, repito, que esteja presente acima de uma determinada quantidade. Então, se eu olho para o raio-x e vejo aquela mancha branca, eu sei que ali tem cálcio. Pode ser normal, como um osso, mas pode ser anormal quando ele está presente, por exemplo, na produção de uma artéria, no caso das artérias coronárias. Eu tenho que fazer esse exame de uma maneira padronizada. Nós estamos hoje tentando evoluir para formas usando inteligência artificial, de fazer essa captação de imagens, mesmo de tomografias mais simples, para chegar no score, mas, por enquanto, para criar um score que dê uma informação útil para quem pediu o exame e que está associado com resultados de trabalhos, como nós veremos ao longo da nossa conversa, tem que fazer cortes padronizados em algumas máquinas de 2,5 mm, em outras de 3, mas tem que ser padronizados. Mas eu quero lembrar que exatamente, é por isso que eu estou mostrando essa figura que gira o tubo de raio-x ao redor do paciente, que a tomografia, ela reflete a presença de cálcio e ela não consegue fazer, por exemplo, nós acabamos de ver uma brilhante apresentação sobre cálcio presente na média, pela tomografia eu não consigo saber exatamente onde está esse cálcio, porque como essa imagem inferior aqui direita, logo acima dessa carta de texto mostra, o cálcio fica meio borrado na tomografia. Como esse raio-x vem de diferentes direções, ele expande um pouquinho, o cálcio é artefato meio brilhante, e eu tenho uma ideia que o cálcio está lá, e por isso que eu preciso do score. Porque eu não consigo dizer exatamente, olha, esse cálcio é tanto, exatamente em tantos milímetros cúbicos, está localizado exatamente nessa camada de células. Mas eu sei que ele existe. Eu crio um score a partir da quantidade que nós associamos com a evolução desfavorável. Isso é importante para que nós não superestimemos a informação que nós podemos obter a partir daí. Quanto mais cálcio eu tenho, mais eu me distancio da realidade, porque mais artefatos de atenuação eu tenho. E o cálcio pode estar presente, veja essa imagem do meio inferior aqui, o cálcio pode estar presente também em componentes não calcificados. Isso é importante. Não quer dizer que eu tenho cálcio numa placa que ela seja só calcificada. Eu posso ter outras coisas além do cálcio. E, na verdade, à medida que esse cálcio aumenta a presença de placas, aumenta a chance de ter placas também não calcificadas. Isso é um conceito relevante. O cálcio não é um retrato fiel da aterosclerose, mas ele é um marcador de que ela existe. Se tem cálcio, tem aterosclerose. Um raciocínio meio simples, até pessoas como eu conseguem fazer. E a partir daí, eu vou estabelecendo que placa tem. Isso não quer dizer, e até tem gente tentando trabalhar nisso, eu vou mostrar alguma coisa no final da nossa conversa, não quer dizer que seja um ateroma de capa fina, não quer dizer que seja um ateroma mais grosseiro, não quer dizer que seja uma doença muito localizada, mas simplesmente quer dizer que essa doença existe e que ele não é um marcador de estabilidade. Não é porque eu tenho cálcio que eu consigo excluir que aquela placa possa instabilizar. Ele é um dos componentes da placa e não certifica que uma placa calcificada seja estável. Então, isso é importante que se saiba. Ele marca o risco. Então, cálcio tem mais risco. Que nós sabemos, partindo agora para as aplicações clínicas, há muito tempo. São trabalhos que têm alguns mais de 20 anos, da época de uma tecnologia que, por exemplo, esse trabalho do Dr. Paulo Prado usava, que era a tomografia por emissão de feixe de elétrons. Ele tinha a vantagem de que ela era muito rápida, usava uma baixa dose de radiação, mas tinha uma definição pobre, por isso que ela passou a ser utilizada, e já mostravam trabalhos antigos usando essa tecnologia, que tem muito cálcio pela tomografia evolui pior do que quem tem pouco cálcio, independentemente de outros fatores de risco, como nós veremos a seguir. Então, em 5 anos de evolução, o cálcio vem se mostrando sistematicamente um preditor de risco. E quando ausente, ele indica boa evolução até para o diabético. Isso é uma coisa interessante. Claro que à medida que nós vamos olhando esse dado com um pouco mais de carinho, peço desculpas, são trabalhos antigos, mas foram aqueles que solidificaram o cálcio como um marcador importante de risco cardiovascular. À medida que nós fomos olhando, nós vimos algumas coisas que vão mostrando quem se beneficia realmente da utilização desse índice na prática. Vamos começar pela coluna mais à direita, os pacientes de alto risco. Vejo que mesmo quem tem, nos pacientes de alto risco, quem tem ausência de cálcio evolui melhor do que aqueles que têm muito cálcio. Mas ninguém vai deixar de tratar um paciente de alto risco porque ele não tem cálcio. Na verdade, se nós compararmos com as outras duas colunas, nós veremos que quem tem pouco cálcio ou cálcio desprezível nessa coluna de alto risco, teve eventos superponíveis àqueles que tinham cálcio mais elevado, que se apresentavam baixo risco e risco intermediário. A lição que eu gosto de tirar desse trabalho, já bem antigo, mas que acompanhou uma amostra muito grande, de quase 10.400 pacientes, é que pessoas com baixo risco e risco intermediário, que têm cálcio elevado, merecem uma atenção especial. Esses sim se comportam como pacientes de alto risco que têm cálcio mais baixo. Isso já indica para a gente que paciente nós estamos falando. Mas também é importante lembrar que o cálcio é útil na prática clínica porque ele modifica informações que nós pudéssemos ter. O que eu estou querendo dizer com isso? Esse estudo de 2012 do grupo do Dr. Nazir mostra que, vejam aqui a coluna da direita, nesse quadro inferior à esquerda, as duas colunas da esquerda, perdão, de nenhum fator de risco e de um só fator de risco, nós tínhamos pacientes aqui que tinham cálcio elevado. Não só cálcio até 100, mas cálcio acima de 100. E já nós temos pacientes com 2 fatores de risco ou mais, que estão aqui na faixa verde de ausência de calcificação. Então, isso que faz com que um exame seja útil na prática, quando ele traz alguma informação que modifica a minha impressão clínica. No caso, ele está presente em quem muitas vezes eu não esperava que estivesse, e pode estar ausente naquele paciente que eu esperava que pudesse ter. E, independentemente dos fatores de risco, a evolução desses pacientes, como mostram os gráficos à direita, são pior a evolução desses pacientes, quanto mais cálcio eles têm, independentemente do número de fatores de risco que eles podem ter. Então, o cálcio modifica a nossa expectativa clínica, mas, de novo, principalmente naqueles pacientes de risco baixo e intermediário. Nesses casos, esse é um outro trabalho clássico do grupo Chang, em 2015, que comparou o score de cálcio a índice tornozelo-braço, até o ultrassom de carótida, na época foi medida da espessura média intimal, não foi ultrassom 3D, e o cálcio é essa curva que tem a melhor relação, a melhor área sobre a curva, essa linha verde mais à esquerda. E isso mostra que, mesmo num cenário clínico, onde todas as variáveis são consideradas, em pacientes assintomáticos de risco pré-teste baixo e intermediário, o cálcio nos auxilia a refinar a estratificação de risco. E pode chamar a atenção da gente, assim, o fato, então o cálcio deve ser para gente jovem também, você está falando muito de risco baixo e intermediário, nos idosos, isso não tem utilidade, porque todo mundo tem mais cálcio conforme envelhece. Pois é, parece que isso não é bem verdade. O cálcio ele pode ser utilizado, e nesse slide no próximo vou mostrar, como um relógio biológico. Ele pode mostrar como nós estamos envelhecendo, ou pelo menos como as nossas artérias estão envelhecendo, e até refletir a qualidade com que nós envelhecemos. Vejam que existem indivíduos mais velhos que podem ter cálcio zero. No meu dia a dia eu vejo isso. Às vezes eu vejo pacientes com 70 anos, 80 anos que têm score de cálcio zero, têm artérias jovens, e pacientes mais jovens que têm artérias mais idosas. Tem até quem coloque isso no laudo. Existe uma ferramenta na internet que dá para calcular a idade arterial. Eu não gosto muito de colocar, porque imagine você com 40 anos receber um laudo que diz que suas artérias têm 90 anos e você não é médico. Não entende bem o que é isso, pode dar um impacto negativo. Mas, de qualquer maneira, o cálcio reflete o envelhecimento vascular. E talvez não só o vascular, mas também a maneira como nós envelhecemos. Esse subestudo do MESA, que todos conhecem, um trabalho bastante importante, um registro bastante importante, ele analisou a presença de cálcio elevado e outras comorbidades, outras doenças. E veja que as pessoas que tinham cálcio elevado na velhice tendiam a ter mais doença renal crônica, tendiam a ter mais pneumonia, tendiam a ter mais doença pulmonar obstrutiva crônica e mais fraturas de quadril. Nós vimos hoje, por exemplo, na apresentação do Dr. Peter Lieb e em outras, a associação que existe de processo inflamatório e doença cardiovascular. Então, o cálcio, na verdade, pode ser um indicador de como nós envelhecemos e alertar a nós como médicos para fazer que os pacientes tenham um envelhecimento mais saudável e um envelhecimento e não um envelhecimento menos saudável. Todo mundo que tiver sorte envelhece. Todo mundo, infelizmente, morre. Mas o melhor é que nós possamos viver o tempo que nós temos aqui com a melhor qualidade possível. Talvez o cálcio nos indique que nós estamos diante de um indivíduo mais frágil, que merece mais cuidados, porque ele está mais sujeito a apresentar adversidades, a apresentar eventos adversos. Então, ter cálcio é ruim, e como nós acabamos de ver também, em qualquer artéria do corpo, o cálcio é ruim e se associa sempre com alguma coisa desfavorável. Por exemplo, quem tem muita calcificação na aorta pode ter mais presença de hipertensão. E ele vai além dos exames funcionais. E é por isso que nós batemos muito na tecla. Quem faz exame, como eu que faço funcional anatômico, está mais à vontade para falar sobre isso, mas é por isso que nós falamos muito de exames anatômicos nessa situação. Essa tosse do Dr. Rafael William, que nós tivemos o privilégio de poder orientar, que ele fez testes de cintilografia e score de cálcio em 177 pacientes. E o que nós vimos é que existiam pacientes com cálcio elevado que podiam não ter isquemia ou não. Nós vamos voltar a isso mais para frente. Mas isquemia sem cálcio é um achado absolutamente excepcional. E que a evolução desses pacientes se associava muito com deposição de cálcio. Isso tem uma explicação, eu vou chegar para ela mais para frente, mas tem alguns que dizem que talvez seja verdade até em diabéticos. E que diabéticos com pouco cálcio estariam livres, com ausência de cálcio, na verdade, estariam livres de eventos por um período mais longo de evolução. Dizem 10 anos, alguns estudos dizem diabéticos 5 anos, eu não tenho certeza desses números tão bons assim, mas eu prefiro pensar em não diabéticos, ter segurança por 5 anos de baixo evento. Em diabéticos a gente precisa acompanhar de perto, mas de qualquer maneira é um paciente que talvez eu não precise olhar toda semana, um paciente que eu posso ficar um pouco mais tranquilo para analisar. Mas o cálcio nesses grupos tem se mostrado sistematicamente um marcador de risco, e alguns autores dizem até que quem tem mais de 40 anos deveria ter pelo menos uma estratificação de cálcio, enquanto ela for zero, para acompanhar e ver quando a aterosclerose surge. O que eu acho interessante é olhar alguns trabalhos que tentam situar o cálcio, então, resumir um pouco tudo que a gente falou até agora. Primeiro é isso. Esse estudo publicado em 2019 mostrou que, de novo, confirmou aquela expectativa inicial que o cálcio traz surpresas, ou seja, vejam, ele pode estar presente em quem tem nenhum fator de risco, pode estar ausente em quem tem múltiplos fatores de risco. Então, ele continua tendo impacto prático. Segundo, continua tendo impacto prático porque ele mostra quem vai morrer mais. E terceiro, mostra quem vai morrer mais de doença cardíaca. Vejam que nos grupos que tinham cálcio zero, claro, como eu disse, somos seres humanos, e seres humanos morrem. Mas a quantidade de morte cardíaca, aqui marcada nessa cor meio cobre, meio laranja, foi muito maior do que nos pacientes que tinham cálcio mais elevado. E como eu já mostrei, isso pode estar associado ao cálcio também a outras comorbidades, a outros fatores, a outras doenças, e isso pode mostrar por que também essa taxa não é pequena. Mas a mortalidade cardiovascular é muito mais expressiva nesses indivíduos que têm cálcio elevado. Então, o cálcio identifica pacientes em risco, prevê a maior chance de complicações. Outra pergunta que sobra até esse trabalho é: serve para indicar tratamento farmacológico? Então, parece que sim. Já de novo, indo para o passado, alguns estudos que mostravam que o score previa eventos diziam, olha, não só ele está presente em quem não tem fator de risco, como ele pode estar presente em gente que, segundo as diretrizes à época vigentes, não teria indicação para iniciar farmacoterapia. Então, a ideia aí é olhar para o cálcio como um guia para escolher quem não precisa ser tratado de uma maneira mais agressiva e quem precisa, para nos ajudar a tomar a decisão correta. Um dos estudos que foi mais, dos primeiros estudos nesse sentido, um estudo não tão expressivo assim, foi publicado na Mayo Clinic, da própria Mayo Clinic, em 2013, pegou 849 pacientes assintomáticos e risco pré-teste intermediário, teve 4% de eventos adversos, mas viu que o tratamento intensivo no grupo que tinha cálcio elevado reduzia eventos. Então, já foi o primeiro direcionamento. Mais para frente, o pessoal já tenta até associar a aspirina. Todo mundo sabe que o debate da aspirina, as últimas diretrizes americanas colocaram o uso de aspirina bem em xeque, mas alguns viram ali, vamos ver se o cálcio seleciona quem tem que tomar aspirina também. Eles viram uma coisa interessante, talvez nos pacientes que têm um baixo risco de sangramento, esses gráficos aqui à direita, não vou mostrar tudo, mas esses gráficos aqui à direita tinham baixo risco de sangramento, tiveram mais eventos adversos cardiovasculares quando tinham um cálcio elevado. Então, vale a pena tratar, quem sabe, esse pessoal, até colocar aspirina, mas quem tinha mais risco mais alto, aí a aspirina realmente superou os prejuízos da aspirina, superaram qualquer potencial benefício que ela pudesse ter. Então, um cálcio muito elevado, talvez mereça até isso, mas seguramente apenas em quem tem risco hemorrágico não tão alto. O que parece que o cálcio faz, a identificação do cálcio faz, é permitir colocar a estatina nesse menu de coisas que incluem situação de estilo de vida saudável, exercício, frutas, muita água, enfim, todas aquelas coisas que nós sabemos que as pessoas têm que fazer. E aí surgem trabalhos mais interessantes, como esse publicado em 2018, que viu que tratando pacientes segundo o score de cálcio melhorava. Olha que interessante. Quando os pacientes não tinham cálcio, que é esse gráfico superior à esquerda, não teve nenhuma diferença entre usar ou não estatina. Quando o cálcio era mais alto, acima de 100, essa diferença aparecia. Aparecia mais nesse grupo, olha que interessante, que tinha cálcio entre 100 e 400, que até do que quem tinha cálcio acima de 400. E não foi significativo em quem tinha cálcio acima de 100. Então, nesse grupo, usar a estatina em quem tinha cálcio elevado reduziu eventos. Só no grupo que tinha cálcio elevado. E talvez não seja apenas ter ou não ter cálcio, uma vez que nós vimos o impacto que foi limítrofe nos casos entre 0 e 100. Então, apesar de todas as suas limitações, ele parece nos ajudar. O estudo de St. Francis foi mais uma contribuição nessa direção, em mostrar que havia redução de eventos, principalmente quem tinha cálcio elevado, e não quem não tinha cálcio. Nesses casos, a estatina reduz desfechos em quem tem cálcio elevado, mesmo que não existam outros fatores de risco. Isso é importante, ele modifica a nossa expectativa clínica. Como que a estatina age? Em parte, a gente sabe que ela age passivando a placa, não vou entrar nos mecanismos, todos conhecem melhor do que eu, mas lembro que ela vai aumentar o grau de calcificação da placa. Isso é uma unanimidade. Mas aqui também vem a história de por que o cálcio não é bom para fazer o acompanhamento do paciente depois que começa a tratá-lo. uma vez que ele aumenta a calcificação da placa, sim, isso ninguém, melhor, não existem vozes discordantes no momento, mas o que nós não sabemos é com o impacto do cálcio, perdão, o impacto da estatina no cálcio total. Existe até quem, como esse trabalho publicado na Aterosclerose de 2018, mostra que quanto mais cálcio na placa, menor a chance de síndrome coronária aguda, mas quanto mais cálcio global, maior seria a chance de síndrome coronária aguda. Um aparente paradoxo. Mas se nós lembrarmos que aumentando a calcificação da placa, pela própria forma de adquirir a imagem, esse cálcio vai borrar mais, é meio natural inferir que ele possa aumentar em quem está usando estatina. E, na verdade, é hora de ter calma e olhar com isso com muita cautela. Porque à medida que o tempo passa e a gente vai acompanhar a distribuição do cálcio, a gente vê como artigos mais antigos mostravam que, olha, talvez quem receba cálcio, quem recebe estatina, tenha um aumento do índice de calcificação global. Isso pode acontecer. Então, é um bom exame para iniciar, para decidir sobre quem vai tratar, mas não é um bom exame para acompanhar esses pacientes. Para separar um pouco do mito e realidade, que hoje está tão na moda falar de fake news, para separar um pouco disso, eu trago essa revisão de 2018 também, que mostra um outro aspecto interessante, mostra um pouco de onde nós que trabalhamos com imagem na prática clínica queremos chegar. São imagens muito mais refinadas, feitas em condições pós-mortem, enfim, não é exatamente a condição que nós trabalhamos no dia a dia, mas que mostra que não é simplesmente ter ou não cálcio, mas quem sabe a morfologia do cálcio, obtida em condições ideais, que nós não conseguimos ainda fazer na prática, possa refletir estados diferentes da aterosclerose. Então, aquele cálcio que é mais espiculado pode estar associado com erosões, o cálcio espiculado pode também estar associado com os ateromas de capa fina. Quando existe fragmentação, pode ser que nós estejamos falando de casos de placa rota. Quando existe calcificação difusa, nós podemos ter falado de rupturas que cicatrizaram, e quando ele é difuso, mas mais difuso, mais grosseiro, nós podemos estar falando de placas fibrocalcificadas. Ou seja, não é apenas a quantidade de cálcio que importa. E, na verdade, existem algumas coisas interessantes. Vamos prestar atenção pelo tempo só nesse gráfico do meio. Vejam que, à medida que vai aumentando o score de cálcio, aumenta a possibilidade de eu ter placas mais graves. Mas quando eu chego em placas extremas, essa curva começa a mudar um pouquinho. Então, talvez a quantidade de cálcio indique, e se eu conseguisse ter imagens tão refinadas, por isso que disse, é um sonho de quem faz imagem, chegar um dia nessas imagens na prática clínica, eu talvez possa conseguir refletir o fenômeno que acontece naquela aterosclerose. Mas, no momento, isso ainda não é possível. Existe essa associação entre diferentes padrões de cálcio com diferentes fenômenos, mas existe, como essa área aqui embaixo mostra, uma área de sobreposição, uma zona de sobreposição, e eu não consigo ainda dizer que tal fenômeno está associado com tal tipo de placa. As minhas penúltimas conclusões, que eu tenho as últimas um pouquinho mais para frente, não muito, Miguel, só um pouquinho mais para frente, é que é um bom exame para refinar a estratificação de risco, seleciona melhor quem vai se beneficiar do tratamento clínico, que é melhor em pacientes mais jovens, mas como eu mostrei, pode ser bom em qualquer idade, e tem impacto clínico, mas hoje em dia não pode ser indicado para acompanhamento. Tem um pouquinho mais. Uma coisa que ainda é um pouco discutida, mas parece que é verdade, é o paciente ter informação sobre a presença de calcificação nas suas artérias, aumenta o susto dele com a presença de aterosclerose, e existe uma melhor aderência ao tratamento. Isso, inclusive, no hub lá do nosso American College, foi mencionado, isso é um dos efeitos colaterais benéficos que saber o score de cálcio tem. E, por outro lado, eu gostaria de lembrar que o cálcio reflete a carga aterosclerótica total. Isso que é uma coisa tão importante que nós estamos vendo ser cada vez mais discutida. A placa aterosclerótica total, ela é um dos principais marcadores de evolução que se conhece, e o cálcio reflete. Reflete por quê? Nós vamos um pouquinho mais para frente, mas vejam que nesses gráficos nós vamos vendo que quando tem muito cálcio, quando tem muita extensão de doença, não faz diferença eu ter ou não ter placas que sejam significativas. Faz diferença, sim, eu ter muitas placas. Então, quer dizer que se eu tiver uma placa obstrutiva, ou se eu tiver uma doença não obstrutiva, mas muito extensa, eu estou em risco do mesmo jeito. Isso quer dizer que a estenose não é importante? Não. A estenose é importante. O grau de estenose ainda é uma das coisas que a gente leva em consideração. Mas a carga aterosclerótica total é mais importante. E isso ficou claro até de estudos como isquímia, onde foi muito valorizado na própria publicação do estudo principal, E até do PROMIS, que disse lá que os exames funcionais e anatômicos eram mais ou menos parecidos, mas desse estudo ficou bem claro, se a carga de placa total é alta, esses pacientes têm que ser tratados, porque a ausência de isquemia, lembra da tese, lá em 2013, do Rafael William, que eu mostrei, a ausência de isquemia não exclui a possibilidade de eventos adversos que aconteceram em 16% dos pacientes, por exemplo, do isquemia, e aconteceu em quase 20% dos pacientes do PROMIS que não tinham isquemia, mas tinham carga aterosclerótica elevada, eles tiveram uma evolução desfavorável. Então, isso dá um papel central, conflito de interesse à parte, para a tomografia. O último aspecto que eu queria lembrar é que o cálcio não faz diagnóstico de estenose. Nós podemos, diante da presença de sintomas, ter falso negativo do cálcio, está mais ou menos 16% a 20%. O cálcio serve sim para fazer diagnóstico de aterose subclínica e orientar o uso de tratamento em indivíduos assintomáticos. Diagnóstico de estenose, ou a gente faz invasivo pela cine, ou faz não invasivo pela tomografia, onde nós podemos encontrar casos como esse, onde a marquinha branca aqui está apontando uma placa não calcificada. Então, se eu quiser ter uma ideia mais precisa da carga aterosclerótica total, a tomografia com contraste vai me dar. Em quem eu vou ter isso? Não sei. Eu sei que pela ateromatose a gente consegue ter mais informações dela pela tomografia, mas que com certeza ajuda nos casos sintomáticos, pois nós temos acompanhado as últimas evoluções, mas eu não sei quando o paciente assintomático, não sei se o paciente assintomático um dia vai se beneficiar do exame contrastado ou não. O que eu sei é que seja pelo cálcio ou pela tomografia, se eu encontro placas, eu estou diante de um paciente vulnerável e eu preciso agir como médico para mudar a história natural. O que me leva às conclusões, agora sim as últimas mensagens final, de que o cálcio é um marcador de risco relevante e que a ausência de aterosclerose pela tomografia indica um bom prognóstico. A presença de placa, por outro lado, indica eventos adversos. A carga aterosclerótica total é mais importante, nós vamos ter que rapidinho uniformizar índices que possam ser compartilhados na prática. E placas com características adversas e maior velocidade de progressão podem ter relevância, mas a gente não sabe exatamente em quando o paciente assintomático vai se beneficiar ir além do cálcio, se é que isso um dia vai acontecer. E no momento o cálcio não pode ser indicado para o acompanhamento dos pacientes. Queria mais uma vez agradecer muito o privilégio de poder fazer parte desse grupo de colegas de primeira e desejar um bom final de semana a todos.
Obrigado, doutor Ebrahim. Muito didática a sua aula, ilustrando aqui as armas diagnósticas que a gente tem em cardiologia para a detecção da aterosclerose subclínica. A sua aula aqui foi muito elogiada aqui no YouTube, pegando a carona do Evandro Cesarino aqui, que tem uma questão a respeito de opções diagnósticas em aterosclerose subclínica. Qual que é o exame mais custo-efetivo? A tomografia coronária para detecção de cálcio, a angiotomografia coronária, a ultrassom Doppler de carótidas ou o ultrassom de abdômen, que eventualmente vai ver algumas plaquinhas na aorta. Isso, logicamente, levando em conta muitas das nossas limitações em solicitar esses exames, principalmente a tomografia coronária, devido a questões de custo e questões, obviamente, de coberturas de seguradoras, né?
Uhum. Eu vou procurar, a pergunta é ótima, Marcelo, eu vou procurar ser bem objetivo na resposta. Quando a gente fala de ultrassom de carótidas, a gente fazer uma distinção. O ultrassom de carótidas que vale, que traz valor, que o Valentin Fuster usa no dia a dia, é o ultrassom 3D. A espessura média intimal, essa traz muito equívocos e a gente não tem muito benefício de usar isso na prática clínica. Qual é melhor, o ultrassom de carótidas ou o score de cálcio? Ainda existe um pouco de discussão, os trabalhos não são uniformes, existem alguns que apontam que o ultrassom de carótidas seria melhor para prever eventos adversos cerebrovasculares e o score de cálcio mais para o coração, mas nós ainda estamos tateando. Então, por uma questão de custo e disponibilidade, não tem dúvidas, o ultrassom acaba sendo mais utilizado. O ultrassom de abdômen e de outras partes do corpo, mostrando cálcio, já mostra que é um indivíduo de risco e que a gente precisa ter atenção com ele, mas ainda não tem estudo comparativo, nem com ultrassom de carótidas, nem com score de cálcio, para a gente ter certeza de que isso vai trazer alguma modificação, tratar esses pacientes vai trazer modificação mais para frente. E, finalmente, em relação à tomografia e o score de cálcio, tomografia em contraste e o score de cálcio, eu acho que são duas ferramentas diferentes. Eu acho que o score de cálcio, ele é para o assintomático. Eu tenho certeza de que eu posso usar no paciente que tem risco para teste intermediário, intermediário baixo, enquanto que o paciente que tem sintomas merece uma angiotomografia. Eu ainda não tenho dados que me beneficiem. Eu até gostaria, porque eu me sinto mais seguro quando eu vejo uma angiotomo e vejo placa não calcificada, calcificada. Eu consigo ver naquelas placas que tem os dois componentes, se é um cálcio mais central ou mais periférico, que também tem repercussão, mas eu ainda não tenho dados para justificar que isso possa me fazer escolher um exame em relação ao outro, perdão, isso possa me levar a fazer tomografia para o assintomático no momento.
Obrigado, Ibrahim. Pela pouco tempo que a gente tem outras perguntas aqui da audiência, eles depois podem mandar para você por e-mail.
E a gente responde com o maior prazer.
Obrigado. Eu vou ter que seguir aqui com a sessão, pela eximidade de tempo, com o professor Francisco Laurindo, que vai nos brindar aqui com a próxima palestra. Pode descompartilhar, por favor, a sua tela, Ibrahim. Obrigado.
Okay, good afternoon. It's a great pleasure for me to be here and to discuss some aspects of vascular biology and risk factors. I hope I can share with you my screen. Let's see. Now, can we share? Can you see me? Can you see the screen or?
Not yet.
Okay, let me do the trick here. Now? Not yet. Not yet?
Not yet.
Sorry. Okay, you have to share the screen. No. Oh my.
Are you using Google Chrome?
Yes, they are asking me to.
Okay.
They're asking me to sign it. Sorry. Let's see. Oh, Can you see it now or not yet?
Not yet.
No.
I don't know if you can send your file to Miguel, then he can.
Yeah, I think I'll do that because I can perfectly see you, but the whole thing is not coming. They ask. Let's see. No, yeah, it's still asking for. You have access to me. Sorry. How do I send it to you? Can I send with email to Miguel?
Yes, please.
I don't have his email, sorry.
Meanwhile, perhaps we can discuss.
I send it to you, Marcel. Maybe I send it to you, and then you. Sorry for that.
Meanwhile, if there is any other questions from the previous speakers or comments that we can do it now. Se tiver alguma pergunta, se tiver alguma pergunta em relação aos palestrantes ou às aulas prévias, a gente pode complementar agora.
Ok. Hi, Marcel.
Olá, Carlos.
Tudo bem? Eu vejo que meus outros dois colegas aí estão junto aí do colóquio, o Fernando e o Márcio. Então, só agradecer o convite aí da comissão organizadora e eu não sei se posso fazer uma pergunta para a Dr. Cynthia. Is she still online?
Yes, she is online. Please, Miguel, can you bring her in? Yeah. Yeah, she's online.
Okay, there I am. Can you hear me?
Yes. Hi, Cynthia.
Hi.
My name is Carlos Serrano. I'm here from the INCOR Art Institute in Sao Paulo, and it was a great pleasure watching your presentation. It was a lot of new data that you revealed, and it's very interesting for us to see what's really going on in this field. And I have one quick question for you. It's mostly for personal curiosity. If the similarities between the calcific aortic valve disease and medial artery calcification, if you see anything going on this mechanistic pathways different on these two diseases, and mainly if there's differentiation between cells, mesenchymal stem cells and smooth muscle cells to osteoblasts, if there are any studies going on this area.
Yeah, well, my lab is doing some studies like that. So one of the, I started with medial calcification, from this rare disease, but we were interested in seeing is CD73 different in valve cells, and I think someone actually beat us to it. I think they tried to look, and it didn't seem that this mechanism of CD73 deficiency is operative in valve. Calcific aortic valve disease. But what is very similar is this osteogenic transition. So in valve, similar to vessel, there's kind of like the two forms. There's ectopic calcification that happens from the precipitation of just too much mineral. So if, a good example is like the MGP knockout mouse. If you don't have means to clear the mineral from the extracellular milieu, then it will precipitate. The other kind is the ectopic calcification that comes more similar to, osteoblasts laying down the calcification itself. And what is similar, at least in our studies, when we use valve interstitial cells. We're not looking at the valve endothelial cells yet, but they are undergoing a similar kind of time course in terms of how they are calcifying. And we haven't published it yet, but we have a grant on it. One of the things that we found with valve cells is we were looking to see kind of this question you asked about the role of like a mesenchymal stem cell like transition, and we had this idea that perhaps you have a control cell that de-differentiates to a stem-like cell that then goes on to osteogenic pathways, and we were looking at that as a function of age. We thought maybe senescence would have to do with that, so we started to look at telomeres, but we found the telomeres weren't changed at all. However, TERT itself has non-canonical effects where it is helping to program by co-factoring with binding with transcription factors as cofactors to drive osteogenic gene expression. So it seems that while the flow from control to calcifying cell is similar, the absolute mechanisms are slightly different. But one thing that we have seen in our valve cells is that this FOXO1 inhibitor is also able to prevent calcification. So there's some connection there, but there's a different driver because at least on the CD73 level, it seems to be different. So I don't have a clean answer for you, but
Oh, okay.
No, thank you.
Thank you very much for your comments. And now Dr. Laurindo will start his lecture, and then we can discuss it further.
To me and see the screen.
Yes.
Okay. Sorry for that. So thank you again for the invitation, and it's a pleasure to discuss. Of course, the title is very broad, but I'll focus on the question of whether cardiovascular risk factors that we all know lead to vascular disease phenotypes through several mechanisms. So the question is how this happens, and we all know several biological processes that act as mediators of these vascular disease phenotypes. For example, vascular cell metabolism, inflammation, signaling. We saw a lot of this. The metabolic state of the inflammatory cell itself is very important. The interaction with gut microbiota, endothelial dysfunction, vascular smooth muscle cell phenotype changes, recapitulation of developmental programs, cell proliferation, migration, survival, death, autophagy, senescence, microparticle deployment and interaction, extracellular matrix secretion and interaction, and mechanosensing and mechanoadaptation. So we have a host of processes, but still the question is, are there processes that orchestrate these mechanisms? Our group has been working with the possibility that oxidative stress, lato sensu, is involved in many of these processes, and this is what we would like to discuss today. We all know that antioxidant supplementation does not work against most vascular diseases, and so it seems kind of strange that I think that oxidative stress mediates all those processes. Actually, those processes are quite complex, so maybe one bullet will not be able to attack all these mechanisms. So that's why antioxidant supplementation may not work as we expected. In addition, some oxidants exert physiological signaling or are even beneficial. For example, exercise, insulin resistance is decreased by oxidative stress. There are several pro-oxidants that are beneficial, so we should not assume that oxidative stress is necessarily bad. And this brings us to the third problem, which is the overall model of oxidative stress we have in our minds. That is, oxidative stress is bad and reduction, everything that brings reduction is good. This is wrong. And that prompted many people to come back to the bench to work more on mechanisms of oxidative stress. That's what we have done over several years. And we focus mainly on how oxidative stress affects its targets and receptors in proteins. So the proteins are not modified by oxidants by accident. They are purposefully made to be responsive to those oxidants physiologically, and the disequilibrium in this process is what causes disease. Basically, there are two main redox receptors in proteins. One is the family of redox active metals, so the metal proteins, and the other, which is the one we'll focus, is the family of cysteine thiols, which brought many small compounds and the number of thiol proteins. One protein that is a kind of professional thiol protein that we have focused over several years belongs to the family of protein disulfide isomerase and is actually the prototype of this family, which I will call from now on PDI, but actually is the isoform A1, PDI A1. There are 20-something PDIs. PDI belongs to the thyrodoxine superfamily, which means it has two motifs of cysteines in its arms, in its active arms, having an X linker that's highly mobile, so the protein can actually open and close in over several substrates and modify their cysteine states. So it's a kind of direct modification of titles. PDI is normally resident on the endoplasmic reticulum, although our group is now working on other PDI pools at the cell surface, and we also believe there is a pool in the cytosol as well. What is important in PDI is that it is the main catalyst for disulfide bond introduction in nascent proteins in the ER. As you all know, disulfide bonds in proteins are very, very important. So the classical protein PDI effects are protein folding and disulfide introduction in the ER, protein homeostasis, which we call proteostasis, and also it promotes cytosolic translocation of proteins for proteasome degradation. It protects against endoplasmic reticulum stress. It is involved in cell survival, mainly because of these effects. And the cell surface and extracellular PDI pool is very important, and it's one of the most important new targets for thrombosis and platelet aggregation. But it's also involved in virus internalization. For example, the dengue virus, the Zika virus require PDI to get into the cell. And it's also involved in cell adhesion. The novel type of effects that we have been describing over the years, and here are several reviews that we have written, you can look at that, relate to the regulation of NOx and EDPH oxidases, which are the main source of oxidants in the cells, like superoxide or hydrogen peroxide. So PDI is required for the angiotensin II response of NOx and EDPH oxidase. But we are also discovering that PDI has a major role in cytoskeletal organization. It's involved in cell migration and vascular remodeling as well. I don't have time to go into all of these effects. I will show only one example in which the cell surface pool of PDI supports the polarized organization of cell adhesion forces. So this is a traction force microscopy image. So the heat map shows how the force that the cells exert in the extracellular matrix. And you can see here the main vector is in this direction for the force. So the cell is gripping here, should go into the upper left corner. And when you incubate the cell with a neutralizing PDI antibody, so you are knocking down the cell surface PDI pool, the cell loses the polarization and decreases the vector length ratio and the net contractile moment, indicating that the PDIs, the cell surface PDI pool, is very much involved in fine regulation of cell distribution forces. Indeed, when you neutralize this pool, the cells lose the persistence of migration in collagen, indicating that they're still able to migrate, but they become kind of drunk. They lose the capacity to keep a straight line clearly without noise. So the cell surface PDI pool is involved in decreasing the noise, mainly through cytoskeletal effects, and we are also investigating effects on integrins. So this is just one example of what this PDI pool can do in terms of redox regulation and cell effects. To further analyze the translational implications of PDI, we built a transgenic PDI overexpressing mice. It's a very simple model. PDI is ubiquitously and constitutively overexpressed. Why overexpression and not knockout? Because PDI knockouts are lethal. So we switched to the overexpression strategy. And what we saw is a very mild phenotype. So these mice develop normally. They eat well, they breathe fine, they don't have a clear weight gain or loss. But we saw some minor but interesting changes in vessels. So you can see here in the aorta a mild disorganization of elastic fibers. Here's a quantitation of this, which we attribute to probably an increased contractile tone of these vessels. Indeed, the most interesting finding, and we have a lot of in vitro studies to support this, the transgenic PDI overexpressing mice exhibit at least a few markers of smooth muscle cell differentiation, such as calcitonin. So those smooth muscle cells are somewhat over-differentiated. And in terms of NOx and ATPase oxidase, sorry, I don't have time to go into detail, but the NOx1 isoform is the isoform that is involved in proliferative and migration responses, and thus is decreased, while NOx4 is involved in differentiation and it's increased. And that is in the baseline situation of those transgenic PDI mice. So these mice are somehow hyper-differentiated in their smooth muscle cells. And because of this and the effects of ER stress also, we asked whether PDI could protect against vascular calcification, because both ER stress and the phenotype of the mouse can be involved in the evolution of vascular calcification. So it's we did a very simple study in which we, conceptually simple and operationally complicated, in which we infuse vitamin D in the mice, and here you can see the development of calcification with the bone tag marker also. And in the transgenic PDI mouse, indeed, had significant attenuation of this calcification, suggesting that the overexpression of PDI indeed decreases the calcium deposition into these arteries. And an interesting feature of this mouse model was that the outward remodeling was also extremely affected by the overexpression of PDI. So here's the vitamin D. You can see the whole caliber of the artery is increased by vitamin D, but this was significantly minimized in the transgenic PDI animal. So the total vessel wall area increased by vitamin D was prevented in transgenic PDI mouse, similarly to the total vessel area and the lumen area as well. So there is a very significant correlation between total vessel area and calcification area. So I actually invite my colleague Ibrahim, who made the previous presentation, to do the same in patients. So is the total calcification area correlated with expensive remodeling? That would be an interesting thing to do. In addition, we have several experiments I don't have time to show. We thought that we should investigate more in depth some features of these vessels, such as apoptosis, elastic fiber rupture, and collagen accumulation. Here, you see that collagen, elastic fibers were disrupted, and collagen was increased with vitamin D, and this increase was significantly prevented in transgenic PDI mice, while apoptosis was also increased in the wild type with vitamin D, but prevented in transgenic PDI mice. So the presence of an excess PDI protects against calcification development, apoptosis, elastic fiber rupture, collagen accumulation, and thus is reflected also in decreased expensive remodeling. We saw a fantastic presentation by Dr. St. Tyler about the mechanisms of calcification. And obviously, we are all willing to understand what are possible mechanisms of PDI protection against vascular calcification. This is still work in progress. We are trying to think about these mechanisms, and we have three possibilities at this time. The first one is the phenotype itself. So we start from a mouse that has an increased calponin expression. So an increased differentiation of vascular smooth muscle. So maybe that affords a kind of advantage to these mice. And at least some aspects, not this protein SN22, which is a marker of vascular differentiation. So it's lost during vitamin D. That's expected because during calcification, the smooth muscle cells de-differentiate. This is not affected in our transgenic mouse, but the calponin loss, which is indicates PSMC de-differentiation, is significantly attenuated in our transgenic PDI mouse, suggesting that at least partially the loss of vascular contractile phenotype during calcification is affected by the overexpression of PDI, and indeed we can show that some markers of the osteochondrogenic phenotype, like MSX2 and Osterix, are significantly less expressed in the transgenic PDI mice exposed to vitamin D here and here. So thus, differentiation is one of the first mechanisms. One additional mechanism that we are that we looked for was the alkaline phosphatase activity, and to our surprise, the transgenic PDI mouse has a significantly decreased alkaline phosphatase, total alkaline phosphatase activity. We don't know to explain this at this time, which was mildly reversed by vitamin D administration, and this is still an open story. Maybe we would love to listen to some ideas about that. And the second mechanism is the presence of endoplasmic reticulum stress. We all know from the work, in part by work from Marcel, while his postdoc at Harvard, he showed that ER stress contributes to vascular calcification, and after vitamin D administration, you can see that there is increased expression of this endoplasmic reticulum stress marker, GRP78, and this is attenuated in transgenic PDI mice. But our PET mechanism, which we are still working on that's the third mechanism, is a redox mechanism at the endoplasmic reticulum. This sounds kind of complicated, but it's not too complicated. One of the most important molecules involved in vascular calcification is vitamin K. We all know that warfarin enhances, which inhibits vitamin K oxide reductase enzymes, enhance vascular calcification. And what happens is that the active form of vitamin K is the vitamin K hydroquinone, which is the reduced form of vitamin K. Vitamin K is oxidized to vitamin K epoxide through the action of gamma-glutamyl carboxylase, which carboxylates several targets, including NGP, which decreases the carboxylation of NGP, decreases vascular calcification. What's interesting is that VKOR is reduced by PDI, and in this process, VKOR oxidizes PDI, and that contributes to protein folding in the ER. So vitamin K oxide reductase is a known factor contributing to protein folding in the endoplasmic reticulum through the oxidation of PDI, which then introduces the disulfide nascent protein. So kind of VKOR rearms PDI to introduce get disulfides into nascent proteins. And at the same time, PDI reduces vitamin K to render it active. So we are very enthusiastic about this mechanism, but unfortunately we still don't have much data about that. But what is interesting is to show that vitamin K, as a proof of concept, is able to decrease the vascular calcification in the wild type and here, but while in the PDI transgenic you have decreased calcification, which is not further affected by vitamin K. So this is remains as a possibility, and it's a possible mechanism of the effects of transgenic PDI. So to wrap it up, I would change the name of oxidative stress to disrupted redox signaling, because what actually we need to do to understand these effects is an improved knowledge of redox signaling mechanisms in normal and pathological conditions, which will explain to us novel pathways that are prone to modulation by therapeutic compounds. PDI is just one example. I don't believe that PDI itself will become a therapeutic target, but certainly it will teach us many important relevant pathways that by themselves can become significant therapeutic targets. This is just to mention the important collaboration of Marcel and Luciana Pescatore, the postdoc, and he does calcification work, and this is all our group, and I thank you for your attention.
Thank you, Francisco, for your presentation. I will invite everyone from the other speakers that will talk in order to discuss this session. And I don't know if Ibrahim is there. Yeah. So, Ibrahim, answering Dr. Laurindo's question about positive remodeling in calcified coronary arteries, what's your experiencing about it, or what's your what do you if you have performed any measures about that?
The mic was muted. Sorry, apologize. That's a good question and a difficult one. It's a difficult point to see from calcium score alone. I would say that from calcium score alone, it's impossible for you to tell if there is positive remodeling or not. What I think that is a little bit more useful at the moment is for if you have standard angio CT, then if the lesion is not very heavily calcified, you could actually identify positive remodeling. Like I said during my presentation, if you have very heavily arteries or plaques, then the image gets kind of blurred, and you can misidentify the actual borders. What I have seen a few times actually is people saying that plaques had positive remodeling, while what they actually had was blur from heavily calcified calcific deposits in those lesions. So I would say that if you're lucky and the image is good and you're doing angio CT, then you can say that there is calcific, that the lesion has calcium, but also positive remodeling. If a lesion is non-calcifying, that's actually easy to tell. And but if you have no contrast, it's actually impossible to say if there is positive remodeling or not.
I have a question for Francisco. It was a great talk, really, really interesting data, and I particularly liked the fact that the, your elastin imaging on the vessels, it's reminiscent to what we see in ACDC. And one of the first questions I had when we looked at the pathology of the patient was, well, obviously there's a very large chunk of calcification, but then on the opposite side, the internal elastic lamina is nice and ribbon-like, but then it breaks, and that's where calcification starts. And we have this idea, which is the chicken and the egg kind of question. Is calcification happening first and damaging the elastic lamina and the matrix, or is the matrix breaking down and then allowing calcification to precipitate? And I mean, I don't think we're at that. We don't have that answer yet, but I thought it was really encouraging that your results really mirrored what we're seeing too in that sense. And I'm also wondering, what are the known substrate, either substrates or targets of PDI? I mean, obviously vitamin K is downstream of it, but are there other known proteins or things, whether it's in extracellular matrix remodeling or osteogenic proteins themselves that are known to be PDI targets?
Thanks for the question, Cynthia. And, yeah, these are great questions. I always think which is the chicken and the egg, and we have discussed with Marcel and Luciana, the internal elastic lamina breaks. It could be maybe a mechanical effect, even from the large calcium deposits, or maybe a protease activation, but we truly don't know. We have seen in some other studies possible association between PDI being protective against aortic dissection, mediated by lysyl oxidase inhibition. So it might be the case that there is some targeting of the elastic fibers directly by PDI, but I think there's a long story to go, because we don't know if the effects are mediated by PDI, by the integrins which PDI reduce or oxidize, or by ER stress. Coming to the second question, the proteins that are associated with calcification, I mean, there are tons of proteins that are modified by PDI because it's a very promiscuous enzyme in the ER. So all the matrix proteins are likely to be modified by PDI, like collagen is well known, actually. PDI heterodimerizes with prolyl 4 hydroxylase, so it's required, actually. PDI is almost required for the collagen synthesis through this mechanism. But also it's involved in many other enzymes, and also locally at the extracellular surface, PDI is very important to redox modify the matrix proteins, and especially through the integrins, but also probably directly. One example has been described in literature is collagen, of course, again, but also additional molecules like fibrinogen have also been described. It's another target of PDI. And with respect to enzymes of the calcification pathway, we searched for them, but we are not yet too confident with the substrates, because then the data get more difficult to analyze. But we came to the vitamin K oxidase reductase, which I think it's a possibility, really, definitely a possibility. Yeah. Thanks for the question.
Thank you. Minami, Cezena, do you have any questions for, or Carlos, do you have any questions for the other speakers?
Yeah, yes, I actually have a question. First of all, I would like to thank the Department of Atherosclerosis for inviting me to participate in this conference. And congratulations to the speakers for the excellent talks. And I have a question to Francisco and Cynthia regarding the pathophysiology of these two types of vascular calcification. As Cynthia said, we have two main types of vascular calcification, the atherosclerotic intimal calcification and the medial calcification. And we know that some conditions like chronic disease can contribute to increasing this both type of calcification, of vascular calcification. And I think if there are some kind of interposition in the pathophysiology of these two types of vascular calcification, and if you think there is some kind of difference regarding the cardiovascular risk between these two types of calcification.
Cynthia, you can start. Thank you.
Pathophysiology, the differences between intimal versus medial calcification at base. Yeah, well, it's very clear that there are a Venn diagram where there's a bit different and a bit the same in both of them. And I think in terms of medial calcification, what we're not seeing a lot of is inflammation. And you do see a lot of inflammation in the atherosclerotic plaque. So in terms of the progression of the plaque and then when the calcification happens, if you don't have the inflammation and then the necrotic core and that all that apoptosis and kind of, you know, very inflammatory substances, you really don't get the calcification. Medial calcification, though, especially when you're looking at peripheral artery disease that is not associated with atherosclerotic plaques in the periphery, the vessels we looked at have very little inflammation at all. And so while I think the pathways converge on the upregulation of osteogenic transcriptional programs, I think the drivers are different. I think in an athero plaque, you're going to get more of an inflammatory driver versus a medial calcification plaque, like Francisco alluded to. I think there's more a biomechanical influence, a stress or a fiber breakdown influence. So I think those are the main differences in the initial pathogenic stress.
Thank you.
Yeah, perhaps I would add that not all calcifications, I think that the pattern of calcification that our colleague Ibrahim alluded to is probably important, because we see that some circumstances that apparently are beneficial, like statins, and as Dr. Protasio recently showed, wine consumption, they increase the amount of vascular calcification. So there are some, I would not call good calcifications, but at least calcifications that are not associated with a bad evolution.
Any further questions for this session?
Hi, may I have a question to Dr. Ibrahim? First of all, thank you very much for the invitation. Congratulations. Thank you all the presenters. I would like to ask Dr. Ibrahim. First of all, I would like to say that I like very much coronary calcium, but I understand that we have to separate populational studies and the clinical practice. I mean, I do believe that calcium zero is associated with very low risk, but sometimes it's different when you have a patient in front of you. So I have patients, for instance, that had myocardial infarction with zero calcium. A lot of people talk about that. So the question is, can we really trust calcium zero in the clinical practice? I mean, in your practice, do you see calcium zero with extensive atherosclerosis or high-risk plaque, or do you think that these cases that the patient has a plaque but zero calcium, these cases, the atherosclerosis is very mild and nothing will happen? Can you elaborate something about that?
Só o microfone.
Once again. That's a wonderful question. Thanks for asking that, because I think this is a very important point that many times we do not address properly in the talks. And I feel much more comfortable when the calcium score is not 0. Then it gives me information that I should treat a patient. First of all, what patients do I think really benefit from that? Well, apart from scores or anything, it's kind of something that comes from clinical practice. That patient, you're not really sure whether you should start statins or not, whether you should be more aggressive with the treatment or not. Then the calcium score, if it comes higher than 0, it helps you and says, well, I should go ahead and treat this guy. He will benefit from that. As from the zero calcium score, I believe it pretty much falls in the same category that having a heavily calcified plaque tells me that the patient is stable. I think this is not quite true. I have seen a few cases in my life where people with calcium score of 0, absolutely 0, in a couple of years would develop acute myocardial infarction or have unstable angina or would have a very quickly progressive plaque. So I think we still have got a lot to learn. And taking from what Cynthia and Francisco were discussing before, and looking at data not from coronary CT, but from coronary OCT, from coronary optical computed tomography, when you have a much, much higher spatial resolution, and you can actually even see, it's the only way you can see in vivo the thin cap atheroma, you can actually tell where the cap is. From that, you have some situations where you cannot identify any calcium whatsoever. So I think that, again, we've got to look at coronary plaques as may be the final result for a number of different mechanisms that will perhaps some use calcium as a way of hurting the artery. Some other paths will come from different directions. So I think it's difficult. That's why I try to stress in my presentation that if you have a high-risk patient, forget about calcium. Calcium may be 0. Do not ask calcium for that guy. I don't think it's going to help you a lot. I don't feel, whenever there is a calcium 0 in a diabetic patient, I call the referral physician up and say, look, be careful. It's 0. I'm pretty comfortable this guy will not have a myocardial infarction in the next couple of weeks, but I wouldn't extend my good expectations for much longer than that. So I think you're right. I think progression is very important. And I think that calcium is one of those things that makes me more comfortable when it's abnormal than when it's normal. I'm sorry if I spoke too much. I got a little bit enthusiastic about that.
Thank you very much. Carlos, can you comment something also about this important clinical issue? The microphone.
Yes. Actually, I have one more question for Cynthia, if it's not any problem for her. In a clinical point of view, I was just kind of thinking if most of these artery calcifications in this manner related to genetic disorders, it looks like it's mostly concentrated on leg arteries, as I understood well. If ABI, ankle brachial index, is that actually being followed for progression, or when you do intervention to treat these calcifications? This would be an interesting way of following these patients?
Yeah, so for the AC/DC trial specifically, we had both, we had a 6-minute walk test, we had the CT calcium score, full body calcium score, but we also have ABI as a metric. So in the original paper in New England Journal, the ABIs are between like 0.1 and 0.3, I believe. Some are very, very, very bad for the patients. Some of them are at risk for amputation, but it's not static. You know, their ABI tends to switch, and that's because I think the calcification itself remodels a bit. You know, it's just a mineral, so it can be dissolved a bit, but it builds back up. At least that's the time course, or what we're seeing as we're following the patients. But in regards to ABI in our clinical trial, part of the group, so like a third of them, no real difference either up or down, but a third of them, it looked like the ABI actually did get a bit worse, and then a third of them also, you know, it got a little bit better. But these groups are each an N of 2 right now, so it's really hard to say, but I think it is a good metric. I think the tricky part is the medial calcification. It's, you know, it's not like once it's there, it doesn't remodel a bit, and that's another thing we don't understand about it, is the dynamics of the calcification itself. And that's probably the same for atherosclerotic plaques. And there's some great studies now that are looking, that Ibrahim alluded to, you know, a large calcification versus microcalcification and what that means for plaque rupture. I think what we do know is that it's dynamic. What we don't know is why or how and what it means.
Okay, thank you very much. Any of you has any further questions? Just because we are on time, I mean, above the time limit.
Can I have a very brief question to Cynthia?
Okay.
We are exploring you today. Do you have any idea why the alkaline phosphatase activity would be so knocked down in our PDI mice? Okay, I mean, it's hard to know, but
yeah, I mean, by speculation, I mean, so I thought it was neat that with the PDI transgenic, the transcription factors were down, the ostrix was down, the other. So to me, that means it's happening upstream of the osteogenic reprogramming. So I was actually wondering, part of my base question is what are the epigenetic imprinting differences between maybe a lower extremity vessel and a coronary, for example. So my thoughts then are, if your PDI is a protein that modifies other proteins, are those other proteins that are helping to drive kind of the base phenotype of a smooth muscle cell impacted by your PDI? Meaning, is it helping to keep that contractile state or helping to suppress kind of a de novo repair mechanism that happens to upregulate TNAP? That's what I could think of, is that it's got to be somehow modifying a modifying protein, if that makes sense.
Yeah, it does. Thank you.
Thank you very much for all of you that gave a brilliant presentation and also comments. And now to finalize our day and morning, which is a little bit late, I will pass to our president, Dr. Chagas, who will finish our spectacular session. Thank you very much.
Thank you very much, Marcel. As president of the Department of the Brazilian Society of Cardiology, I really want to express our gratitude to all our invited speakers, to the members of our Department of Atherosclerosis, to our fantastic audience during this more than 6 hours of presentations and debates. And a special thanks for Fabiana Rached, Marcel Lieberman, and Miguel Moretti for the organization of this superb event. In name of the Department of Atherosclerosis of the Brazilian Society of Cardiology, our gratitude for all the efforts in order to have this morning and part of afternoon fantastic course and new science developments and also knowledge. And I think that the atherosclerotic disease is coming to be more and more understood by all these physicians, all these students, And I think that we will have in a near future different and new courses like this that you had today. Thank you very much, and bye-bye for everybody, and please be safe. Bye-bye.